Good morning. This is Melinda Wharton, Executive Secretary of the Advisory Committee on Immunization Practices. I'm delighted to call this meeting of the committee to order on behalf of Chair Kip Talbot. Can we get the slides up on the monitor, please? I apologize for the delay in getting the meeting started. We've had some technical problems with the webcast. Next slide, please. Copies of the slides are being presented at today's meeting are available or will be available soon on the ACIP website. A few notes on meeting logistics for those who are listening in on the Zoom line. Please keep your line muted until you're called on for discussion. When the meeting is open for discussion, please use the raise hand function in Zoom to virtually raise your hand if you wish to be recognized. During the discussion, questions will be taken first from voting ACIP members and ex officios, and then, as time allows, from liaison representatives. Please keep your video off. A profile picture is fine, but no live video, please. Next slide. The Advisory Committee on Immunization Practices is, at its heart, a public body, and engagement with the public and transparency in our processes are vital to the committee's work. For this meeting, we'll be holding 2 oral public comment periods. The first will occur today at approximately 3:45 p.m. Eastern Time, and the second will occur tomorrow at approximately 2:25 Eastern Time. To create a fair and more efficient process for requesting to make an oral comment, we ask those interested to submit a request online in advance of the meeting. We give priority to advance requests, and if there are more requests than can be accommodated in the allotted time, we select speakers through a blinded lottery. The 14 speakers selected by lottery for this meeting have already been notified. We thank all those who requested an opportunity to make a public comment. Members of the public also had the opportunity to submit written public comments on issues coming to ACIP via regulations.gov. The docket number for today's meeting is ID CDC 2024-0072. More information on the public comment process can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forego participation in certain activities related to vaccines during their tenure on the committee. For certain other activities that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains on all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next slide, please. I am delighted to welcome a number of new ACIP members to the committee who are joining us for the first time at this meeting. The first is Dr. Edwin Asturias, who's Professor of Pediatric Infectious Disease and Epidemiology at the University of Colorado. Dr. Asturias has expertise in global health and infectious diseases, and welcome to the committee. Next slide. Dr. Noel Brewer is Gilling's Distinguished Professor in Public Health at the Gilling School of Global Public Health at the University of North Carolina at Chapel Hill. Dr. Brewer is a behavioral scientist who studies vaccination, tobacco cessation, and other health behaviors. Welcome, Dr. Brewer. Next slide. Dr. Lin Shin is Associate Professor of Medicine at Harvard Medical School. She directs the Travel Medicine Center at Mount Auburn Hospital and is past president of the International Society of Travel Medicine, an organization of worldwide experts on vaccines. Next. Dr. Helen Chu is an infectious disease physician and professor of medicine and epidemiology at the University of Washington. She studies respiratory viruses and vaccines. Welcome, Dr. Chu. Next. Dr. Minnie Cambodge is Chief Medical Epidemiologist at Memorial Sloan Kettering Cancer Center in New York City. Dr. Cambodge is an infectious disease physician and professor of medicine at the Weill Cornell Medical College at Cornell University. Welcome, Dr. Cambodge. Next. Dr. George Kuchel is a geriatrician and professor of medicine in the Traveler's Chair in Geriatrics and Gerontology and directs the University of Connecticut Center on Aging at UConn Health. Welcome, Dr. Kuchel. Next. And finally, I'd like to welcome Charlotte Moser, who is our new consumer representative on ACIP, so we're particularly delighted to have you join us at this meeting. Ms. Moser co-directs the Vaccine Education Center at Children's Hospital of Philadelphia. And now, on behalf of Dr. Talbot, I will take roll calls, starting with ACIP members and then ex officio members and liaisons. For ex officios and liaisons, I'll announce the organization name, and then please indicate if you are present and your first and last name. And ACIP members should declare any conflicts of interest after they respond to the roll call. Okay, we will now proceed with roll call. Dr. Asturias?
Present. No conflict of interest.
Thank you. Dr. Brewer?
Present. No COI.
I'm sorry, could you repeat that?
Present. No conflicts of interest.
Thank you. Dr. Brooks?
Oliver Brooks, clinical professor of pediatrics, Charles O. Drew University of Medicine and Science. No conflicts. Good morning.
Thank you. Dr. Chen?
Lin Chen, I'm present. No conflict of interest.
Thank you, Dr. Chen. Dr. Chu?
Present. No conflicts of interest.
Thank you. Dr. Sineas?
Sybil Sineas, Associate Professor of Medicine and Pediatrics at the Warren Alpert Medical School. No conflicts.
Good morning. Thank you. Dr. Jameson?
Denise Jameson, Dean, Carver College of Medicine, University of Iowa. No conflicts of interest. Good morning.
Good morning. Thank you. Dr. Cambodge?
Minnie Cambodge, Memorial Sloan Kettering Cancer Center. No conflicts of interest.
Thank you. Dr. Kuchel?
George Kuchel, UConn Health, no conflict of interest.
Good morning. Thank you. I'm glad you were able to join.
Thank you.
Dr. Lair?
Dr. Jamie Lair, private practice, family medicine, Ithaca, New York. No conflicts of interest. Thank you.
Thank you, Dr. Lair. Dr. Maldonado?
Bonnie Maldonado, Professor of Global Health and Infectious Diseases at Stanford University School of Medicine. I have no conflict of interest, but I previously served as a DSMB member for Pfizer meningococcal vaccine trials and as a site PI for Pfizer pediatric COVID and maternal RSV vaccines and AstraZeneca varicella-zoster vaccine trials. Thank you.
Thank you, Dr. Maldonado. Ms. Moser?
Charlotte Moser, Children's Hospital of Philadelphia. No conflicts.
Thank you. Dr. Schechter?
Rob Schechter, California Department of Public Health. No conflicts. Present.
Dr. Shaw?
Albert Shaw, Professor of Medicine in the Section of Infectious Diseases at Yale School of Medicine. I have no conflicts. Good morning.
Thank you. Good morning. And Dr. Talbot?
Morning. Kip Talbot, Professor of Medicine and Health Policy. No conflicts of interest.
Dr. Talbot is present, but she's got laryngitis, so she will probably be talking less and I will be talking more, but she's here. So thank you. All 15 ACIP committee members are present. and we do have a quorum and can proceed. We'll now call on our ex officio representatives, and I will call them by organization. CMS? Okay. HRSA?
Good morning.
Thank you. Thank you and welcome. Indian Health Service?
Good morning. Matthew Clark representing the Indian Health Service.
Good morning. Thank you, Dr. Clark. Office of Infectious Disease and HIV/AIDS Policy?
Good morning. Chinedu Okeke, present.
Good morning. Welcome. Dr. Beigel? I'm sorry. National Institutes of Health. And Food and Drug Administration. Thank you. I'll now do roll for the liaison representatives by organization, and please reply with your name if you're present. American Academy of Family Physicians.
Good morning. Laura Morris, present.
Good morning. American Academy of Pediatrics. American Academy of Pediatrics Red Book.
David Kimberlin, AAP Red Book Editor.
Good morning. American Academy of Physician Associates.
Good morning, Marie-Michelle Léger, present.
Good morning. American College Health Association.
Good morning, Sarah Lee, ACHA.
Good morning. Welcome. American College of Nurse Midwives. American College of Obstetricians and Gynecologists.
Hi, I'm sorry, I couldn't get to the mute button. This is Carol Hayes with the American College of Nurse Midwives. I am present, and I'm sorry for interrupting out of.
No problem. We've all been there. Thank you. Thank you, Ms. Hayes. American College of Obstetricians and Gynecologists. American College of Physicians.
Good morning, Jason Goldman, American College of Physicians, present.
Good morning. American Geriatric Society.
Good morning, Ken Schmader for AGS.
Good morning, Dr. Schmader. America's Health Insurance Plans.
Good morning, Lori Goya for American Association of Health Insurance Plans.
Good morning, welcome. The American Immunization Registry Association.
Good morning, Ms. Rebecca Coyle representing ERA.
Good morning. American Medical Association.
Sandra Freihofer representing the American Medical Association.
Good morning, welcome. The American Nurses Association.
Present, Barbara Resnick, thank you.
Good morning, welcome. The American Osteopathic Association.
Good morning, Masood Mahmoudi, present.
Good morning, welcome. The American Pharmacists Association.
Good morning, Kelly Good, present.
Good morning. The Association of Immunization Managers.
Good morning, Molly Howell, present.
Association for Prevention, Teaching, and Research.
Rick Zimmerman, present. Thank you.
Good morning. The Association of State and Territorial Health Officials.
Good morning, Manisha Jutani representing ASTO, present.
Good morning, welcome. Biotechnology Innovation Organization.
Phyllis Arthur and Emily Acker for Bio. Good morning.
Good morning. Council of State and Territorial Epidemiologists.
Good morning, Christine Hahn representing CSTE.
Good morning, welcome. Canadian National Advisory Committee on Immunization.
Morning, Matthew Tunis for NACI, present.
Good morning. Infectious Diseases Society of America.
Good morning, Jim McCauley, present.
Good morning. International Society for Travel Medicine.
Good morning, Elizabeth Barnett, present for ISTM.
Good morning. The National Association of City and County Health Officials. National Association,
Sorry, this is Matt Zahn. Couldn't get myself unmuted. I'm present.
Good morning. Welcome. National Association of Pediatric Nurse Practitioners.
Good morning, Dana Deshawn, pediatric nurse practitioner representing National Association of Pediatric Nurse Practitioner. Nice to be here.
Welcome. We're glad to have you. The National Foundation for Infectious Diseases.
Good morning. This is Marla Dalton representing NFID, and I'll be joined this afternoon by Bob Hopkins, Medical Director.
Great. Thank you. Welcome, Ms. Dalton. National Medical Association.
Good morning, Dial Hewlett, National Medical Association present.
Welcome. Pediatric Infectious Diseases Society.
Good morning, Graham Paulson, PIDS.
Good morning. Welcome. Pharmaceutical Research and Manufacturers of America.
Good morning. This is Mike Lee-Barra. I'm also joined by Carolyn Haw, representing Pharma.
Good morning. Welcome. Society for Adolescent Health and Medicine.
Good morning. It's Amy Middleman, representing SAM.
Good morning and welcome. Society for Healthcare Epidemiology of America.
Good morning. Preeti Mehrotra, present.
Thank you. Welcome. So that concludes roll call. I think with that, we will get started on our first session on pneumococcal vaccines with an introduction by Dr. Lehr. But before we do that, I just want to confirm that we're good on the webcast. Okay? And can we get the slides on this monitor, please? Okay, Dr. Lehr, you can go ahead and get started.
Good morning. We're going to be presenting about the pneumococcal vaccines. Next slide. I'd like to thank the pneumococcal work group, including the ACIP members, myself, Dr. Camboj, Dr. Kuchel, and Dr. Schechter. Next slide. I'd also like to thank our CDC lead, Dr. Miyako Kobayashi, who's been absolutely wonderful in herding cats and getting us to all come to an agreement or at least a consensus on what the recommendation is for today. Next slide. Probably one of the most important things that you should know is that PCV21 is not PCV20 plus one additional serotype. This is something you should be telling all of your colleagues. This has been redesigned and has many different serotypes that are not present in the previous pneumococcal vaccines, and also is missing some of the serotypes that were in the pneumococcal vaccines. I'll draw your attention to the serotype 4, which is not in PCV21, but is in the other pneumococcal vaccines, and that might be relevant for certain populations. Next slide. This is probably one of the 3 slides I want you to focus on when we're doing my presentation. If you look on the left-hand side, it's 19 to 64-year-olds with a risk-based indication, and on the right-hand side, it's 65-year-olds with a risk-based indication. And on the left-hand side of the 65-year-old, you'll see that PCV20 covered about 54% of the serotypes for people who had invasive pneumococcal disease from 2018 to 2022. And PCV21 covers about 85%. So again, a reminder, PCV21 is not PCV20 plus one additional serotype. It is covering over 30% additional serotypes. And that's very important for our discussion. Next slide, please. There are a number of new pneumococcal vaccines in advanced stages of development. So if you look at the bottom of this slide, you'll see 2 24-valent pneumococcal vaccines which are available. And there's also a 31-valent which is coming down the pike. And these, are in different phase studies as we're going forward, but we're expecting information about these in the next few years. Next slide, please. Again, reemphasize, I've said it twice, PCV21, sorry, wrong slide. We can go back one slide. This is the current recommendations for people who are supposed to receive a conjugate vaccine, adults greater than 65 who have not received a PCV, adults aged 19 to 64 with certain underlying conditions or risk factors who have not received a PCV, and certain adults who have received PCV13 but have not received PCV20. Next slide. A reminder that PCV21 is not PCV20 plus an additional serotype. This was developed to target serotypes that commonly cause disease in adults, and the manufacturer does not have plans to seek an indication for routine use in infants. They will seek an indication for children with a risk condition, and there's a phase 3 trial currently in progress. The last line is important. We do not expect PCV21 to offer similar indirect protection from its additional serotypes, but that might be relevant if we get new higher serotype vaccines in the future that are indicated for children. Next slide. So we did a large presentation in June, and the work group was very comfortable that we could recommend PCV21 for adults who are currently recommended to receive PCV. But the work group could not reach a consensus on whether the age-based recommendation should be lowered from 65 to 50. And the majority of the work group members at that time believe there is insufficient evidence to support lowering the age-based recommendation for other recommended PCVs, specifically PCV15 and PCV20. Next slide. The ACIP agreed that we should recommend PCV21 for people over 65, but also could not reach a consensus for people between 50 and 60, whether to lower the age-based recommendation. There is just not enough data to make decisions on vaccines other than PCV20. And so the ACIP requested that the work group review the data and come back with an additional recommendation. And then there is also a feeling from the ACIP that there's a request to, can we phase out PPSV 23 in the future, if at all possible? Next slide. So the work group has met, and we came up with our policy question: should a single dose of pneumococcal conjugate vaccine be recommended for all PCV naive adults aged 50 to 64 years? Basically, we're saying, should we lower the age-based recommendation to 50? Next slide. These are the initial policy recommendations that we considered. One is to lower the recommendation for all PCVs to 50. We also considered in option 2, lowering the age recommendation age to 55 or 60. The third option was to lower it to age 50, but only for PCV 21. The fourth one was shared clinical decision-making, and the fifth one was where we are now, the status quo. Next slide. We narrowed those down to 3 options. And next slide, and this is one of the 3 most important slides, this is our final recommendation, that the majority of the work group supported lowering the age-based recommendation for all PCVs to age 50 years and older. The majority supported this option. There are some concerns which are going on. We're thinking that we will need a future booster dose. Most of the economic models that we plugged in used a waning of about 15 years. So if someone were to get the vaccine at age 50, they would then be more susceptible to pneumococcal disease at 65. The work group was not happy with that concept and said we should have an additional dose at 65. So the economic considerations that you're going to be seeing are going to have 2 doses of pneumococcal vaccine at 50 and 65, and that's very important to understand if we make this recommendation. Key uncertainties remain the indirect effects from the new pediatric pneumococcal vaccines that are coming down the pike, the duration of protection, as I just mentioned, and the impact of the new higher valency vaccines. Pneumococcal has been a very confusing recommendation for many, many years, and it's hard to have a new recommendation every 2 or 3 years, and that's one of the concerns, but we will have new vaccines coming down the pike. Next slide. This, again, is another important slide that I want you to be thinking about as you hear these presentations. These are some of the major issues that the work group considered when we were making our recommendation. Health equity is important. There's higher pneumococcal disease rates in Black African American adults with an earlier peak. The risk prevalence 33 to 54% of adults in the 50 to 64-year-old age group already have an indication for the risk-based pneumococcal vaccine. But as number 3, as you know, age-based recommendations are much easier to implement, and you're going to see studies that suggest that when you have an age-based recommendation, you can get above 50, almost 60% of the people vaccinated. But for risk-based recommendations, you might only have 20% of the people vaccinated, and that was a concern. Simplicity was very important. Trying to make a distinction between PCV21 and PCV20 when you're making a recommendation down to age 50 was a major concern for the work group. The economic considerations, doing the PCV21 at age 50 and 65 years had a lower cost per quality gained. I'll give you an approximation of about $200,000 per quality. Whereas for PCV20, it was much higher, approximately $500,000 per quality, and that was a consideration for many of the work group members. And the serotype coverage, as I said, there's a different serotype coverage, and that will be important in certain populations. So these are the 6 things that I want you to listen for when you're going through the presentations, because these are the trade-offs that you'll have to make when you're making your decision about the vote. Next slide. So for today's session, we have had my introduction, and we're going to have Dr. Stoker's economic analysis and Dr. Leidner's summary comparing various economic analyses. And then Dr. Kobayashi will be giving us the work group interpretation and the clinical considerations. Next slide. And thank you, and turn it back. Should we just go forward with the presentation? Great. Dr. Stoker, I think you're up.
Should I share screen? Okay. Hi, I'm Charles Stecker, and I'm going to be presenting the economic analysis. Next slide. I have no conflicts. Next slide. And here are some abbreviations that'll come up that you can refer to later. Next slide. So the question is to evaluate the cost effectiveness of an age-based recommendation for PCV20 or PCV21 in adults younger than age 65. And the motivation here is to get a higher coverage among risk-based adults. So they will be moving from a risk-based recommendation and that's associated vaccine coverage rate to an age-based recommendation where we think that they will have a higher coverage rate. And then additionally, we'll get a higher coverage rate among the general population. This model is going to evaluate the program cost and savings, look at the changes in disease, medical costs, non-medical costs, and work productivity costs. It's going to be from a limited societal perspective, so that means it'll include work loss for the working age population. The population is a cohort of about 4 million 50-year-olds, and there'll be separate model buckets for the immunocompromised, abbreviated IC, and that consists of HIV, cancer, organ transplants, and dialysis patients. For those with chronic medical conditions, so that's the CMC population, those have diabetes, heart disease, lung disease, liver disease, and alcoholism. And then others, we're going to term those the general population that don't have any of those conditions. Next slide. So there'll be 2 modeling strategies here, the moving strategies and the adding strategies. So in the moving strategy, we'll move the age-based recommendation from 65 to 50 or 60. And it's going to shift the disease burden from younger adults to older adults. So by moving that vaccine dose down in age, the older adults will be less protected. And there's a few concerns with the moving strategy. It may overcount the benefits. So it's going to overstate the savings from not vaccinating at age 65 if the intent of the work group is to then introduce a booster dose maybe when these other vaccines come out. It's also, this moving strategy modeling is also going to overstate unprotected time if the waning is longer than 15 years. So if we move the vaccine recommendation from age 65 to age 50, there'll be 15 years in those in between. And then if the intent is to reinstate a recommendation at age 65, and we've assumed that the vaccine waning is 20 years, and we've given the age 50 vaccine the benefit of all 20 years, then we'll overstate that benefit. And then, as I mentioned, if the future policy considerations will add a later age-based vaccine recommendation after reevaluation in the future, then that would contribute to overcounting those benefits. And those reevaluations could be motivated by an evaluation of the vaccine waning, or maybe these higher valency vaccinations coming. So we'll spend one slide on the moving strategies and results, and then we'll have more slides on the adding strategies. And so the adding strategies, they add a vaccination at 50 in addition to 65. And so conceptually what this is doing is, what is the marginal benefit of this additional dose at 50, assuming the policy was to continue a vaccination at age 65. And ideally, of course, we'd know what these new higher valency vaccines were and what they did and their effectiveness, but we'll just use the current vaccinations as a stand-in at age 65. So in the future, clinicians may prefer to administer a booster dose at age 65 in the moving strategy to ensure protection for older adults. So this, even if these other vaccines don't materialize, this is one motivation for looking at the adding strategies. And then also it's going to maintain those protective benefits for the older adults. Next slide. So here are the specific strategies we'll evaluate. So in the moving strategies, we'll look at, in the intervention arm, in the top row there is PCV20 at age 50. And then the comparator will be PCV20 at the diagnosis of immunocompromising condition or chronic medical condition, and PCV20 at age 65. So that's the current schedule on the right side. And then we'll also look at an intervention that looks at PCV20 at age 60 instead of age 50, and then again, the current recommendation on it. In the adding strategies, we'll look at 2 doses on the left side. So the top line of the adding strategies, PCV20 at ages 50 and age 65, and then the comparator is again the current recommendation. And then we'll repeat all of this with PCV21. Next slide. So here's the conceptual model. What we're going to be doing is we're going to be comparing the disease outcomes. You can see them listed on the top of the slide there: invasive pneumococcal disease, non-vaccinal, etc. In Schedule A, and then subtracting off whatever happens in Schedule B. So Schedule A might be the intervention strategy, and Schedule B would be the current strategy. Next slide, please. So our model inputs, these are in the appendix slides, so I'll just summarize them briefly here. So we're going to look at IPD rates, all-cause inpatient pneumonia and outpatient pneumonia rates, and then IPD cases resulting in fatality. And those are going to be estimated separately by age buckets and risk group, i.e. general, CMC, or IC. We are going to have age group specific IPD and MPP case fatality rates to the 3 risk groups. And then our vaccine effectiveness is going to be estimated by risk group and outcome. We're going to have a lower vaccine effectiveness against serotype 3 for both vaccines. And the vaccine serotype specific effectiveness is going to be the same across PCV 20 and 21, but they're going to have obviously different serotypes that they affect. And then the vaccine coverage is going to be estimated separately by age group, 50 to 64 or 65 plus, and separately for the existing risk-based recommendations. And I'll say that we have updated the coverage data from our June 2024 presentation with more granular data. Next slide. So the vaccine prices, it's going to be around $300 for both of them, and then there's going to be another $75 of administration, et cetera, costs. Next slide. For waning, we're going to look at 2 scenarios. One, in both of the scenarios, there'll be no waning for the first 5 years. And then one of those scenarios, it'll wane to 0 by 15 years, and in the other, it'll wane to 0 by 20 years. Next slide, please. We're going to look at the impacts of herd effects from the PCV20 program in children. In year 1, disease will be reduced by 25%. So 75% of the disease will be remaining for those serotypes that are in PCV20, and that's going to apply to both IPD and NBP. And then by year 6, 85% of adult disease will be gone due to the PCV20 program in kids. And we've modeled this off of what happened to with the PCV13 program. And then in years 7 plus, there's no further decline, so we'll just maintain that 15% of ex-ante disease. Next slide. So on to the results for the moving strategies. Next slide. So on the left side, you see outcomes. Before the line break, those are the discounted outcomes from the model. So like looking at the top row, IPD cases, when we move the vaccine from age 65 to age 50, in the PCV20 scenario results in an additional 44 cases of IPD and an additional 871 hospitalized pneumonia cases, et cetera. So across that top row, we have increases in IPD cases. Across the second row, we have increases in all-cause pneumonia cases, et cetera. And then if you go to the total cost row, you can see all those are negative. So those reflect the savings of the vaccine cost at age 65. And then the next line down, labeled dollars saved per quality lost, that's the key economic indicator for these models. This is the cost effectiveness ratio, i.e. how much does it cost for the benefits that we get. In the first column, you can see it's cost saving, meaning we save money and we get on net better health because of the way we're counting the QALYs. And then in column 2, you can see that it costs $2 million per QALY saved. So these, obviously the first row looks good, but there's some winners and losers. On net, IPD cases go up, yet QALYs go down. And this is because how we do the burden shifting. So the last 4 rows, I think, sum up the key takeaway for the moving strategies. In the first row, the undiscounted cases in the 50 to 64, they go down. This is the combination of higher coverage rates among the CMC and immunocompromised populations, as well as higher coverage rates among the general population. But then in the age 65 plus, the cases go up because we're removing the vaccine. So this is the shifting of disease burden from younger adults to older adults in the moving strategies. Next slide. So with those don't look so good because of these unprotected populations. So that's why we're going to look at the adding strategies. Next slide. So this is the base case for the adding strategies. Same slide as before, except there's no winners and losers. So I've omitted the bottom 4 rows from that table. You can look at across the top, IPD cases. Those are going to go down in all the strategies because we're maintaining these vaccinations at older ages. The first column is vaccination with PCV21 at age 50 and age 65. So maintaining that current vaccination at age 65. And then the second column is vaccination at age 60 and then at age 75. So we've revaccinated 15 years later. So instead of, because it doesn't really make so much economic sense to vaccinate at age 60 and 65. So if you'll look down, the QALYs are increasing in all of these models, and the costs are also increasing because we're adding a vaccine. We do save some on medical costs, and we also save some on preventing work loss. The second to last line is the summary economic measure, the cost per QALY. In the first column, that's adding a dose at 50 in addition to the dose at 65. It costs $214,430 per quality adjusted life year gained. And so that's for PCV21 at 50 and 65. PCV21 at 60 and 75 costs less because you're now vaccinating at ages where the disease rates are higher. So at 60 and 75, it costs $100,000 per QALY. PCV20 in the next 2 columns, you see the same pattern where we get more return when you vaccinate at later ages, but PCV20 doesn't have quite a good a serotype match with the disease in the adult population, especially after we incorporate the effects from the herd, the kid PCV20 program, and so it costs $500,000 per QALY or $300,000 per QALY if you go with the later ages. Next slide, please. So this is the same slide, but now we're looking at a 20-year vaccine waning, roughly the same results. Skipping to that second to last line, it's about $200,000 per QALY for PCV21 at 50 and 65. Next slide. And then again, we have, similar to the first slide, it's got 15-year waning now, but now it has no herd effects. So there is a cost improvement in PCV21 because some of the serotypes in 21 do overlap with those serotypes that would be reduced by the KID program. So now instead of 200,000 per QALY, we're at 130,000 per QALY. And then in the last 2 columns, PCV20 now looks better than it does when there's no herd effects. So it's $250,000 per QALY at 50 and 65. Next slide. So to wrap up, some limitations. We have uncertainty about waning and herd effects, which we presented some alternative scenarios for. We didn't model sequelae from IPDs explicitly. I think the evidence base for sequelae from kid IPD is well established, and it's much thinner for adult consequences. We have uncertainties about the pneumococcal disease trends due to pneumococcal serotypes that are no longer included in PCV21, i.e. what's going to happen to serotype 4, what's going to happen to 19F. And then we didn't model any disruptions from this change in the pneumococcal schedule as providers adjust to these new ages. Next slide. So to summarize the moving strategies, all scenarios result in an increase net cases. It does lower cases and deaths in ages 50 to 64, but it increases deaths and cases in ages 65 plus. It does have that lower cost, and that these summaries are also true. I didn't show these here, but they're in the appendix under scenarios where we have longer vaccine wanings and scenarios without herd immunity from the childhood program. Next slide. To summarize the adding strategies, adding a second age-based vaccination results in increased qualities and costs compared to the current recommendation. The ICERs range from 50K in the appendix slides to 500K per quality. And the ICERs are always lower for PCV21 recommendations than for PCV20 recommendations because of the alignment of those serotypes. Assuming no herd effects from the KID program improves economic efficiency of both the PCV20 and 21 in the adult population. The change in dollars per quality is greater in the PCV20 program because obviously they were entirely affected by the KID serotypes, but those changes aren't large enough to make PCV20 more efficient than PCV21. The assumptions around vaccine waning are minimally impactful on the ICERs because the waning is extended in both the intervention and the comparison strategies. So we assume a 20-year waning, then we're also going to assume that for the current recommendation. And then vaccination at later ages is more economically efficient. So vaccination at 65 and 75 is a lower dollar per quality than vaccination at 50 and 65. And then we also ran some models with 55 and 70 that you can see in the appendix. Next slide. Well, that's it from me. Thank you so much.
Thank you, Dr. Strecker. I think we've got a couple minutes for questions. You want to go to the next one? Okay. Dr. Leitner?
Okay, looks good. Can you hear me? Hello. My name is Andrew Leitner. I'm presenting on behalf of myself and my co-author, Sophia Blednitsky. We work on the econ team in the ARISE branch of the Immunization Services Division at NCIRD. Happy to talk to you all today about 3 economic analyses looking at PCV use among 50 to 64-year-olds.
Just a moment, Dr. Leitner. I'm not sure the audio is working.
Oh, sorry about that.
I can hear you fine on Zoom.
Thanks. Okay. Okay, so yeah, my name is Andrew, presenting on behalf of my colleague Sophia, or with my colleague Sophia Blednitsky. Next slide, please. This presentation summarizes the work of 3 modeling teams. The teams are listed here. I really appreciate all the hard work that was done by these teams. Next slide. I have no conflicts. Next slide. For your reference, here's some shorthand and abbreviation. Next slide. This presentation will include a background on cost-effectiveness analysis, an overview of 3 models and some of their main results, additional results from sensitivity analysis, a discussion of 2 other models beyond the 3 main models, and finally I'll talk about the limitations and provide a summary of results. Next. The main objective of cost-effectiveness analysis is to calculate an incremental cost-effectiveness ratio, or ICER. The ICER equation is presented in the blue box. The ICER value is the dollar per outcome term on the far right of the blue box. An ICER summarizes the difference in value between 2 vaccination strategies. One strategy is the intervention and the other is the comparator. The difference in cost between the 2 strategies is divided by the difference in outcomes to get the ICER. In this case, the intervention under consideration is vaccination using PCV at ages 50 to 64, and the comparator is the current set of PCV recommendations. Essentially, the ICER will tell us how much additional cost is associated with each additional unit of health outcome gained by vaccinating 50 to 64-year-olds as compared to the current recommendations. Next. Economic models of vaccination can be thought of as a calculation that summarizes many different aspects of a disease and a vaccine into a single measure of economic value. Economic model inputs include vaccine efficacy, disease burden, fatality rates, and costs. All these different factors contribute to the estimated ICER. And if there is uncertainty in these underlying factors, then the estimated ICER can have a range to reflect that uncertainty. Next. One way to think about ICER values is by considering a graph like this. The y-axis shows change in costs, which is the numerator in the ICER equation. The x-axis shows the change in health outcomes, which is the denominator of the ICER equation. The CR in the origin represents current recommendations, so values on this graph are all relative to the current recommendations. The best region for economic value is in the bottom right quadrant, where health outcomes are better and the costs are lower. Saving costs and getting better health is the best place to be for economic value. The worst region for economic value is in the top left quadrant, where health outcomes are worse and costs are higher. Spending more money and getting worse health is not good economic value. Most new healthcare interventions and the main results we'll see in this presentation will all be found in the top right quadrant. This quadrant has better health outcomes and higher costs. So strategies in this quadrant improve our health, but the change in cost is positive, so we have to pay for that better health. Next. A final key takeaway from a graph like this is to suppose you have two estimated ICERs, estimate A and B. Both are located in the top right quadrant, so relative to the current recommendations, both A and B will improve health and both will increase costs. In this example, A and B have the same change in health outcomes. They both generate 8 additional QALYs, but B has a lower change in cost, so the ICER for B is lower. Equivalently, we could say that B is less expensive or that B is preferred to A because it is less expensive in economic value terms. Next slide. Just to reiterate the policy question, should a single dose of PCV be recommended for all PCV naive adults age 50 to 64? Next slide. The first comparison that addressed the policy question was referred to as the moving comparison or the moving strategies in the presentation by Dr. Stecker. This is not the main comparison we'll be looking at today, but I wanted to briefly mention it here as a reminder. In this comparison, the comparator strategy is current recommendations for PCV. The intervention strategy is age-based vaccination at 50 years only. The middle columns of this table show vaccination coverage rates under the comparator and intervention strategies. Note these coverage rates are from the Tulane CDC model. The other models have different coverage assumptions, which will be described in a couple slides. The far right column in this table shows the modeled policy impact on vaccination coverage for different age and risk groups that might be impacted by the policy change. Note that in this moving comparison, PCV coverage among 50 to 64-year-olds increases, and PCV coverage among 65-plus-year-olds decreases. The results from the Tulane CDC model indicated that with this comparison, the overall burden of disease would increase, so overall there would be more cases, more hospitalizations, and deaths. It would shift the disease burden from adults in their 50s to older adults in their late 60s and 70s. This comparison was also investigated by the Pfizer model, and the overall health impact estimates were similar, increased numbers of cases, hospitalizations, and deaths. Finally, just note again in the bottom row, far right column, the modeled policy impact in this comparison is that coverage decreases in the 65-plus age group by 70%. Next slide. This slide shows the vaccination coverage in the main comparison we'll be considering for the rest of the presentation. It was also called the adding comparison or adding strategies. Notice in the bottom right cells of the table, there is now age-based vaccination at age 65 plus in the intervention strategy, which means between the intervention and comparator, there is now no change in PCV use among populations 65 years and older. This adding approach isolates the modeled policy impact to just those individuals in the 50 to 64-year-old age band. Next slide. The adding comparison allows for a more direct estimate of the impacts of expanding coverage among adults aged 50 to 64. It also presumes that older adults aged 65 and up would not be left without any disease protection if the age-based recommendation were lowered to 50. This seemed reasonable to do for a few reasons. First, even with a 50-year-old age-based recommendation, it seemed likely there would be some vaccine-naive individuals who might not get a PCV until they turn 65 and join Medicare. Secondly, new evidence may become available that demonstrates PCV vaccines confer protection for longer than 15 years. If protection does last longer than 15 years, then someone vaccinated at age 50 could still be protected at age 65 and beyond. Finally, at some point in the future, new vaccines may become available and a revaccination strategy could be in place. Next. This slide and the next provide an overview of assumptions across the three models. I'll just highlight a few of them that were identified during the review as contributing to differences across models. The first assumption I want to mention is the cost of vaccinations in the middle of the table. The Merck and Pfizer models have lower costs per dose, which will lead to lower ICERs. The second assumption I want to mention is the vaccine coverage changes in the 50 to 64-year-old population in the next to last row of the table. Increasing vaccination coverage among 50 to 64-year-olds is a likely outcome of a policy change to lower the age base of PCV dose, but the economic value will depend on how that increased vaccination coverage gets distributed across the higher risk and lower risk individuals who are 50 to 64 years old. The more coverage increases in the higher risk population, which is the CMC-IC populations, the lower the ICERs will be. The Pfizer model assumes a higher increase in coverage among CMC-IC, which would lead to a lower ICER. The Merck model assumes a lower increase in CMC-IC, which would lead to a higher ICER. The Merck model includes a sensitivity analysis where the CMC-IC coverage rate increases by 8%. When the Merck results are presented later, that 8% increase scenario is included as part of the range of estimates when possible. The last assumption on this slide I want to mention is in the bottom row, the serotype coverage for PCV21 versus PCV20. This assumption was also mentioned in the meeting in June. The Tulane CDC and Merck model looked at both vaccines, PCV20 and PCV21. In those models, the circulating serotypes that were specific to PCV21 were at least twice as prevalent as the serotypes that were specific to PCV20. Because there's more circulating preventable disease associated with PCV21 than with PCV20, the ICERs for PCV21 tended to be lower than for PCV20 in the models that assessed both vaccines. Next. I want to mention two groups of assumptions on this slide. First is the vaccine effectiveness described in the top three rows. All three models have very similar VE for the first 5 years. After 5 years, the Pfizer model base case assumes higher VE than the other two models. Overall, the Pfizer model assumes about 30% more vaccine protection than the other models. This will contribute to lower ICERs in the Pfizer model. In addition, the Pfizer model estimates VE against non-bacteremic pneumonia in two different ways. The first way is based on estimates of circulating vaccine-type disease. The second way, which is represented in the third row down from the top, is based on observational studies that have estimated PCV vaccine effectiveness where all-cause pneumonia is the primary outcome. This all-cause pneumonia VE approach confers more vaccine or more disease protection than the vaccine-type VE approach. The all-cause approach lowers the estimated ICER in the Pfizer model. Both of these approaches will be reflected in the range of results presented for the Pfizer model. The second group of assumptions I want to point out is the indirect effects in the middle rows of the table. In these models, indirect effects come from childhood use of PCV20. The use of PCV20 in children reduces the burden of disease across the entire population, including adults, With a lower burden of disease due to these indirect effects, the ICERs will increase when indirect effects are included. All three models include indirect effects in their base case. The indirect effects impact the two vaccines differently. Indirect effects have a bigger impact on PCV20 than PCV21 because PCV21 has several serotypes that are not included in PCV20. Due to the uncertainty around the magnitude of indirect effects, on the next few slides, the results from all the models will be shown as a range, where the range will include scenarios with variability in the magnitude of indirect effects. Next. These are the main results from the models. Looking at the adding comparison, where age-based use at age 50 and 65 is compared to the current recommendations. These results are reported as ICERs that represent the additional cost incurred to gain an additional QALY. Across the Tulane CDC and Merck models, in the top row, the cost per QALY for PCV21 ranged from $130,000 to $430,000. Across all three models, in the bottom row, the cost per QALY for PCV20 ranged from $56,000 to $880,000 per QALY. Finally, just note again, apologies. Note that across all models, there's a wider range for PCV20 than for PCV21. This is partially due to there being 3 models that assessed PCV20 versus only 2 that assessed PCV21. But this is also due to the impact of indirect effects, which has a bigger impact on PCV20 values than PCV21 values. The Tulane CDC ICERs tended to be lower than the ICERs from Merck and were higher than the ICERs from Pfizer. The Tulane CDC and Merck models assessed both vaccines, and within each of those 2 models, PCV21 was less expensive than PCV20. Next. Vaccine effectiveness and duration of protection are uncertain and impactful inputs in these models. The scenarios on this slide assumed higher VE and longer duration of protection. In general, these ICERs are lower than on the previous slide because higher VE, longer duration of protection confer better economic value. In the top row from the Tulane and Merck model, Tulane CDC and Merck models, the ICERs for PCV21 ranged from $117,000 to $200,000 per QALY. In the bottom row across all 3 models, the ICERs for PCV20 range from $62,000 to $420,000 per QALY. Note the lowest estimates for PCV20 were from the Pfizer model. Next. Indirect effects are another input that is highly uncertain and also impactful in these models. This slide focuses on scenarios where the magnitude of indirect effects are reduced. Remember that lower indirect effects means there's a greater burden of disease in the adult population, and the greater burden of disease then leads to better values or lower ICERs across all models. Many of the estimates on this slide are the lower range values from the main results slide a few slides ago. Next. In addition to the Tulane CDC, Merck, and Pfizer models, there were also 2 other models that we considered over the last few months. Those models are the Merck Health Equity Model and the Pittsburgh Model. The Merck team submitted a separate health equity modeling analysis that used the Atkinson Index to quantify inequality across Black and non-Black populations with and without 50 to 64-year-old PCV vaccination. Their model concluded that 50 to 64-year-old vaccination would reduce health inequality or would improve health equity. The Pittsburgh model was summarized in the meeting last June. This model focused on the value of PCV use among Black and non-Black population groups, and this model estimated equity benefits were associated with 50 to 64-year-old PCV vaccination. Next slide. All these models are subject to limitations. Model results are subject to uncertainties. 3 that have already been touched on include limited clinical data on vaccine effectiveness and in particular duration of protection after 5 years post-vaccination. There are also limited empirical estimates of indirect effects from the use of PCV20 in pediatric populations. And finally, the magnitude and distribution of vaccination coverage among 50 to 64-year-olds, if the age-based recommendation were lowered to 50, are not known with certainty. Additional limitations that we have not touched on yet include future epi around serotype 4 and 19F, the impact of supplemental PCV doses, particularly with higher valency PCVs in the future years, and finally, implementation challenges that might be associated with changing the schedule were not explicitly considered in any of the models. Next. In summary, using the adding comparison, the main results indicate age-based vaccination at 50 years would lead to improved health but no cost savings. Estimated results had a wider range in value for PCV20 than PCV21 because PCV20 was assessed by 3 models, not just 2, and also because of indirect effects. Finally, in the 2 models that assessed both vaccines, the ICERs were lower for PCV21 than for PCV20. Next. With that, once again, I want to acknowledge the hard work of everyone who worked on these models, and I'm happy to try to answer any questions.
Thank you, Dr. Leitner. We do have a few minutes where we can take questions.
Hi, this is Helen Chu, University of Washington. Thank you for that presentation. I had a question about the Pfizer model and why they assumed 36% VE compared to 0% after that waning period. Do they have some data to support that?
Well, the data on vaccine duration of protection following 5 years is limited. So all the assumptions in the model are kind of expert opinion. And they're, just to clarify the way their vaccine effectiveness waned, the Tulane and CDC models, they declined kind of linearly from 5 years. They went straight down to 0 at year 15. And the Pfizer model did more of a parabola shape. So it declined every year, but kind of more gradually. And it was at 36% in year 15, and then it dropped to 0% in year 16.
I had a question about the duration of immunity. Because the conjugate vaccine is so different than the polysaccharide, what studies were used to determine a 15-year time point? Yeah.
Hi, can you hear me? Okay. Hello? Okay. Yes, this is Dr. Kobayashi. So again, unfortunately, we don't have good data. It's based on what has been used in other studies when assumption of duration of protection is needed. So that's something that we hope to get better confidence in data, and we hope to get that in the future.
So because of that, this is Kip Talbot, if you can't tell by the lack of voice. So was any modeling done with a 20-year duration of protection to see what that would change the model?
Yeah, all 3 models did variations on duration of protection. And I think the Tulane CDC and the Merck model did include a 20-year waning period. When there is like a longer period of protection, the ICERs definitely go down. It's not as impactful as herd effects. Yeah, but they definitely do go down if the protection is longer.
And this is Dr. Kobayashi again. I also wanted to add that we did try to look at information from other conjugate vaccines, for example, meningococcal vaccines. Again, we have to note that the disease severity is different, so we can't completely assume based on what is known for other vaccines, but we know that for meningococcal vaccines, the duration of protection from the conjugate vaccines isn't that long. I think there are studies showing duration protection of about like 10 plus years. And then also there were some pediatric carriage studies. Again, for pediatric carriage, number of doses given to children are different from what's given to adults, which is typically a single dose, so we can't completely infer, but there has been some data showing some gradual decline even within a period of 7 years. So from those, we kind of assumed that it wouldn't be that much longer than what we estimated. But again, there are definitely uncertainties that we acknowledge. Thank you.
We have a group of adults that received PCV13, so it'd be interesting if we could get some serology data on those folks, since it's been, what, 10 years more?
So yes, that's definitely something we've been trying to look into, and thank you.
Dr. Shah.
Thanks. It's Al Shaw. I just had a question. Did the models, I think I saw that the models differed in their consideration of post-infection care, things like need for long-term care or skilled nursing facility or increased disability. Were those incorporated? I thought in some models, but not others. Is that correct?
That's correct. The Merck model includes a disability state following invasive pneumococcal disease episodes, and the Pittsburgh model includes a disability state following, a small percentage of invasive pneumococcal disease episodes as well as non-bacteremic pneumonia episodes.
I don't see any more questions from committee members. So we'll move on to the next presentation. Dr. Kobayashi.
Doing a quick sound check? No? Okay. I'll just use yours. Quick sound check? Okay. All right, so good morning. Today I will be presenting our work group's interpretation of the evidence to recommendation framework and policy options regarding PCV use in adults aged 50 years and older. Okay. Our policy question, again, as a reminder, is should a single dose of pneumococcal conjugate vaccine, or PCV, be recommended for all PCV-naive adults aged 50 through 64 years old? The PICOs are shown in this table. The ETR framework consists of the 7 domains shown here. First is public health problem. Okay. This figure shows the invasive pneumococcal disease, or IPD, rates due to all pneumococcal serotypes during 2007 through 2022 by year and by age group, using CDC's active bacterial core surveillance data. After PCV13 was recommended for children in 2010, IPD rates decreased not only in children in gray, but also in older adults in blue through indirect effects of PCV13 use in children. After PCV13 use in children, the incidence of IPD in adults aged 50 to 64 years, indicated by the arrow, has been higher than that in children aged under 5 years. It's worth noting that although PCV13 was recommended for all adults aged 65 years and older in late 2014, this intervention had minimal population-level impact, leading to the discontinuation of this age-based recommendation in 2019. Looking at IPD mortality rate per 100,000 population, the rates in adults aged 50 to 64 years and 65 years and older have been the highest across all age groups. With reductions over time, the IPD mortality rate in adults aged 65 and older has become closer to that in adults aged 50 to 64 years. So who's getting pneumococcal disease among adults aged 50 to 64 years? Nearly 90% of adults in this age group with IPD or hospitalized pneumococcal pneumonia had at least one condition that currently qualifies for a risk-based pneumococcal vaccine indication, or a risk condition. Is pneumococcal disease of public health importance? The workgroup interpretation was yes. Data show that the success of the pediatric pneumococcal vaccine program increased the relative burden of pneumococcal disease in adults aged 50 to 64 years, especially in those with risk conditions. Some work group members stated that we should consider the absolute rate of disease, which has come down significantly compared with pre-PCV era rates. Next is equity, which was one of the key considerations among the work group. According to NHIS 2020 data, about 32 to 54% of adults aged 50 to 64 years had a self-reported condition with risk-based pneumococcal vaccine indication, with a wider range across race and ethnicity groups compared with adults aged 65 years and older. This shows percentage of any pneumococcal vaccine coverage by vaccine indication in age group using 2022 BRFSS data. Disparities in vaccine coverage by race and ethnicity exist for both adults with age-based and risk-based indications. This figure was presented at the June ACIP meeting and shows IPD incidence due to any pneumococcal serotype in 2018 to 2019. It compares Black adults to the left to non-Black adults to the right in 5-year age increments, starting from age 40. The red horizontal dashed line represents the average IPD rate for adults aged 65 and older across all race and ethnicity groups. The figure illustrates that in Black adults, IPD rates peak at a younger age 55 to 59 years, compared to non-Black adults who show a steady increase in IPD rates with age. Notably, the IPD rates for Black adults aged 50 years and older exceeded the average IPD rate for all adults 65 years and older. We estimated the impact of hypothetical vaccination scenarios to estimate their impact on non-PCV13 type IPD rates among American Indian, Alaska Native, Asian, Black, and white adults 19 years and older. Non-PCV13 type cases account for most of persisting racial disparities in IPD. For this analysis, we assumed PCVs provide complete protection against vaccine-type disease in adults with IPD from 2014 to 2019, and the dots indicate average non-PCV13 type IPD rates for each racial group before applying vaccine scenarios. The first scenario applied the currently observed vaccination coverage by race, risk-based vaccine coverage for adults 19 to 64 years, and age-based vaccine coverage for adults 65 and older. And under both PCV20 scenario to the left and PCV21 scenario to the right, non-PCV13 type IPD rates decreased, but the rates in American Indian, Alaska Native adults, and Black adults remain above the population average shown by the black dotted line. The second scenario assumed an expanded age-based vaccine recommendation. The current vaccine coverage by race for adults 65 and older was applied to all adults 50 years and older, while maintaining risk-based vaccine coverage for adults 19 to 49 years. Under both PCV20 and PCV21 scenarios, this achieved greater reductions in non-PCV13 type IPD incidence in American Indian, Alaska Native, and Black adults compared with scenario 1. However, only Black adults in the PCV21 scenario saw rates drop below the population average. Therefore, while lowering the age-based recommendation has the potential to reduce IPD incidence in racial groups experiencing the highest burden of disease, racial disparities would likely persist. The workgroup interpretation was that recommending PCV for all PCV-naive adults aged 50 to 64 years would probably increase health equity. This is by improving vaccine coverage for those with known or unknown risk conditions, providing protection at an earlier age when certain populations are already experiencing elevated disease rates, and by simplifying the recommendation, which could improve implementation across all populations. The workgroup also acknowledged that the overall impact on health equity is complex. It would depend on how the recommendation is implemented and any underlying disparities in healthcare access. Next is benefits and harms. Benefits and harms were determined by data against the outcomes specified in PICO. For benefits, outcome deemed of critical importance were vaccine type IPD, vaccine type non-bacterial pneumococcal pneumonia, and vaccine type pneumococcal deaths. However, studies assessing these clinical outcomes were not available for PCV 15, 20, and 21, so these were informed by immunogenicity data from clinical trials. Assessment of harms was guided by data on serious adverse events after vaccination. This was informed by safety data from clinical trials and post-licensure data for PCV 20. Post-licensure data for PCV 15 will not be presented since data were limited. We previously conducted systematic review of literature and presented summary of findings and grade for PCV 15, 20, and 21. We conducted an updated literature search based on the new PICO question, and in total, 6 PCV 15, 3 PCV 20, and 7 PCV 21 clinical trials were included in the updated review. The search terms and list of included studies are available in supplemental slides. The overall conclusions from immunogenicity data remain unchanged. PCV 15 met the non-inferiority criteria for all serotypes shared with PCV 13, while also having statistically significantly greater response to the additional serotypes 22F and 33F. PCV 20 also met the non-inferiority criteria for all PCV 13 serotypes. When compared to PPSV 23, PCV 20 met the non-inferiority criteria for 6 out of 7 non-PCV 13 serotypes, with the exception of serotype 8. PCV 21 met the non-inferiority criteria when compared to PCV 20 for all 10 shared serotypes and had statistically significantly greater response to 10 out of 11 serotypes unique to PCV 21, except serotype 15C. The worker believed that the anticipated effects of the intervention were moderate. However, it's important to note that we don't have direct clinical outcome data specified in PICO for these newer vaccines. At the February ACIP meeting, certainty of evidence was deemed moderate for the PCV 21 clinical trials. Conclusions of safety data from PCV clinical trials also remain unchanged. There were no vaccine-related serious adverse events reported for PCV 15 and PCV 20. 2 vaccine-related serious adverse events were reported among PCV 21 recipients, and these findings were previously presented. During the February 2024 ACIP meeting, post-licensure PCV 20 safety data from VAERS and from the FDA-CMS partnership were presented. The majority of VAERS reports for PCV 20 through December 2023 were non-serious. However, a data mining alert was triggered for disproportionate reporting of Guillain-Barré syndrome, or GBS cases, following PCV 20 vaccination. 11 GBS cases were confirmed upon chart review, equating to a reporting rate of 0.5 million per million doses. Preliminary data from the FDA-CMS partnership had not identified any safety concerns regarding GBS associated with the PCV 20 vaccine among Medicare beneficiaries aged 65 and older. VAERS report through August 2024 included 18 chart-verified GBS cases after PCV 20 vaccination, resulting in 0.7 GBS cases per million doses distributed. Updated analysis from the FDA-CMS partnership showed a statistically significant signal for GBS following PCV 20 vaccination in Medicare beneficiaries 65 and older, using the primary definition for GBS. It's important to note that these GBS events were identified through claims data without chart confirmation, and findings were not statistically significant when using a different GBS definition or adjusting for positive predictive value of GBS. And incidence of GBS was low, which resulted in wide credible intervals. In summary, updated post-licensure PCV 20 safety data showed that there is a potential GBS signal for PCV 20 in VAERS. There was a GBS signal in Medicare sequential monitoring for primary definition, but not for the alternate definition or when adjusted for positive predictive value. Significant uncertainty remains because of the small number of GBS cases observed, and CDC and FDA will continue to monitor post-licensure PCV safety. The work group determined that the undesirable anticipated effects of PCV vaccination were minimal despite the updated PCV20 post-licensure safety data from the FDA given the uncertainties. However, the work group emphasized the need to continue to monitor post-licensure safety data. At the February ACIP meeting, certainty of evidence for PCV21 was determined moderate due to imprecision. Weighing the desirable and undesirable anticipated effects, the work group believed that the intervention, which is recommending PCV for all PCV-naive adults aged 50 to 64 years, is favorable compared with the current risk-based recommendation. However, some work members believed that the interpretation would vary by the PCV product being considered. Next is values and preferences. Does the target population feel that the desirable effects are large relative to undesirable effects? Yes and probably yes combined were supported by the majority of work group members. However, a third of the members said don't know. Members with experience serving underserved populations with many underinsured or self-pay individuals noted that these groups can be comfortable with pneumococcal vaccines if benefits are clearly explained. At the same time, it was noted that effectiveness of communication about benefits depends significantly on who delivers the message and how much time is spent explaining it. There was also discomfort in asserting what the target population thinks without more evidence. Some believe that average populations may prioritize concern about undesirable effects over perceived benefits. An increased vaccine hesitancy observed in recent times made the interpretation challenging for some. Is there important uncertainty about or variability in how much people value the main outcomes? The work group interpretation was probably not important uncertainty or variability. Next is acceptability. Is it acceptable to recommend a PCV for all PCV-naive adults aged 50 to 64 years? The work group interpretation was yes. At the June 2024 ACIP meeting, we presented findings from Merck-funded healthcare provider surveys that indicated challenges with implementing risk-based vaccine recommendations due to time constraints, difficulties in identifying vaccination history or underlying health condition of the patient. Survey providers also showed support for lowering the age-based recommendation to age 50 years. Next is resource use. As you saw in the presentation by Dr. Leidner, all models using adding strategies improved health, but none were cost saving. Cost per quality gained estimates for PCV20 had a wider range, reflecting more uncertainty than PCV21. In 2 of 3 models, PCV21 had lower cost per quality gained than PCV20. Is PCV used for PCV-naive adults aged 50 to 64 years a reasonable and efficient allocation of resources? The majority of work group members responded either probably yes or yes. Members valued the opportunity to prevent more disease, particularly among racial and ethnic groups who currently have higher disease burden despite the higher economic costs. However, probably no was the second most common response. Some expressed concerns about the less favorable economic analysis findings for PCV20 compared to PCV21. Improved vaccination coverage among those with risk-based pneumococcal vaccine indication could diminish the need for broader age-based recommendation while acknowledging that there has been insufficient success with the risk-based vaccination strategy. The decision varies when considering projections over the next 15 years, for example, indirect effects of pediatric vaccination, availability of new higher valency vaccines, data on duration of protection from vaccination, and considerations of whether or not to give booster doses. The last ETR domain is feasibility. Is it feasible to implement PCV for all PCV-naive adults aged 50 to 64 years? Probably yes and yes combined reached a majority. There are currently other vaccines recommended for all adults in this age group, including the recombinant zoster vaccine recommended for all adults 50 years and older. Vaccine coverage data for such vaccines show that vaccine coverage in younger adults is generally lower compared with adults age 65 and older, even with an age-based recommendation. However, pneumococcal vaccine coverage was disproportionately lower in adults aged 50 to 64 years who had risk-based indications for vaccination. The rightmost column compared the coverage ratio between adults aged 50 to 64 years and 65 and older across different vaccines. Age-based recommendations are generally easier to implement than risk-based recommendations. The lower vaccine coverage in younger adults is less likely due to multiple factors such as healthcare access, perceived risk of disease, or benefits from vaccination. We know that there is a larger proportion of adults aged 50 to 64 years without health insurance compared with adults 65 and older. Workgroup members agreed that having a different age-based vaccine recommendation by product would be more challenging to implement. At the same time, variability in health insurance coverage might keep PCV20 as the only practical option for some individuals in the short term, since PCV21 is new. This is a summary of the workgroup interpretations of the ETR domains. Now let's bring all of these elements together to explain how we arrived at our proposed policy option. Factors supporting lowering the PCV age-based recommendation that were recognized by the workgroup were the following: the relatively high burden of pneumococcal disease in adults aged 50 to 64 years, particularly among those with risk conditions, potential for improved vaccine uptake through an age-based recommendation, which is easier to implement compared with the current risk-based recommendation, potential to reduce pneumococcal disease incidence in demographic groups experiencing the highest burden, and projected health benefits from economic models despite increased net costs. We also deliberated on several potential implications of lowering the age-based recommendations for all PCVs. While the economic models showed health benefits, there were significant concerns about the cost of lowering the age-based recommendation for both PCV20 and PCV21 when considering overall health benefits to society. Concerns were raised that variability in health insurance coverage might keep PCV20 as the only practical option for some individuals in the short term, given that PCV21 is a newer vaccine. But at the same time, the workgroup agreed that having different age-based recommendations by vaccine would be challenging to implement. We also acknowledged several uncertainties that could impact future policy decisions. How long is the duration of protection from a dose of PCV in adults? What is the magnitude of indirect effects from pediatric PCV 15 or 20 vaccination? What might be the impact of higher valency vaccines under development? Despite these uncertainties and concerns, the majority of the workgroup believed that recommending a single dose of PCV for all PCV-naive adults aged 50 to 64 years would probably result in desirable consequences outweighing undesirable consequences in most settings. Although the majority recommended, about a quarter of the workgroup members did not recommend the intervention, and this was primarily due to, again, the higher cost per quality gained for PCV20 compared to PCV21 and economic analyses, uncertainties around key assumptions like the impact of pediatric PCV use and duration of protection, and concerns about the implications of a broad recommendation given the differences in serotype coverage between PCV20 and PCV21. However, the majority believed that there is sufficient information to move forward with a policy option to recommend the intervention. The proposed policy option is ACIP recommends a pneumococcal conjugate vaccine for all PCV-naive adults aged 50 years and older. Before moving on to clinical considerations, I'll pause here and I would be happy to take any questions. Thank you.
So at this time, are we just saying that we recommend adults over 50 years of age, and then later we will reevaluate if a second dose is required?
Correct. At this point, the work group felt that there's insufficient evidence to recommend, when exactly, to whom, how to provide a second dose. So today we will not be, for this session, we're not including that in the policy option.
Dr. Lear. Dr. Schechter.
Thank you for the excellent presentation. On slides 16 and 17 with the hypothetical scenarios, what was the vaccination coverage rates estimated, and were they uniform between racial and ethnic groups?
Yes, could you show slide number 16, actually, vaccination coverage by racial groups, is that the?
What I mean, what vaccination coverage rates were estimated with reductions in disease?
Thank you very much. So if you could please go to slide number 16. So for that, we used observed vaccine coverage through BRFSS. For this specific analysis, we used 2021 data, so it wouldn't be that different from what I presented in slide 12 in the as part of the evidence for ETR domain equity. So what we did was that we assumed that each racial groups get the observed vaccine coverage by age-based and the current age-based and risk-based recommendations. And then for simplicity, we assumed that all vaccine type disease will be prevented. So the reduction is a factor of the observed vaccine coverage by racial group, and then the serotype distribution in each racial group. Thank you.
Thank you. Dr. Chu.
I just wanted to clarify a point that Dr. Talbot brought up. So based on my understanding, the recommendation now is to move the recommendation down from 65 plus to 50 plus. But we know in the moving model that then shifts the disease burden potentially to an older adult group, assuming that there is waning, and given that we are potentially not recommending a second dose at 65. Is that correct?
So if there is no future vaccination coverage, that is a potential risk. But as mentioned in the other economic model presentations, it's very unlikely that adults will have only an opportunity to get vaccinated at age 50. Probably what will happen is that if the age-based recommendation is lowered, people will have an opportunity to get vaccinated starting from age 50 unless they were previously vaccinated under risk. So it's possible that some adults will continue to get vaccinated at age 65. We also don't know how the future recommendation will look like whenever the new higher valency vaccines currently in advanced stage of development becomes available for use. So there are uncertainties, and that is part of the reason why we'd like to reevaluate that in the future.
Okay. Great, thank you. Can I just ask one more question, which is about the percent uninsured by race in that 50 to 64 category, and those who might not be able to receive PCV 21? Do you have data on that?
So the approximate, this is off memory, but there is a national estimate which is around, I believe, 10% of adults in that age group who do not have any sort of vaccine coverage. And then that percentage becomes a much lower, a single-digit value once adults hit 65 and older group.
But by race, so in higher risk race groups, is that percent uninsured higher?
Oh, unfortunately, I don't have the number by for that specific age group by race and risk group, unfortunately.
Okay. Okay, thank you.
But I assume there will be some variability.
Okay. Dr. Brewer?
This is Noel Brewer. I have two questions. One has to do with age effects. Is the benefit of the vaccine is the vaccine effectiveness the same at any given age given? Does it wane over time? Not saying the same person, once they're vaccinated, is it as effective a year or 2 or 3 later? That was addressed directly in your model. It's a different question about whether you get the same vaccine effectiveness at age 50 and 65. And I apologize if you said that and I missed it.
Just to confirm, so the question was whether the effectiveness of vaccine will be the same at age. So yes, thank you for that question. So there are some data that show that probably the vaccine effectiveness, if given at the same time for somebody who's younger versus older, it will be probably lower in adults who are older, and that's putting aside waiting for protection.
Yeah, I was trying to connect that idea to, as I was thinking about it, to the idea of equity, that if we have Black adults having higher risk factors, it would be a concern to me if those risk factors are coming younger, and that if by vaccinating older, we're missing the folks at higher risk. I mean, it's just another way of looking at the same data and the same conclusions you already made. Let me ask a separate question, which is the policy decision was put down at 50. How do we come to the age of 50? I'm very sensitive to the idea of crowding a space with multiple vaccines, and it's not working very well in the adolescent platform, and in my opinion, I'm wondering, are we creating the same situation now at age 50? Why is 50 a good idea versus even 52 or 55? Can someone speak to that?
Yes, thank you for that question. So we actually did consider alternate age thresholds earlier in the discussion. Could we please go to slide number 14? And part of the reason is, so one of the reasons is because of this peak of IPD rates when looking at Black versus non-Black adults. And then if we, so the alternate age thresholds that we considered were 55 when, based on this figure, the rates peak in Black adults. We also considered 60 as an age threshold because there are some vaccines that have thresholds at that age. However, one of the concerns was that it wouldn't really address one of the main motivations that was behind lowering the age threshold, which is the health equity piece, or the potential to reduce disease burden in certain demographic groups experiencing higher disease burden at a younger age. And also, age 55 didn't seem to align with any of the existing vaccine recommendations, so there were some concerns that there might be some additional implementation challenges with that age threshold.
So the perspective is that by picking an existing year, well, the equity issue is compelling, I agree, but the idea is that by picking an existing year that's on the schedule, it makes it easier, not harder. And I'm going to propose that the opposite may be true.
Thank you, Dr. Brewer. Dr. Shaw.
Yeah, thank you for that. It's a terrific presentation. I understand that the question will leave the choice of conjugate vaccine to the practitioner, and I was wondering, Dr. Lair's presentation specifically mentioned the absence of serogroup 4 in PCV20 while it's present in PCV15. The absence of serogroup 4 in PCV21 when it is present in PCV15 and 20. So I was wondering if the published guidelines would mention, specific populations that seem to be at risk for serogroup 4. So this would be, I believe, residents of the Navajo Nation, specific, I think, residents in the Western U.S. with substance use disorders or unhoused persons. It seemed, at least in older data, I don't know if there's updated data on that. It seemed to be at increased risk for serogroup 4.
Yes, thank you for that question. So unfortunately, I don't have any updated data readily available to share with you for serotype 4, but then that is something that we are looking into so that we can publish more up-to-date data to inform practitioners who might be affected in the populations currently experiencing or observing higher prevalence of serotype 4 disease. And those are the groups that would probably benefit from a serotype 4 containing vaccine. We do have that guidance in the currently published MMWR that was published last month, but we do plan to provide up-to-date data whenever available. Thank you.
Dr. Asturias.
Yeah, Edwin Asturias. In slide 9, you mentioned that 88% of those presenting with a serious pneumococcal infection have one or more medical conditions. It may be a difficult question to answer, but what proportion of these medical conditions were diagnosed at the time of the pneumococcal infection?
Thank you for that question. So that question did come up during the work of discussions as well, and unfortunately, we don't have that information. But if you're getting at how many undiagnosed conditions there might be, definitely it's definitely possible that there were people who got sick and had undiagnosed risk conditions.
Dr. Brooks.
Yeah, first of all, just excellent presentations ×4, including yours, Dr. Lair. Again, slide 9, do we have any information regarding those that were hospitalized? And as a side comment, we think about COVID vaccine is not to prevent COVID, but to prevent hospitalization and death. And so I think that this data is even more important than the fact that 33 to 54% have a risk, but that 88% are the ones hospitalized with a risk. But do we have any data on how many of these were actually vaccinated of this particular age group because they had a risk and therefore an indication to get vaccinated?
Yes, so unfortunately for both data sources, we don't have vaccination history of these individuals who had risk condition, but that's something that we would like to look at. Thank you.
Thank you.
Any other comments or questions? Oh, Dr. Maldonado.
Thank you. This is a great presentation and a great follow-up to the June meeting. I have a question about access equity for the 50 to 64-year-olds. And my sense, and again, I don't have data to support this, but I wonder if you do, the issue around access. As a pediatrician, I think we have kind of a baked-in system with children, and the 50 to 64-year-old group just needs work on messaging, I think. And in addition, my own sense from the COVID period of time is that there were people, just again anecdotally, who wanted to get vaccinated at off-label, and had an underlying condition, and it took 2 or 3 rounds getting back to their physician, trying to get documentation. I mean, I get calls all the time from adults. I'm a pediatrician, but I get, can you give me a letter for CVS, for example, because they don't generally go to their medical home, and a lot. I'm sorry, I didn't mean to give a pharmacy, and the pharmacies have to follow guidelines, and there are many guidelines across the country that may be different from state to state or from pharmacy unit to unit. And it can be a real barrier on top of what Dr. Woods just mentioned around undiagnosed conditions for somebody to have to go back to their caregiver to be able to get a note and then get that to a pharmacy and then get their vaccine. So I do think that there's probably, and unless you have other data, understanding that under vaccination in those age groups should not be a barrier. In fact, it should be a call to action to try to access those groups over time, and then understand that there is some of the underlying conditions for why people may be under-vaccinated may be understudied, and may be results of those age groups with underlying conditions who may just have less access to healthcare providers who can provide them documentation. Thank you.
Thank you. Dr. Lair.
Jamie Lair, and I'm the chair of the pneumococcal work group. So I'm going to speak for a little bit and respond to some of the things that have just been said and give my own summary as well. I'd like to echo Dr. Brooks and thank everyone for their presentations, especially Dr. Steckner and Leidner and Dr. Kobayashi for an excellent presentation and bringing the information to us to make it a clear decision. For Dr. Chu and Dr. Talbot, with regard to the age 50 and then having an additional dose, the work group was very clear that we did not want to penalize those over 65 by giving the dose at age 50. And so if the waning is as expected, the work group was very clear that we felt that there will be an additional dose needed 15 years after the first dose. We don't have that data now, and that's why it's not in the recommendation right now, but it will be studied and followed over time to make sure that the people who are getting it, if it wanes, get it later and get protected from it. With regard to Dr. Shah, there is going to be very clear guidance that if there's a high prevalence of serotype 4 in certain communities, then there will be a recommendation in favor of PCV20 over PCV21, or at least a serotype 4 vaccination if we have other vaccinations coming down the pike. Could we go to slide 47, please? We had a robust discussion in the pneumococcal work group, and there were a number of factors. You remember from my presentation, we had 3 main policy options we considered. One was dropping the age from the PCV, all PCVs down to age 50. One was dropping PCV 21 down to age 50, and one was the status quo, which is what we have right now. And I want to emphasize, as the chair of the work group, that the majority of the work group favored taking all PCVs down to age 50. And there are a number of reasons, some of which are here. The equity reason, which is number 3, that there are certain populations which are not protected by the recommendation at age 65. The risk base, there's a high burden of disease already in the 50 to 64, and many of those are not getting covered under the risk-based recommendation. And so those were the main reasons I would think of why we wanted to do it. I'm going to take off my chair hat now, and I told the work group I was going to do this, and put on my individual ACIP member hat here. And I want to say that I disagree with the work group, and that I would have chosen option 3. And option 3, which isn't here, is to just lower the recommendation for PCV 21 down to age 50, and not for all pneumococcal diseases. And if you'll go to the next slide, one of the major reasons that the work group felt that we should do it for all PCVs is the implementation. They were very, very strongly in favor of simplicity. Make it easy, make it understandable for working physicians to know what's going on. And personally, I just think that was a mistake, because I think that the cost differential is significant. PCV 20 is much more expensive when you go down to age 50 compared to PCV 21. I think that providers are smart enough to know that there are 2 different vaccines. I think that PCV 21 is a better vaccine. From the slides you've seen, it covers many, many more serotypes for adults. So this is my personal opinion. I want to not disregard, and I totally respect what the work group is saying. And so that is what is going to come forward to the ACIP. My understanding from Dr. Wharton is that because the work group has made this recommendation, that doesn't even need a motion. Is that true?
No, we will need a motion. Can we go back to the proposed policy language?
So I, as the work group chair, am going to make a motion in favor of this, but I will tell you right now that I'm going to vote against it. And if this group, the ACIP, votes this down, I will then make a motion at that time to make the recommendation to lower the recommendation for PCV 21 only down to age 50. So just being clear and transparent about my thoughts. But I am now formally making a motion that the ACIP recommend a pneumococcal vaccine PCV for all PCV and naive adults aged greater than 50 years. Thank you.
Dr. Lair, thank you for the clarity. Do we have a second for this motion? Is that a second, Dr. Sineas? Okay, can you say it out loud? I second the motion. Before we proceed, I'd like to make one comment as chair prerogative. If we vaccinate at 50 and we have to revaccinate at 65, I take that as a total win. That means our adults have had a healthy life and they have not passed away before their grandkids. And so to me, this is a total win. Okay, I think we're ready to move on. Oh, sorry. Go ahead, Dr. Brewer.
I apologize if I'm out of order in terms of the discussion. I'm just not yet persuaded by the implementation argument, and so I'm not able to support this for PCV 20. It doesn't make sense to me. I think I'm convincible, but I'm not convinced by what I heard.
Thank you, Dr. Brewer. Dr. Brooks.
I hear what was just stated by Dr. Brewer and by Dr. Lair. There are 7 domains of ETR. And so both of you have some issue with one of the domains. So the question would be, is that issue with one domain enough for you to determine your vote? And that's obviously your choice. But even if your positions are reasonable and even accurate, it does not mean necessarily that you would still vote against it, because I more or less agree also with you, but I think that the other areas outweigh that, and it's not an all or nothing for me.
All right, Dr. Lair, last comments so we can move on. Oh, sorry, Dr. Shaw. Actually, Dr. Shaw had his up first, so go ahead, Dr. Shaw.
No, just quickly, so in the event, for Dr. Lair's proposal, then there would still have to be an exception made for serogroup 4 at-risk individuals were that to come up. Is that correct?
Can you say yes out loud, Dr. Lair?
Yes, the work group would make an exception and probably under clinical considerations for serotype 4. Thank you.
Dr. Lair, did you have anything else to add?
I want to emphasize what Dr. Brooks says, is that this is just a difference in priorities. I'm weighing different values in the ETR system than other people are weighing, and it doesn't mean that I'm right and they're wrong. And I totally respect the work group recommendation. I'm simply saying that my values are different, and so I'm voting differently based on those relative prioritization of the values. So I thank Dr. Brooks for pointing that out. Thank you.
Yeah, I think it's an issue of weighting of values, that reasonable people can differ in how they weight the different domains of the ETR, and that's, I think, what this discussion is highlighting.
Thank you, Dr. Jameson.
Thank you. Given Dr. Lair's concerns, cost effectiveness is one. The other issue, the fact that if you look at slide 5 from his initial slides, the PCV 21 coverage is better for most adults. It seems that that could be handled in the clinical considerations. So a recommendation for vaccination at 50 and above, but with the clinical consideration that 21 may be better in some cases based on the coverage.
Okay. Any other comments? This has been a very good discussion, very thoughtful. All right, I'm letting Dr. Warden take over.
There are a couple of liaison members who have hands up. We'd ask for very brief comments. Dr. Zimmerman.
Yes, speaking on behalf of the Association Prevention, Teaching, and Research, the association supports lowering the age of routine vaccination to 50 years due to the benefits on health equity and to a greater likelihood to protect persons with high-risk conditions who are aged 50 to 64. As is well known, risk-based recommendations result in lower coverage rates than age-based recommendations. There is a large burden of pneumococcal disease in persons less than 65 with high-risk conditions. In addition, the peak age for pneumococcal attack rates in Black Americans is less than 65 years of age. Published decision analyses showed that use of PCV21 at age 50 and again at age 65 would result in a 15% decrease in invasive pneumococcal disease cases in Black Americans and a 14% decrease in other populations. Thus, APTR supports lowering the age for routine vaccination to 50 years. Thank you.
Thank you, Dr. Zimmerman. Dr. Goldman, again, a brief comment, please.
Very brief, thank you. As a general internal medicine specialist practicing and vaccinating my patients, I'm very much in favor of lowering the age. I think that will improve implementation. I think it is better for the patients. 21 is different from 20, and I think that is something we need to really take into account. My only concern with lowering one and not the other as far as implementation, if you have the at-risk conditions with 19 to 64, and now we have an overlap of which vaccine to give, we want to make sure that we have the most succinct and clear considerations for who should be vaccinated between the 50 to 64 now with other medical conditions and which vaccine they should choose. But overall, I'm in favor of lowering them and personally think that both vaccines should be available and given to each patient, not just the vaccine naive, because they are two separate and distinct vaccines, in my opinion, and would certainly support lowering it to age 50. Thank you.
Thank you, Dr. Goldman. We do have requests from both manufacturers to make brief statements. Dr. Haupt, please be brief.
Yeah, thank you. I just want to make sure you can hear me okay, yes or no?
Yes.
Yep, great. We would like to thank the pneumococcal work group for their thorough reevaluation of the policy question. Merck strongly supports the work group's proposed recommendation. Would like to underscore the imperative of this vote for improved adult pneumococcal vaccine utilization and, more importantly, health equity. A vote to expand the age-based recommendation improves access to the benefits of pneumococcal vaccination and provides an opportunity to reduce persistent disparities in pneumococcal disease risk that have not been addressed under current recommendations. That is my simple comment in summary. I did want to note, because it came up, we actually have very high payer coverage for PCV21 already. Remember, it was licensed in June. Payer coverage, both from commercial as well as Medicare Advantage plans, usually follow MMWR publication. And so there's the vast majority have already covered PCV21, and we expect that to be near final by the end of the year. Thank you.
Thank you very much. Dr. Hodar?
Yes, thank you very much, Dr. Talbot. Can you hear me?
Yes, we can. Thank you.
Thank you. So Pfizer as well, despite their different compositions, support an ACIP recommendation to use any of the currently available PCVs for all adults age 50 years and older. In the case of PCV20, this is supported, I think, as the presentations have said, for the following reasons. The burden of IPD and pneumococcal pneumonia caused by the 20 serotypes remain a public health concern, which is especially pertinent for serotypes unique to PCV20, including serotype 4, which has been increasing not only in the US, but also globally with a focus in disadvantaged populations. The use of PCV20 in individuals age 50 to 60 years of age is estimated to be a reasonable use of resources while reducing pneumococcal disease cases and disease-related deaths, and differential recommendations for only one higher valency vaccine, I think, as was said, would create a de facto preferential recommendation without the robust evidence base that is expected for this type of policy, complicating implementation of the recommendations, creating a barrier to vaccinating vulnerable populations. For all of the above, Pfizer contends that coexistence of both PCV21, PCV15 followed by PPSV23 and PCV20 in the adult population will allow a greater choice, less complexity of recommendations, increased equity, and easier implementation. Thank you very much.
Thank you. So I think we'll now turn things back over to Dr. Kobayashi for the clinical considerations.
Hello? Okay. All right. So now I will cover clinical considerations for implementation. And these are clinical considerations assuming that the recommended policy options move forward. So for PCV naive adults or those with unknown vaccination history, there's only one key change. The age threshold for age-based recommendation will be 50 years and older, while risk-based recommendation apply to adults 19 to 49 years. And the recommended vaccine options remain unchanged from our current guidance. So this is how the updated clinical guidance will look. Again, the only proposed change is the age threshold. For PCV13 experienced adults who completed the recommended series or shared clinical decision-making recommendation regarding the use of a supplemental PCV20 or PCV21 dose remains unchanged. The current age threshold is maintained because under previous recommendations, PCV13 vaccinated adults were only considered have received all recommended vaccine doses after receiving one final dose of PPSV23 at or after age 65. And as a result, this scenario applies only to adults age 65 and older who receive both PCV13 and PPSV23 at or after age 65. So this is how this recommendation looks in a figure. Again, no changes are proposed. For PCV13 experienced adults who have not completed the recommended series, we propose updating the guidance to state a single dose of either PCV20 or PCV21 is recommended for adults aged 19 years and older who have started their pneumococcal vaccine series with PCV13 but have not received all recommended doses. Under current guidance, PCV13 vaccinated adults can complete their series with PPSV23. However, the number of recommended PPSV23 doses varies by age and risk condition, making the recommendation complex. With our updated clinical guidance, we propose that those who started with PCV13 but haven't completed their series complete their vaccination with a single dose of either PCV20 or PCV21. This is how the current recommendation looks with PPSV23 shown in gray boxes. So with our updated clinical guidance, we propose that those who started with PCV13 but haven't completed their series complete their vaccination with a single dose of either PCV20 or PCV21. And not in this slide, but we currently do have clinical guidance on use of the higher valency pneumococcal conjugate vaccines, specifically in areas experiencing high proportion of serotype 4 disease. And depending on what the new recommendation will be, we will work with the work group to review that clinical guidance. This is the end of my presentation. I'd like to thank the following groups and individuals for their contributions. Thank you.
Dr. Talbot has asked me to see if there's additional comments or questions from the committee. Should we take a break? Okay, seeing none, I think we can take our break a few minutes early. We had a 10-minute break scheduled, so I think we can make that 12 minutes and reconvene at 10:25 a.m. Thank you all very much. Good morning. This is Dr. Wharton reconvening after the break on behalf of Dr. Talbot. Our next session is influenza vaccines, and I will turn things over to Dr. Lair, who is the influenza vaccines work group chair.
Good morning, and thank you, Dr. Wharton. Next slide, please. This is a list of the influenza work group when it appears. I'd like to thank everyone on it. Special attention to the other ACIP members, Dr. Schechter, Dr. Shaw, and Dr. Talbot, the ex officio members, and all the liaisons. I'd also like to do a special thank you to the CDC lead, Dr. Grosskopf, who's been the chair, the work group lead for many, many years, for a very long time, and has done a wonderful job of helping us move forward with the influenza work group. Next slide. We also have some CDC participants who've been very helpful in our deliberations. Next slide. A brief update. You may have heard that FluMist, which is a live attenuated influenza vaccine, has been approved by the FDA for the self or caregiver administration. This will be not for this current season, but will be hopefully available for the 25-26 season. So for this current year, it will only be available from healthcare providers. But in the future, it would be able to be ordered online, sent to the house, and given either by a person themselves or given to their child. We hope to have a presentation on this in the future before next season. Thank you. Next slide. We have a few topics specifically for today. We have the vaccine effectiveness. Influenza vaccine effectiveness varies, and we assess it annually. We gave some preliminary data at the February 24 meeting, and now we have the end of the season influenza vaccine effectiveness update, which Dr. Ellington will be presenting later on today. Next slide. You may have heard of the avian influenza H5N1, and we want to give an update here. It has been detected in U.S. dairy herds in 14 states, and we have 27 human cases. 16 confirmed as H5N1 have been reported during 2024. So Dr. Shimabukuro will be presenting an update on the highly pathogenic avian influenza H5N1. And this, again, is just for discussion and information purposes. Next slide. And finally, you might recall that at the June 2024 meeting, we extended the high-dose and adjuvanted vaccines to be given to solid organ transplant recipients. And we included that for all people ages 18 through 64. Having said that, the 18-year-olds are under the VFC, and so we need to do a formal VFC vote to give approval that we can give those vaccines as an option for 18-year-old recipients of solid organ transplants. So Dr. Santoli will be giving us a presentation on that. Next slide. I think we're ready to move forward, and so we're going to move forward with Dr. Ellington's presentation. Thank you very much.
All right, good morning. I'm Sasha Ellington from the Influenza Division, and I'll be presenting on 2023 to 2024 end of season influenza vaccine effectiveness. Let's see. So the 2023-2024 season was an H1N1 predominant season with lower levels of H3N2 and B Victoria circulation. Peak influenza activity occurred week 52 of 2023. The vaccines last season were quadrivalent and included an A H1N1 PDM09, A H3N2, and B components in the vaccine. We have 4 platforms that we use to assess vaccine effectiveness. We have the Investigating Respiratory Viruses in the Acutely Ill, or IV, the New Vaccine Surveillance Network, or NVSN, the U.S. Flu Vaccine Effectiveness Network, or as we call it, U.S. Flu VE, and the Virtual SARS-CoV-2 Influenza and Other Respiratory Viruses Network, or VISION. The 3 platforms at the beginning are, the first 3 listed are active surveillance platforms that enroll participants and test all participants for influenza, and then VISION is a passive surveillance system that is EHR-based. Our 4 networks cover all ages in both outpatient and inpatient settings, so I'll walk through that quickly here. Starting with children and adolescents, NVSN is a pediatric network that includes outpatient, emergency department, and hospitalizations. Then we have U.S. Flu VE that enrolls children in outpatient settings, including clinics, emergency departments, and urgent care. Then we have vision, which includes children from emergency departments, urgent care, and hospitalizations. And then for adults, we have IV that includes hospitalized adults. U.S. flu VE enrolls adults in outpatient settings. And then vision also enrolls adults in outpatient settings. Taken together, these networks provide data on the full age spectrum across healthcare settings. And then our networks are also geographically diverse, including patients from 23 states. So as you may recall, we put out interim VE estimates in February of this year in an MMWR and presented at the February ACIP meeting. These estimates use data through the end of January, and while we had hit the peak, there was still a lot of flu season left at this point. So today I'm going to present our interim estimates, and when possible, compare those to, I'll present our final estimates, and then when possible, compare those to what we had estimated for the interim estimates. So for our methods, we use the test negative design, comparing vaccination odds among case patients with influenza confirmed by molecular assay versus control patients testing negative for influenza and SARS-CoV-2. Vaccination status was determined by receipt of any 2023-24 seasonal flu vaccine according to medical records, immunization registries, claims data, and/or self-report. VE was calculated as 1 minus the adjusted odds ratio times 100. Estimates were adjusted for geographic region, age, and calendar time of illness. IV, US flu VE, and vision also adjust for sex and race and ethnicity, and then US flu VE network also adjusted for days between illness onset and enrollment and self-reported general health status. So next I'm gonna go over VE estimates for children 6 months to 17 years. For each age group, I'll present the VE against any influenza, against influenza A, and then against influenza B. So in February, we estimated that VE ranged from 59 to 67% for children in the outpatient setting and 52 to 61% in the inpatient setting. Our final end of season estimates were very similar. You can see here 56 to 59% in the outpatient setting and 59 to 64% in the inpatient setting. For flu A, we estimated VE was 46 to 59% in the outpatient setting, and then 46 to 56% in the inpatient setting. And then our estimates were quite similar for our end of season estimates shown here. For influenza B, we estimated VE was 64 to 89% in the outpatient setting. We were not able to provide an estimate when we did interim estimates for inpatient setting due to insufficient data at that time. So you can see that when we're able to do end of season estimates, we did have enough data. So we found similar estimates, and then we were able to provide additional estimates for inpatient setting, estimating that VE was 78 to 85% for VE against influenza B in the inpatient setting. So next I'll go over VE estimates for adults 18 to 49 years. For this, I'm only presenting the end of season. In the interim, we had to combine 18 to 64 due to insufficient data for the interim estimates, and I'll use those as a comparison for the next age stratification. So here you can see that for any influenza among adults in the outpatient setting, the VE was 37 to 54%, and then in the outpatient setting was 51 to 53%. For influenza A, the VE in the outpatient setting was 20 to 45% across the platforms, and then 37 to 44% in the inpatient setting. And then for influenza B, we saw effectiveness of 67 to 75% VE in the outpatient setting and 68 to 72% in the inpatient setting. So next, I'll present VE for adults ages 50 to 64 years. And for those, I do provide for comparison, the comparison to the 18 to 64 for reference, though keep in mind it's not the exact same age group here. You can see that for the interim estimates, we were estimating in the outpatient setting against any influenza, the VE was 25 to 52%, and then inpatient setting was 40 to 49%. And then in the for the end of season estimates, we saw similar VE estimates both outpatient and inpatient. For VE against influenza A, we had VE ranging from 13 to 49% in the outpatient setting, and then 38 to 42% in the inpatient setting. And then similar estimates were seen for our end of season estimates against influenza A. And then for influenza B, We noted again higher VE, 75 to 79% in the outpatient setting, and then 50% in the inpatient setting. For end of season, we saw similar VE for outpatient, and for inpatient, we were able to, again, provide an estimate from an additional network that couldn't produce an estimate for interim, though the confidence intervals are very wide for this estimate. We did have enough data to produce an estimate for end of season. So next, I'll present the data for adults over 65 years of age. Our interim estimates ranged from 41 to 51% in outpatient settings, and were 42% in both the platforms for the inpatient setting. And then you can see we had similar end of season VE for adults over 65, and this is against any influenza. Then for influenza A, in the outpatient setting, they range from 40 to 52% and 42 to 47%. And then in the end of season estimates, 36 to 37% in the outpatient setting and 27 to 35% in the inpatient setting. And then again, against influenza B, we were not able to provide a B estimate for inpatient when we put out these interim estimates, but we saw high VE in the outpatient setting for adults 65 and older. And then when we did our end of season estimates, we were able to provide more estimates for VE against influenza B in both the outpatient and the inpatient setting. Again, some wide confidence intervals because we do not have as many influenza B cases, but we did have enough by the end of season to produce these estimates. So I did want to briefly also go over some of our cumulative data by A subtype. So we were able to use our 3 active surveillance networks to estimate VE by subtype. For A, H1N1, all estimates were under 50% for adults, with the lowest VE observed in adults less than 65. For children, VE was about 50% from NVSN in both inpatient and outpatient settings, and around 60% from US flu VE, which is an outpatient network. And then for H3N2, we had less data to produce these estimates since 2023 to 24 was an H1N1 predominant season. So confidence intervals are wider here. We observed the lowest VE among adults over 65 years. For children, we observed a VE around 40% against hospitalization and 50% for outpatient from NVSN. US flu VE observed lower VE for children in the outpatient setting, but again, these confidence intervals are quite wide due to less cases of H3N2 last season. All right, so moving to the conclusions here. So vaccination with the 2023-24 influenza vaccine reduced the risk of medically attended influenza outpatient visits and hospitalizations among children, adolescents, adults, and older adults over 65. While point estimates varied from network to network, across the 4 networks, most results were consistent with overlapping confidence intervals. Importantly, we found preliminary end-of-season estimates are similar to our interim estimates from February, so largely consistent. We were, however, able to generate more estimates for more different stratifications because we had obviously more data by end of season, and with more data, the confidence intervals, the confidence in the estimates also increased. And I think that is all I have. Thank you.
Thank you so much, Dr. Ellington. I think according to our schedule, we're going to proceed on with the H5 update from Dr. Shimabukuro, and then we'll take questions on both presentations. Dr. Shimabukuro.
Thanks. So today I'll be giving an update on highly pathogenic avian influenza A H5N1 and the situation in the United States. And moving forward, I'm going to refer to this for brevity to H5N1 or H5. Next slide. So this is a figure showing H5N1 and H5 human cases reported since 1997. And if you focus on the bar for 2024, and this is current through August, you'll see that a substantial number of those cases in 2024 have been reported in the United States. That's that purplish or maroon section of the bar, and those are related to the 2024 outbreak in dairy cattle. Next slide. So historically, human infections have been the result of poultry exposures. So direct or close contact with sick or dead poultry, activities such as visiting a live poultry market, and exposure to other infected animals. In the case of the current outbreak in the United States, exposure to dairy cows. Limited non-sustained human-to-human transmission has occurred globally in the past, but not in the United States. Next slide. So CDC's priorities include supporting and engaging public health and agricultural partners, protecting human health and safety, understanding risk to people from H5N1 viruses, and assessing H5N1 viruses for genetic changes. Next slide. So as of October 18th, 2024, USDA has confirmed H5N1 in U.S. dairy herds in 324 farms across 14 states. Dairy cow illness was observed in early 2024, and the main presenting sign was a decrease in milk production and quality. On March 25th, 2024, USDA reported H5N1 confirmed in cows from Texas and Kansas, and it subsequently spread to the states that you see on the map there on the right-hand side. Next slide. So this shows a table of the 27 reported human cases in the United States during 2024 by state and by exposure. 27 total cases. The majority of those involving exposures to dairy cattle and some exposures to infected poultry, and then one with unknown exposure, that's the Missouri case. So cases with dairy cattle and poultry exposures have been clinically mild, mainly eye symptoms, so conjunctivitis and eye discharge. Some cases reported mild respiratory and systemic symptoms. The Missouri case had multiple underlying health conditions and was hospitalized with gastrointestinal symptoms, chest pain, and other symptoms not typical of a respiratory illness, and tested positive for influenza A. The illness was not severe. The patient was treated with oseltamivir and recovered. So this specimen was identified and confirmed as H5N1 through regular surveillance. So during the summer, we had an enhanced surveillance program, so we maintained high level of influenza surveillance over the summer, including recommending that, that specimens be sent to public health labs for subtyping. So this specimen, which was, again, this person tested positive in the hospital, this specimen was sent to the lab, and then at the lab, it was tested positive for H5N1, and per protocol was sent to the CDC for confirmatory testing, where CDC confirmed the results. So serology results are pending on the case. Symptomatic household contact of the case, and several exposed healthcare workers who experienced mild respiratory illness at some time following an exposure to the case. Next slide. So as far as the human the cases from or the virus from the human viruses from the human cases, the sequences maintain primarily avian genetic characteristics and lack changes that would make the virus better adapted to infect or spread among humans. There's been no impact to the current CDC influenza diagnostic assay's ability to detect H5N1 viruses, and no known markers of resistance to FDA-approved antiviral drugs for influenza have been detected. The hemagglutinins of the human influenza viruses remain antigenically related to the two available candidate vaccine viruses, and assessment of newer viruses, for example, the California viruses, are underway. And I just want to reinforce that seasonal vaccines would not be expected to provide protection from influenza A H5N1 viruses. Next slide. So this slide outlines CDC's recommendation on symptom monitoring. All people with direct or close exposures to animals infected with H5N1 should be monitored for illness during exposure and for 10 days after their last exposure. Signs and symptoms may include feeling feverish, cough, sore throat, runny or stuffy nose, muscle or body aches, headaches, fatigue, eye redness, shortness of breath, or difficulty breathing, and less commonly diarrhea, nausea, vomiting, or seizures. If signs or symptoms develop, recommend that the patient seek medical evaluation for possible influenza testing and antiviral treatment. Symptomatic persons should isolate away from others during this evaluation. And state and local health departments are monitoring workers on impacted farms and can facilitate testing and treatment. Next slide. So here are some data on our targeted H5 surveillance, and by targeted I mean this is surveillance of workers or others who have been exposed to infected animals on farms. And CDC is continuing to support state and local health departments monitoring exposed people during and for 10 days after exposure. So with this targeted surveillance, over 5,100 total people have been monitored after exposure to infected animals. Over 260 people have been tested after exposure to infected animals, and 26 cases have been detected through this targeted H5 surveillance program. Next slide. So we're also conducting regular surveillance, and this is really our enhanced summer surveillance and surveillance going into the influenza season. So since February 2024, public health laboratory monitoring includes testing of 54,360 specimens using a protocol that would have detected H5 or other novel influenza viruses. And so again, this is our regular monitoring that we normally do, that we maintained at a high level over the summer while the outbreak in dairy cattle was evolving. And through this testing, one person has tested positive. We have detected one case, and that is the Missouri case that I previously described. There have been no indicators of unusual influenza activity in people, including H5N1 in our regular surveillance. Next slide. So I'll go over some findings of a Michigan seroprevalence study, and these have been previously these findings have been previously communicated on a spotlight on our website. So in June 2024, the Michigan Department of Health collected blood samples from 35 dairy workers. These workers had varying roles, but most worked with infected cows, and less than half reported using masks or goggles. Samples were tested for antibodies against H5N1 virus and also a seasonal influenza virus as a control. None of the participants showed neutralizing antibodies specific to H5N1 virus, although many showed antibody responses to seasonal influenza virus. And this suggests that these people were not previously infected with H5N1 despite high risk of exposure. And there's additional serology work ongoing at CDC in collaboration with our state partners. Next slide. Moving on to some ferret studies. So the ferret model permits study of influenza disease severity and transmissibility at the same time. Ferrets present with many clinical signs of infection shared by humans, but not conjunctivitis. There are limitations of the ferret model. These ferrets are in sustained contact 24/7. The inoculation doses used in these studies may not be representative of natural exposure in humans. Ferrets used in most studies have no pre-existing antibodies to influenza, unlike most humans who have had disease or vaccinations. And there are the general limitations of animal models. Next slide. So these are the data on the pathogenesis and transmission of human influenza AH5N1 viruses in ferrets using the Texas virus, which was the first human case in 2024, and also the Michigan virus, which was the second human case in 2024. You see the Texas in the first row there of the table, and the Michigan results, the results from the Michigan virus from the human case in the second row. There were two ways of looking at this. The direct contact transition model, which you see on the lower left part of the screen, that's where an inoculated ferret is placed in the same living space with a naive ferret. They're allowed to interact. And also the respiratory droplet or the airborne transmission model. That's where an inoculated ferret and a naive ferret are placed next to each other in cages that allow air exchange between the two living spaces. So if you compare the pathogenesis and transmission of the human Texas and the human Michigan viruses, you'll see that mean maximum weight loss was greater in the Texas virus, 13%, versus the Michigan virus, which is 9.1%. Lethality was greater with the Texas virus, 9 out of 9 inoculated ferrets for 100% lethality versus 0 out of 6 for Michigan. For direct contact transmission, 3 out of 3 for Texas, 100%, and also 100% for Michigan. And for respiratory droplet transmission, there was 66% transmission, 4 out of 6 for Texas, and 66%, 2 out of 3 for Michigan. Next slide. So to sum up the ferret study data, as far as severity, the Michigan human H5N1 virus caused less severe disease in ferrets than the Texas human H5N1 virus. There was less mean maximum weight loss, 9.1% versus 13%, and lower lethality, 0 for 6 or 0% versus 9 for 9, 100%. The Michigan human H5N1 virus still transmits with some capacity by the respiratory droplet route, similar to what was observed with the Texas human virus. And these findings are important because the Michigan human H5N1 virus better represents currently circulating viruses compared to the Texas human H5N1 virus. Next slide. So I'm going to go over some of the findings from the CDC influenza risk assessment tool that we conducted. It's called the IRAT. The IRAT is an evaluation tool for prioritizing resources for pandemic preparedness. The viruses are scored using 10 risk elements you see there on the right-hand side by U.S. government subject matter experts for emergence and public health impact. Emergence is the risk of a novel influenza virus acquiring the ability to spread easily and efficiently in people. And public health impact is the potential severity of human disease caused by the virus, the burden on society if a novel influenza virus were to begin spreading efficiently and sustainably among people. Next slide. So in this figure, you see the scores of several of the IRATs plotted, and I've highlighted the Texas H5N1 2024 virus. That's the virus that we conducted the IRAT on. And I've also highlighted the Spanish mink and the American widgeon as well. Those are both 2344B clades and viruses where we have conducted fairly recent IRATs. So for the Texas virus, the emergence score was 5.8 and the impact score was 6.1. That's compared with the Spanish mink virus, which emergence was 5.1 and impact was 6.2. And the American widgeon, where emergence was 4.4 and impact was 5.1. So the highest emergence score on this table was the Eurasian avian swine H1N1 in China, with an emergence score of 7.5 and an impact score of 6.9. And the highest impact score was in the H7N9 virus in China, the emergence 6.5 and impact 7.5. Next slide. So the IRAT is an evaluative tool used by public health partners for prioritizing resources for influenza pandemic preparedness. It is not intended to predict a pandemic and is not to be used to assess the overall population risk nor individual risk. Using H5N1 clade 2344B, the Texas H5N1 virus, as the prototype virus, the score remains in the moderate potential pandemic influenza risk category. The mean high and mean low acceptable scores Score ranges for all the clade 2344B viruses overlap, indicating that these viruses remain similar and their overall risk scores remain moderate. Based on available data, CDC's current risk assessment is that the risk to the general public from H5N1 virus remains low. Next slide. So in summary, again, the overall risk to the public for HPAIA H5N1 remains low, but that can change quickly. There's greater risk for people with close, prolonged, or unprotected exposures to infected animals or to environments contaminated by infected animals. And exposed individuals should monitor for symptoms after first exposure and for 10 days after the last exposure. Next slide. So here's a couple communication products that we have developed on PPE for farm workers. Next slide. Here's some resources from CDC. Next slide. Next slide. Thank you, and that concludes my presentation.
Thank you very much. Any questions or comments from the voting members? Dr. Chu.
So thank you for that nice presentation. I had a couple of comments and questions, specifically around the data around the airborne transmission in the ferret studies and the differential lethality of the two different strains. Do you have any sequencing data on the viruses to indicate changes in potentially receptor binding with the Texas and Michigan strains?
I don't have the details in front of me, but what I can, I mean, I would refer back to slide 7. I believe the sequencing data to date is consistent with the information on these slides. These maintain primarily avian genetic characteristics and lack changes that would make the virus better adapted to infect or spread among humans.
Can you speculate on why there's a difference in lethality between the two viruses?
I'm sorry, can you speak up?
I said, can you speculate on why there's a difference in lethality between the two viral strains in the ferret studies?
You know, I'd rather not speculate about that. I think I'll have to get back to you with some, talk to our folks in the lab and get back to you with some information on that.
Okay. And then can I ask, are there any household studies being done to look at transmission in these communities, in the farm worker communities?
We do have teams right now in the field working with our state partners who are doing epidemiologic investigations, contact tracing, and looking for evidence of animal to human and human to human spread. So there will be more information forthcoming on those investigations, and I'm sure they're looking at all angles in the course of those investigations, again, conducted in collaboration with a state and local public health partners.
Okay, thank you.
Dr. Schechter.
Thank you, Rob Schechter. Along with the Michigan seroprevalence data, are there additional data from poultry workers over the last few years regarding seroprevalence?
I'm not, I suspect there is, but I'm not aware off the top of my head of seroprevalence data in poultry workers. There may be data from outside the United States. I'm not aware of any in the United States, but that's not to say that there isn't.
And in following up with Dr. Shu's questions, can you comment on the level of genetic differences between the Michigan and the Texas strain? How many or how few?
I'm going to have to get back to you all with those details on the differences between the Michigan and the Texas strains.
Thank you.
Dr. Shaw?
Yeah, thanks very much for that nice presentation. I had 2 questions. One is about information on the use of detection of H5N1 in wastewater, and whether those have detected H5N1 and whether you can distinguish human from animal sources? That's my first question, I guess.
So wastewater surveillance is being conducted. It complements our traditional surveillance. There have been detections of H5N1 in wastewater, and all that information on wastewater surveillance is available on the CDC website. Where they have detected, it's usually associated with, they've been able to associate it with animals, so animal waste or maybe areas where there's dairy production or dairy processing facilities. But typically, when they've made detections, it's either in areas where there's been infected herds or there's some connection to animals or animal like milk products. And I'm sorry, one of the limitations of wastewater surveillance is you really, it's difficult to definitively determine source, whether animal, human, or an agricultural product.
Okay, thanks. And my other question was if there was any specific outreach to make sure dairy and poultry farm workers receive seasonal influenza vaccination. Obviously, the big concern would be some kind of recombination event between an HPA influenza strain and a seasonal human strain. So beyond, our usual recommendations, is there any outreach to make sure they're vaccinated?
So we have a program to support jurisdictions where there have been infected herds to promote and to provide seasonal influenza vaccination for agricultural workers. The main purpose of that is to protect those individuals from seasonal influenza, and there may be also some benefit of reducing some noise to signal if we can prevent respiratory illness, but those efforts are ongoing.
Okay, thanks.
Dr. Lear.
Thank you for your presentations. I'm almost embarrassed to ask, but for Dr. Ellington or Dr. Grosskopf, I often get questions from patients, if I get the flu vaccine and I get the flu, will I have a less severe case? And I'm wondering if we have any data on that. We have the evidence of vaccine efficacy where they might not get it, but will be less severe if they do get it. Thank you.
So none of the data that I presented today illustrate that, but there's certainly, there are studies out there that indicate that through other designs that you would have less severe illness. But our vaccine effectiveness studies are not designed to answer that question specifically. But I don't know, Lisa, if you want to add anything to that.
Yeah, I don't really have anything to add. There are various studies that have found a suggestion that you're less likely to have severe illness, but we're not able to address that in our platforms.
So I'd just like to say for the public that not only do we recommend you get the vaccine to prevent the illness, but if you get the illness, you'll likely have a less severe case when you get the illness. So another recommendation for everyone to get their flu vaccine. Thank you.
Thank you. Seeing no more, there's Dr. Hahn.
Yeah, hi, thank you. I just wanted to speak, representing CSTE, I wanted to speak as a state epidemiologist with a state that has had multiple impacted dairy herds that to get back to, and Tom Shimabukuro answered these questions well, but just from a state perspective, absolutely, we've had wastewater detections, and we do investigate those, but as Tom alluded to, it's very hard to know, there's no way to know where that's coming from. But in our cases, we do investigate. It appears that a dairy, a milk processing facility is probably the source of those detections. And as far as the vaccine, yes, we've reached out. And I think almost all or all the states that are impacted have done this and gotten vaccine to our local health departments to target those farm workers. And as you noted already, the messaging is we have to be very careful with the messaging that this is to protect against seasonal flu. But yeah, all that work is going on.
Thank you, Dr. Hahn.
Dr. Ward? I'm sorry, Dr. Ward. Could I just make a clarification to one of the answers I gave? And it's about the ferret studies. While I don't have the genetic sequence information at hand, I think I want to reinforce one of the points I made about the Texas and the Michigan viruses. So the Michigan human virus, we think better represents circulating viruses compared to the Texas virus. The Texas virus was detected very early in the outbreak, and based on our analysis of human viruses over the course of this, it appears that virus was more of an outlier. And so the viruses circulating now appear to be more consistent with the Michigan human virus.
Thank you. Dr. Camboge?
Sorry to ask another question on ferrets, but is there ferret challenge studies that are ongoing with the candidate virus vaccines?
I'm sorry, could you repeat that?
So pathogenicity studies with ferrets, challenging them with either the Texas or the Michigan strain in vaccinated ferrets with the candidate virus vaccines.
So we do have other ferret studies ongoing, and I think there are a lot of studies that I think could shed more light on that. So we are exploring all options to further look at this model at the ferret model. So I think that's what I can say at this point.
Dr. Chu.
Okay, I'm just going to ask one more question. There are currently rapid home flu tests that are available under, I believe, FDA EUA, the iHealth flu COVID. Do you know if those detect H5?
So the over-the-counter, the tests that you're talking about, if they detect influenza A, they should be able to detect influenza A H5N1.
Okay.
But those any results I think need to be sent to a lab that can do the subtyping, and if preliminary positive, sent to CDC for confirmatory testing. So the diagnostics should be able to detect influenza A virus, yes.
Is there a plan to scale up availability of these types of tests in these communities, these farm worker communities, potentially?
So we have programs to work with industry and government partners to explore expanding and scaling up testing capacity should that need arise. That work is ongoing, yes.
Okay, thank you.
A couple last questions from the committee. Dr. Maldonado?
Yeah, thank you, Dr. Shimabukuro. You didn't mention it at this meeting, but I recall that the transmission from cows to cats involved drinking raw milk. And I wonder if there is additional messaging around or information around that. So, for example, are there data around viral load in unpasteurized milk? My understanding is that pasteurization reduces or eliminates virus from milk, and is that something that is being messaged to individuals across public health agencies to avoid drinking raw milk? I mean, obviously this is a very low risk situation, but it's yet one more reason to avoid raw milk.
So CDC's recommendation is that people should not drink unpasteurized milk or raw milk. As far as the safety of the milk supply, I mean that's the FDA regulates milk. So if there's an FDA liaison here, I'd be happy to turn that over to them. But the pasteurization process, I think all the data point to the pasteurization process resulting in a safe commercial milk supply.
Okay, seeing no more questions, I think we'll proceed with the agenda and move on to Dr. Santoli for the, Dr. Daskalakis.
I do not work for the FDA, but I think I'm able to say, after thorough investigation of pasteurization, even down to actually creating a pasteurization setup that replicates real-world pasteurization in a BSL-3 environment, pasteurization has high effectiveness in addressing H5N1. Notably, I think CDC have put out pretty clear guidance around raw milk. FDA has also further magnified, again, the same guidance that existed before H5N1, which is that raw milk should not be consumed given the risk of multiple pathogens. But thank you for bringing that up, really important point.
Thank you, Dr. Daskalakis. Now we'll proceed with Dr. Santoli's presentation on the VFC resolution. Dr. Santoli.
Thank you. Next slide, please. Just as a note, the orange font or highlight in the presentation is where the changes are. There are not many changes. I just wanted to make them easy to spot. Next slide. So the purpose of the resolution, as was mentioned earlier, is to update the inactivated influenza vaccine component of the resolution to add options for the vaccination of 18-year-olds who are solid organ transplant recipients, and to update links in the contraindication and precautions sections of both of the components of the resolution. Next slide. This is the inactivated influenza vaccine component. There are no changes to the eligible groups. Next slide. There are no changes to the recommended vaccine schedule and dosage intervals. Next slide. You do see that there are two products added to this particular table, Fluzone high-dose vaccine and Fluad, which are indicated for persons 65 years and older, but also for younger, as noted in footnote 2, which we'll see on the next slide. And so footnote 2 has been added to the table. Persons aged 18 years should receive an age-appropriate influenza vaccine, i.e. one approved for their age, with the exception that solid organ transplant recipients on immunosuppressive medication regimens may receive high-dose inactivated influenza vaccine or adjuvanted inactivated influenza vaccine as acceptable options without a preference over age-appropriate IIVs. Next slide. There's no changes to the dosage, contraindications, and precautions on this slide, although on the next slide, there is an update to the link for additional details about contraindications and precautions. Next slide. In the live attenuated influenza vaccine component, there are no changes to the eligible groups. Next slide. No changes to the recommended vaccine schedule and dosage intervals. Next slide. There are updates for the dosage to be consistent with the way this is depicted in the inactivated influenza vaccine component of the resolution. And then secondly, an update to the link for the contraindications and precautions. Next slide. This statement remains unchanged. That's all. Thank you.
Are there questions for Dr. Santoli? Dr. Minoche?
Just wanted to make a comment that there's emerging evidence that merits consideration of the high-dose flu vaccine beyond solid organ transplant, especially hematopoietic stem cell transplant recipients. Would really appreciate the work group's consideration on that.
Dr. Brooks?
Yes. Was there any consideration of making it a should recommendation for the solid organ transplant and the high dose or adjuvanted versus may?
If that was a question, I'm sorry, I didn't actually hear the question.
Oh,
Could you say that again? I'm sorry.
The recommendation was children 2 to 18 with solid organ transplant may receive high-dose or adjuvanted versus should receive.
Right, and that's reflected, could we go back to that? This was reflected as an option here without a preference. So shall we go back and make sure that the wording you think aligns?
Dr. Brooks, this VFC resolution is to align VFC with the vote the committee made in June. Right. And so there wasn't consideration for younger children, if that was the question.
Thank you.
We are going to need a motion for this. Can we get the motion language up?
Dr. Santoli, I might be missing it, but is there a recommendation for recombinant RIV for 18-year-olds? I didn't see that on the list that you had there.
It was not, it was never included in the VFC program, that particular vaccine.
Am I missing a reason why?
At the time that that was licensed, it just wasn't brought forward as something to include in the VFC program. And so it was not. It's sometimes challenging to manage a vaccine that's only for one age group, one age cohort in the VFC program. And so it wasn't brought forward, and so we have not pursued that.
Thank you. I would like to make, this is Dr. Lair, I'd like to make a motion to approve the VFC resolution for vaccines to prevent influenza. Thank you.
Thank you, Dr. Lair. Do we have a second? Dr. Sineas?
I second the motion.
And I'm sorry, Dr. Brooks, did you have a question? Okay. So we've got a motion and a second for the VFC resolution. Are there any additional questions, comments, or discussion? Well, seeing none, I think we can bring the influenza session to a close. Thank you very much, Dr. Lair and the work group, and Dr. Groskopf and the other speakers. And we will move on to the chikungunya vaccine session.
Yes, so thank you, and we'll move then to the chikungunya vaccine. And can I have the first slide, please? So as background, the chikungunya vaccine working group was formed in May of 2022. Since then, the two vaccines are one licensed and other available. The live attenuated vaccine was licensed in November of 2023. This is manufactured by Valneva, and the virus-like particle vaccine manufactured by Bavarian Nordic has submitted its file to FDA for licensure. Some recommendations are under development, and others have been developed for the use of chik vaccines among U.S. persons at risk of chikungunya, including travelers, laboratory workers, and the residents of U.S. territories and states with risk of transmission. And today, just a recap from the working group to the ACIP members. In October 2022 to 23, we reviewed the chikungunya disease and its sequelae, also the epidemiology at the global level, as well as to U.S. travelers and laboratory workers, and the evidence behind the live attenuated chikungunya vaccine, including its immunogenicity, safety, and other topics. In February 2024, the ACIP approved the recommendations for the use of the live attenuated chikungunya vaccine among U.S. travelers and laboratory workers. And in June, the ACIP was presented with the epidemiology of chikungunya in the U.S. territories and states and the cost-effectiveness of the use of the live attenuated chikungunya vaccine among adults living in the U.S. territories. Today, we're going to have an update on chikungunya and chikungunya vaccines. We We'll review also the virus-like particle chikungunya vaccine data to date and the work group interpretation of chikungunya virus-like particle vaccine data. I want to thank the chikungunya vaccine work group, especially my colleague Lin Chen, as well as the tremendous work that the CDC lead, Susan Hills, has done, and the many contributions of the ex officio liaisons, as well as the consultants that we have had for the group, as well as other collaborators for the working group. And with that, I'll give Susan Hill the floor.
Thank you very much, Dr. Asturias. Dr. Hill?
So thank you, Dr. Wharton and Dr. Asturias. So as an introduction to today's session, I'd like to provide a brief overview of chikungunya and discuss the status of chikungunya vaccines. Chikungunya is a mosquito-borne disease, and the key vectors that spread the virus to humans are Aedes aegypti and Aedes albopictus mosquitoes. The virus is typically transmitted in tropical and subtropical regions, and there are about 120 countries and territories globally where transmission has ever been documented. A key feature of this virus is that it periodically causes large and explosive outbreaks, often with very high attack rates. Clinical illness is characterised by fever and joint pain, which is typically severe and can be debilitating. Other symptoms can include headache, rash, myalgia, and anorexia. In the absence of specific antiviral treatment, the approach to management is supportive and typically involves rest, fluids, and use of analgesics and antipyretics. Serious complications are rare, but can include myocarditis, hepatitis, and neurologic illnesses, such as Guillain-Barré syndrome and meningoencephalitis. Deaths are also rare and are reported mostly in older adults, particularly those with comorbidities, and young infants infected perinatally or by mosquito bites. Acute symptoms of chikungunya usually resolve in about 7 to 10 days. However, some patients have a continuation or relapse of their joint symptoms in the months after acute illness and experience other symptoms such as fatigue. Studies have reported variable proportions of patients with persistent symptoms, but ongoing arthralgia of variable severity might be present in up to about half of patients at 3 months and up to about 30% at 12 months after infection. Chikungunya is a reportable disease in the United States, and among US travellers, approximately 100 to 200 cases of chikungunya are reported annually, although there is likely substantial underdiagnosis and underreporting. Infections are most commonly acquired in Asia and the Americas, with specific locations of acquisition influenced by local transmission patterns which vary from year to year. Unquestionably, the greatest risk for US travellers for acquiring chikungunya is travelling to an area with an outbreak. The status of chikungunya vaccines in the United States is that there is currently one licensed vaccine and one that has been submitted to FDA for licensure, as you heard from Dr. Asturias. The licensed vaccine is a live attenuated vaccine manufactured by Valneva as IXCHIQ. It was licensed in November 2023 and is currently approved for use in adults aged 18 years and older. The vaccine has a single dose schedule. Recommendations for use of this vaccine in adult travellers were approved by ACIP in February 2024. The recommendations note that ACIP recommends the live attenuated chikungunya vaccine for persons aged 18 years and older travelling to a country or territory where there is a chikungunya outbreak. In addition, the vaccine may be considered for certain persons travelling to a country or territory without an outbreak, but with evidence of chikungunya virus transmission among humans within the last 5 years. The groups include persons older than 65, particularly those with underlying medical conditions who are likely to have at least moderate exposure to mosquitoes, or persons staying for a cumulative period of 6 months or more. In addition, recommendations for use among laboratory workers were also approved in February, and they note that ACIP recommends live attenuated chikungunya vaccine for laboratory workers with potential for exposure to chikungunya virus. Recent updates on the live attenuated vaccine include that for adolescents aged 12 to 17 years, Valneva plans a submission to FDA this year, which, if ultimately approved, would allow use in this age group. For children aged 1 to 11 years, a clinical trial began in December 2023. Finally, monitoring the vaccination cohort from the pivotal clinical trial in adults 18 years and older is continuing to investigate persistence of seroresponse following the single dose of the vaccine. At 2 years, a high seroresponse rate of 97% was maintained, and monitoring will continue through 10 years to determine if a booster dose will be needed in future. The second chikungunya vaccine, and the one the session will focus on today, is a virus-like particle vaccine. The vaccine is manufactured by Bavarian Nordic. Licensure of this vaccine is possible in February 2025. The intended age group for licensure is adolescents and adults aged 12 years and older, and the vaccine has a single-dose primary schedule. As with the live attenuated vaccine, the virus-like particle vaccine will be licensed through the accelerated approval pathway. This is because traditional approval would have been challenging and clinical development would likely have been delayed if this approach had been required. It would have been difficult to conduct a randomised controlled field efficacy trial with a disease endpoint because chikungunya outbreaks are unpredictable and their duration can be relatively short. In addition, there is no established immunologic correlate of protection. As a result, the accelerated approval pathway was endorsed for licensure of chikungunya vaccines at an FDA VRBPAC meeting in 2019. FDA can grant accelerated approval for products that are for serious conditions and that fill an unmet medical need. With the accelerated approval pathway, demonstration of effectiveness is based on controlled clinical trials, showing the vaccine has an effect on a surrogate endpoint that is reasonably likely to predict clinical benefit. For the virus-like particle vaccine, the marker of protection was based on a neutralising antibody titer estimated from a validated non-human primate model. And Dr. Jenkins will be discussing this marker further in the next presentation. With this approval pathway, there is a post-licensure requirement for controlled trials to confirm the clinical benefit. The ACIP Chikungunya Vaccines Work Group has 4 population groups for whom vaccine recommendations are being considered. These include travellers, laboratory workers, residents of US territories with risk of chikungunya virus transmission, and residents of US states with risk of transmission. For the live attenuated vaccine, ACIP has approved recommendations for use among travellers aged 18 years and older and among laboratory workers. The work group is currently considering policy options to present to ACIP for use of the vaccine among residents of US territories and states with risk of transmission. For the virus-like particle vaccine, policy options for use of the vaccine among all 4 groups are under consideration, and recommendations will be presented for ACIP's consideration at future meetings. Thank you, and I'll hand back to Dr. Talbot or Dr. Wharton.
Thank you, Dr. Hills. Are there questions for Dr. Hills? I think we can proceed to the presentation from Bavarian Nordic. Dr. Jenkins, are you on?
Yes, I am.
Okay, you can proceed.
Okay. I'm unable to share my screen. Okay. Okay, perfect. Thank you. I hope you can hear me well and you can see my screen.
Yes, we can. Thank you.
Okay, so thank you very much. My name is Victoria Jenkins, and I'm here today to present on behalf of my colleagues at Bavarian Nordic the data on our candidate chikungunya vaccine, CHIKV VLP vaccine. Next slide, please. Okay, good. So the CHIKV VLP vaccine is a virus-like particle vaccine and is comprised of 3 recombinant structural proteins that assemble into virus-like particles. These VLPs mimic the chikungunya virus but cannot replicate in the host. The vaccine is adjuvanted with aluminum hydroxide, and it's provided in a 40 microgram VLP dose in a pre-filled syringe and administered intramuscularly. Priority review was granted by the FDA, and the dossier has a PDUFA target action date of the 14th of February 2025. And we have the proposed indication of prevention of disease caused by chikungunya virus infection in individuals 12 years of age and older, with proposed contraindications of hypersensitivity, including severe allergic reaction to any component of the vaccine. And it was agreed with the regulators to use a defined threshold of serum neutralizing antibodies as a surrogate endpoint of efficacy in phase 3 trials, and I'll discuss this in more detail on the following slide. So the assay used in the phase 2 and phase 3 studies was a luciferase reporter assay, and this was based on the CHIK 18125 strain, which is of the Asian lineage, and was engineered to express the luciferase transgene. The assay and data reported in this presentation are based on an 80% reduction in luciferase activity, which results in an NT80 value. And of note, the assay itself measures cross-neutralization, as the vaccine is heterologous to the assay strain, with the vaccine strain being of the West African lineage and the assay strain originating from the Asian lineage. So as mentioned by Dr. Hills, the phase 3 clinical studies used a surrogate marker of protection, which was a conservative NT80 titer of 100. This was based on data from a non-human primate passive transfer study where non-human primates received pool sera at various antibody concentrations from human participants vaccinated with the CHIKV VLP vaccine. These non-human primates were then challenged 24 hours later with the chikungunya virus. The graph on the left-hand side shows the probability of protection against viremia at different antibody titers. On the y-axis, 0 represents non-human primates where viremia was detected, and 1 represents non-human primates that have protection against viremia, with the pre-challenge serum neutralizing antibody titers on the x-axis. With this data, a logistic regression model was applied, which demonstrated that a serum neutralizing antibody titer of 50 resulted in a 99.97% probability of protection against viremia. This was then discussed and agreed with the regulatory agencies to use the conservative serum neutralizing antibody titer of 100 as an acceptable surrogate endpoint in the phase 3 studies. So this is an overview of the clinical program of the CHIKV VLP vaccine that's been submitted as part of the BLA, which included 3 phase 2 studies and 2 phase 3 studies, which were all conducted in the US. The first phase 2 study was a dose and schedule finding study, and I'll discuss this in more detail on the following slides. Then there was an immunogenicity and safety and tolerability study of the selected 40 microgram dose. And we did a third phase 2 study, which was an immunogenicity and safety study in prior alpha virus vaccine recipients. Then there was 2 parallel phase 3 studies, which were placebo-controlled, which looked at the immunogenicity, safety, and tolerability of the vaccine. So this is our phase 2 dose and schedule finding study that was conducted in healthy participants aged 18 to 45 years of age in the US. And this graph displays the GMT titers of various vaccine concentrations over time. As a control, we had the 20 microgram unadjuvanted group that received 2 doses of the CHIKV VLP vaccine on day 1 and day 29. We then had a second group that received 2 doses of the 20 microgram adjuvanted vaccine on day 1 and day 29. And the final group was a single 40 microgram adjuvanted dose on day 29. The results from the study demonstrated that a higher antibody titers were observed after the first dose with the adjuvanted vaccine versus the unadjuvanted group. And the 40 microgram single dose had a higher GMTs at all time points for the duration of the study than the other two groups. And thus, for the ease of implementation of a single dose vaccine and the superior durability of the vaccine over the 2-year study, the 40 microgram dose was selected for further development. In addition, this study also looked at the immunogenicity and safety of a booster dose of the vaccine. Now, I'd like to point out at this point in time, it's unknown if a booster dose is required or not, and at all time points, the average GMTs were above 100, the threshold agreed with the regulatory agencies. However, a single 40 microgram vaccine dose given as a booster 1.5 years after the initial vaccination did provide a boost in the immune response. As I've just mentioned, there were 2 phase 3 studies which were completed in parallel for the CHIKV VLP vaccine. These were both placebo-controlled and conducted in the US. The first was in adolescents and adults less than 65 years of age, with 2,790 participants in the vaccine group. The second study was in older adults greater than or equal to 65 years of age, and 206 participants were in the vaccine group. The primary and key secondary endpoints were similar between the 2 studies. Both had co-primary endpoints of superiority of GMTs at day 22 versus placebo, difference in the seroresponse rate at day 22 versus placebo, and safety. In addition, the adolescent and adult study had a lot consistency endpoint in a subgroup of the population. Key secondary endpoints for the 2 studies included the difference in seroresponse rates at day 15 and day 183 versus placebo, and the adolescent and adult study had an additional time point of day 8. This is an overview of the demographics in the adult and adolescent study, which was balanced between the vaccine and the placebo groups. The average age of the participants in this study was 39 years of age, with 254 participants, 254 adolescents enrolled. And the demographics were fairly representative of the US population. This slide provides an overview of the demographics in the older adult study, which was again balanced between the vaccine and placebo groups. The average age of participants in this study was 71 years of age, with 23% of individuals greater than or equal to 75 years of age. So this slide shows the immunogenicity data in the adult and adolescent study. The graph on the left-hand side displays the seroresponse rate, which is the percentage of individuals who had a titer greater than or equal to 100, which was the defined surrogate marker of protection in this study. And the graph on the right-hand side shows the GMTs, with a value of 7.5 being the lower limit of quantification for the assay. And the vaccine group are in orange and the placebo group are in blue on both graphs. Looking at the seroresponse rate, there was a rapid immune response to the vaccine, with a seroresponse rate of 47% in the vaccinated group as early as day 8, which increased by day 15 to 97%, and at day 22, which was the primary endpoint of the study, 98% of individuals had a titer greater than or equal to the threshold. The response was durable over the study, with 86% of individuals above the threshold at day 183. For this study, all co-primary and secondary endpoints were met. So this slide gives an overview of the data in the older adult study. So this is in individuals greater than or equal to 65 years of age. And again, the seroresponse rate is on the left-hand side and the GMTs are on the graph on the right-hand side. A rapid immune response was again observed in this study, with 82% of individuals at day 15 having a titer greater than or equal to the threshold of 100. And by day 22, which was again the primary endpoint for this study, 87% of individuals had a titer greater than or equal to the threshold. The response was durable, with 76% of individuals above the threshold at day 183. And again, for this study, all co-primary and secondary endpoints were met. Moving to the reactogenicity data from the phase 3 studies, the CHIKV VLP vaccine was well tolerated, and this data is in the adult and adolescent study. With solicited adverse events in this study similar between the vaccine and placebo group, except injection site pain and myalgia, which were higher in the vaccine group. The most commonly reported solicited adverse events was injection site pain, and the most common reported systemic solicited adverse events were fatigue, headache, and myalgia. The incidence of grade 3 adverse events were low, with local solicited grade 3 events occurring in 0.2% of the CHIKV VLP vaccine recipients, and systemic solicited grade 3 events occurring in 1.5% of the vaccine recipients and 0.4% of the placebo recipients. Again, this is data from the adult and adolescent study. Unsolicited adverse events were slightly higher in the vaccine group, and one participant in the CHIKV VLP group had a severe grade 3 treatment-related unsolicited adverse event of dehydration, which resolved without medical intervention. Treatment-related adverse events of special interest, which were defined as the new onset or worsening of arthralgia that was medically attended adverse events, and serious adverse events were even between the vaccine and the placebo group. There was one investigator-assessed, possibly related serious adverse event of retinal detachment in the CHIKV VLP vaccine group. However, this was assessed by the sponsor and independent safety committee chair as unrelated and due to a prior medical history of seeing black spots in the right eye, which was the same eye as the retinal detachment 1 month pre-study. So this slide presents the solicited adverse events in individuals greater than or equal to 65 years of age. And again, in this study, the vaccine was well tolerated, with events similar between the vaccine and placebo groups, with the exception of injection site pain. Most events were of grade 1 or grade 2 in severity, except for one participant in the vaccine group who experienced 2 grade 3 systemic solicited adverse events of headache and fatigue, and no participants experienced a grade 3 local solicited adverse event. Unsolicited adverse events of special interest, medically attended adverse events, and serious adverse events were evenly distributed between the vaccine and the placebo group. Unsolicited adverse events which were considered treatment-related, fatigue and myalgia were the only treatment-related events that occurred in more than one participant. Fatigue occurred in one of the vaccine recipients and in 2 placebo recipients, and myalgia occurred in 1 participant per treatment group. And there were no related serious adverse events which were considered treatment-related in this study. So this slide provides an overview from the integrated summary of safety, which includes data from 3,141 individuals across the phase 2 and phase 3 studies who received 40 microgram dose of the CHIKV VLP vaccine. Across the studies, there were no related serious adverse events as determined by the sponsor or safety committee chair. Grade 3 events of arthralgia were similar between the vaccine and placebo groups at approximately 0.2%, and there were no cases of related arthritis or related osteoarthritis across the studies. So in summary, the CHIKV VLP vaccine is a single-dose vaccine in a pre-filled syringe based on the virus-like particle technology. We have a PDUFA target action date of the 14th of February 2025, and the proposed indication is for the prevention of disease caused by Chikungunya virus infection in individuals 12 years of age and older. Phase 3 studies demonstrated a rapid and robust immune response in individuals 12 years of age and older, and the response was boostable and durable for up to 2 years in a subset of the study population in a phase 2 study. The vaccine was well tolerated, with no treatment-related serious adverse events as determined by the sponsor, and most solicited and unsolicited adverse events were mild or moderate in intensity. So I thank you for your attention, and I will hand it back to the chair.
Thank you very much, Dr. Jenkins. Are there any questions? Dr. Sineas.
Thank you for that presentation. Did the studies include patients with chronic medical conditions and immunocompromising conditions?
No, they were excluded from the phase 3 studies. This was in healthy participants. But we do have a phase 3B confirmatory efficacy study where certain groups of immunocompromised, people with immunocompromising conditions that are stable will not be excluded from the study.
Thank you. Are there additional questions from the committee? So I will turn things back over to Dr. Hills.
If I can have my slides, please. Thank you. So the work group has conducted a preliminary review of the data for the virus-like particle chikungunya vaccine, and today I'd like to provide a brief summary of the work group's initial conclusions. In regards to vaccine effectiveness, the work group noted there are no vaccine effectiveness data available, so results are based on immunogenicity data. Short-term immunogenicity data reflecting seroresponse rates at 3 weeks after vaccination are available from about 2,750 vaccinated subjects in 2 phase 3 studies. The majority of these data are from adults aged 18 to 64 years, with smaller numbers of adolescents and older adults with data, with about 200 subjects with data in each of these age groups. The work group noted there was a robust response to vaccination, with seroresponse rates at 21 days after vaccination of 98% in adolescents and younger adults and 87% in the older adults, and that relatively good seroresponse rates were maintained at 6 months after vaccination, with seroresponse rates of 86% and 76% in the younger and older age groups respectively. We noted that longer-term data on the seroresponse rate beyond 6 months after vaccination are not yet available from phase 3 studies, so the need for a booster dose is unknown. In regards to safety, data are available from about 3,000 vaccinated subjects in 2 phase 3 trials. Again, the majority of these data from adults aged 18 to 64 years, with smaller numbers of adolescents and older adults, with about 210 subjects with data in each of these age groups. Based on the available data, the work group noted the overall safety profile of the vaccine was acceptable. Among adolescents and adults aged 12 to 64 years, solicited adverse events were assessed for 8 days after vaccination, and local events were reported by 24% of subjects overall, with 0.2% of these events being graded as severe. The reported events were mostly injection site pain. Solicited systemic adverse events were reported by 32% of subjects, with severe events in fewer than 2% of subjects. The most frequent events were fatigue, headache, and myalgia, which were all reported by 18 to 20% of vaccinated persons. Arthralgia is a key feature of chikungunya disease, but there was no concerning signal with arthralgia after vaccination. New onset or worsening arthralgia requiring medical attention occurred in 0.2% of vaccinated persons and at the same rate in the placebo group. And there was one serious adverse event, which you heard about from Dr. Jenkins earlier, which was a retinal detachment assessed as related by a study investigator, but as unrelated by the chair of the Safety Monitoring Committee. The results I've summarised here are for adolescents and adults aged 12 to 64 years, and for older adults aged 65 years and older, all adverse event rates were lower. Overall, the workgroup determined that the chikungunya virus-like particle vaccine will provide an additional effective and safe option, in addition to the licensed live attenuated chikungunya vaccine, for vaccination of adults aged 18 years and older, and will provide a new option for vaccination of adolescents aged 12 to 17 years, as the currently available chikungunya vaccine is not yet licensed for this age group. We noted the vaccine is immunogenic, but no vaccine effectiveness data are available, and these will be gathered post-licensure, and no longer-term data from phase 3 studies are available yet, so the need for a booster dose is currently unknown. There are no apparent safety concerns, but safety data are only available in phase 3 trials from about 3,000 people, which is an insufficient number of people to detect rare adverse events. And post-marketing safety surveillance will be important to monitor for any such events. Finally, the workgroup plans to conduct a more comprehensive review of immunogenicity and safety data and summarise findings in the grade assessment, which we presented as part of the evidence to recommendations framework at a future ACIP meeting. To finish, I'd like to outline for ACIP members the chikungunya vaccines workgroup plans for the next 12 months. During 2025, the workgroup anticipates presenting recommendations for ACIP's consideration and asking for votes on vaccine recommendations in various groups. These include use of the live attenuated vaccine among travellers aged 12 to 17 years, use of the virus-like particle vaccine among travellers aged 12 years and older, use of the virus-like particle vaccine among laboratory workers, use of both vaccines among persons in US territories at risk for transmission, and use of both vaccines among persons in US states at risk for transmission. And thank you, and I'll hand back to you, Dr. Wharton.
Thank you, Dr. Hills. Are there questions for Dr. Hills?
Rob Schechter, thank you for the presentation. I think you mentioned in your opening remarks rare perinatal deaths, and I'm just wondering implications of prenatal vaccination and any short-term or long-term plans around the issue.
Right, so the question is about use of this vaccine in pregnancy. Yeah. So thanks for that question. The work group has started discussing that topic, but we are still in the midst of discussion, so we'll be able to provide that information at a future ACIP meeting. For the live attenuated vaccine, we did consider the use of the vaccine. One of our main recommendations is that pregnant women avoid travel to an area with chikungunya because of the concern for transmission during the intrapartum period. If that is unavoidable, then that vaccine we suggested should be a precaution for use with preferably avoidance during the first trimester and after 36 weeks. So they're the current recommendations for the licensed vaccine, and we can get back on the VLP vaccine in our discussions.
Dr. Chu? I had a very similar question. It was around pregnancy. Are there any DART studies from this most recent product? Because I imagine pregnant persons will want to receive an DART development and reproductive toxicity studies, pre-licensure studies from this VLP candidate.
There are animal data, is that what you're referring to? Yes, and I can hand over to, I can ask Dr. Jenkins to respond on that.
Yes, we do have DART data available, and I wonder if my colleague Lo, because he knows more about this data than I do, could actually take this question.
Can you guys hear me?
Yeah. We can, though.
Okay.
Thanks.
Yeah, so we do have DART studies that were conducted in both rabbits and rats, and both showed that the vaccine's safe. There were no minor observations or minor concerns with those two DART studies that were conducted.
Dr. Maldonado?
Yeah, thank you. Along the lines of just talking about prenatal vaccinations or for pregnant people, is the work group starting to consider whether they're going to make preferential recommendations, or are they considering making blanket recommendations for both vaccines, or does that depend on the effectiveness data that will be coming forward? And then finally, will the work group be continuing to follow surveillance for strains circulating in the Western Hemisphere, given that the risk groups, the risk areas will probably can change over time given the sporadic nature of the virus? Thanks.
So I think the first question was about a preferential recommendation. It's difficult with these vaccines, and we are considering each of them independently. They were, so for both immunogenicity and safety, there are differences in these vaccines. So with immunogenicity, there's a different assay used with a different marker of protection. So those comparisons are difficult. For safety, we have we've got no more safety data than 4,000 people, which is very hard to make those comparisons. So we are looking very closely at all the data. It's very hard with, for example, with safety for those few data to make any definitive considerations. So essentially we're looking at both of these vaccines independently as we consider recommendations. Sorry, it's hard to hear, but I think the second question was, are we monitoring?
Yeah, it was around a working group tracking surveillance across the Western Hemisphere, given the changing patterns of outbreaks around in the region.
Yeah, so the data from both vaccines suggests that they will protect against the various strains, but we will certainly, as things move ahead and the vaccine is used in more people in a wider population of the US population, be looking for any evidence of vaccine failure. But at this stage from the Valneva vaccine, we've had no reports of vaccine failure, but of course it's in the very early stages.
Dr. Asturias?
Yeah, thank you, Edwin Asturias. So I'm going to reiterate what Susan said. I think we're going to have to be careful about considering these vaccines independently, just because the surrogates of protection are different between the two. And one is a plaque neutralization assay, the other is the luciferase assay. So really it's very difficult to compare, and I invite the ACIP members to think that way. It's very encouraging to have two vaccines against Chik, though. This is great, especially now that in 2024 we have had close 500,000 cases, especially in the Americas, and close to 150 deaths. And so this is getting closer, and important to have these options. Thank you.
Thank you, Dr. Asturias. Are there other questions or comments from committee members? So seeing none, Dr. Talbot, shall we recess till 12:30?
Yes.
So we'll take a break until 12:30. Thank you all very much, and we'll see you back in half an hour.
Testing 1, 2, test. Testing 1, 2. Check, testing 1, 2, 3, testing 1, 2, 3. Okay, you got that one.
I don't know. Testing 1, 2, testing 1, 2, testing 1, 2, test, 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 test.
A microphone right now. Check 1, 2, 3. Okay.
What's going on with audio?
Check 1, 2.
Testing 1, 2, testing 1, 2.
I'm hearing the audio checks.
Test 1, 2, 3. Check 1.
Testing 1, 2. We good? Good. Let's see.
Welcome back, everyone. We'd like to start the afternoon session. I'm going to try to speak for a little while, and when it gives out, Dr. Wharton has volunteered to step in. So we are going to start off with COVID vaccines, and Dr. Schechter, if you'd like to open up the session.
Thank you, Dr. Talbot, and good afternoon. On behalf of the work group, next slide, please. I'd like to start by reviewing our current 2024-2025 COVID-19 vaccine recommendations. At its June 2024 meeting, at our last meeting, the committee recommended the use of 2024-2025 COVID-19 vaccines as authorized or approved by FDA. The recommendations included everyone 5 years and older should get 1 dose of 2024-25 vaccine, while children 6 months to 4 years need multiple doses of any COVID-19 vaccine, including at least 1 dose of a 2024-2025 vaccine. Currently, people who are moderately or severely immune compromised may receive additional doses of 2024-2025 vaccines, but there was no recommendation at the time for additional doses for older adults. Next slide, please. Today's review and discussion will focus on these last two bullets, that is the use of the current vaccines in immune-compromised and older adults. Next slide, please. Since the June meeting, the work group has met many times, covering a variety of topics, including the seasonality of SARS-CoV-2, epidemiology of COVID-19 in older adults and persons with immune compromise, vaccine effectiveness of additional doses, vaccine safety, additional dose uptake and intent, SARS-CoV-2 variants, economic analyses, and implementation of additional doses. Next slide, please. The presentations today will cover vaccine uptake and implementation, epidemiology, vaccine effectiveness, economic analysis, leading into the ETR and clinical considerations discussion. Next slide, please. I'd like to thank our tremendous co-leads, Dr. Panayotopoulos and Lauren Roper, the ACIP members, and the extensive membership, including ex officio government members, liaisons, and consultants. And I want to also thank, next slide, the tremendous support from the dozens of CDC participants who continue to be so responsive and helpful as we carry out our work. And I will pass it back to you. Thank you.
Dr. Peacock.
Okay, thanks. I'm Georgina Peacock. I'm from the Immunization Services Division. And before I get started on the implementation considerations for additional doses of COVID vaccine, just wanted to give you the latest numbers on vaccine coverage for this season that we posted today on the web. So for children, it's 3.7% compared with 3.1% last year at this time. For adults 18 and over, it's 11.7% compared to 6.8% at the same time last year. And for 75 plus, it is 30.6% compared to 17.7% last season. So now I can have the next slide. And what I'm first going to do is I'm going to show you some information about coverage and intent for 2 doses based on last season, both for adults over 65 and also immunocompromised, and then talk about some of the implementation considerations. Next slide, and then the next slide. So this shows you COVID vaccination coverage for 1 and 2 doses for age 65 last season, so from September 2023 to June 2024. There are approximately 40% vaccine coverage for 1 dose and 8.9% for 2-dose coverage. And this is from the National Immunization Survey. Next slide. If you look at more details on this for the two doses or greater than or equal to 2 doses of COVID vaccine for the 2023-24 vaccine ending June of 2024, overall, we saw the 8.9% coverage for those over 65. And you can see here when you look at some of the details, we have greater coverage in urban versus rural for that second dose. And then there are definitely differences geographically if you look at those HHS regions. Next slide. With more details, you'll see that for those adults over 65 related to having 2 doses by the end of June 2024, there's minimal differences when we look at the social vulnerability index. It's greater in those over 65 who have a health condition and also those who are immunocompromised or those who have a disability. Also of note, and I know this is well known to this group, but a healthcare provider recommendation was a significant predictor of getting a second dose. Next slide. In those that were surveyed between April and June of 2024, this group of over 65-year-olds, 36.8% had received one dose, and in those that had received one dose, 20% of those that had received the first dose received a second dose. And then if you want to look at intent, another 44% said that they would definitely get a second dose. 30% were said probably or were unsure, and about 5% will not get another dose. And so this is all information from last season, but hopefully gives you information to think about this season. Next slide. And then when we look further into the vaccine coverage and intent among adults who had received one dose, and we're looking at receipt or intent to receive a second dose, that trends up with age, with it being greatest at the age over 80 years old. There is a trend towards greater intent with urban versus rural, and then you can see that there are some differences with racial and ethnic groups. Next slide. And then this just shows you, as we went through the survey month, obviously you're seeing an increase in the numbers who, a modest increase in the numbers who are being vaccinated, and seeing that intent is also still increasing from April to July. Next slide. So now I'm going to switch gears and talk about immunocompromised. So second dose coverage among adults 18 and over who are immunocompromised. Next slide. And so this first slide shows you the data that I showed before, so the vaccine coverage of the second dose among adults 65 and older at 8.9%, and then we look at adults 18 years and older who are immunocompromised with a coverage of the second dose of 5.4%. Again, these data are all from the National Immunization Survey. Next slide. When we go into further details, again, the overall for the 18 plus who are immunocompromised is at 5.4%. You'll see that that also changes with age. So if we look at people that are immunocompromised and are also over age 65, that percentage is the highest at 13.5%. And in this case, when we look at individuals who are immunocompromised, the vaccine coverage that is highest when we're looking at urban, rural, and suburban is in the suburban areas. There are, again, racial and ethnic differences, and wanted to underscore yet again that a healthcare provider recommendation makes a significant difference. And also in this case, when we look at those that are immunocompromised, there was a significant difference between those that are insured or uninsured, with those that are insured being more likely to have a second dose. Next slide. And then the next one. So these are data from a different data source. So this is an omnibus survey that is collected, and we collect this in 2 waves each month. So the month sample accounts for responses from about 4,000 people. Next slide. So this omnibus survey looked at intent to receive a second dose, and this is now asking about this season. So an intent to receive a second dose of 2024-25 COVID-19 vaccination, if recommended, for those greater than 18 years of age with health conditions, or those over 65 years by age. And when we look at that, we see that about a third of this group definitely would get a second dose. The intention is higher among the age 65 group. And among those who definitely or probably would get the first dose, there's a little less than half that said that they would get a second dose, so that's in our greater than 65 group. And again, we see lower intent in those in rural areas and also among uninsured adults. Next slide. So to summarize, as of June 29, 2024, 8.9% of adults greater than 65 reported receipt of a second dose. And among those 65 and older who got the first dose, 20% got a second dose. Based on the omnibus surveys, about a third of those over 65 said that they would definitely get 2 doses. And then finally, when we look at the immunocompromised, so as of June of 2024, 5.4% of adults reported receiving 2 doses. And then a reminder that if you put those 2 groups together, so those that are immunocompromised and over the age of 65, that coverage was 13.5% last season. So switching now into, next slide, into implementation considerations, and then one more slide. The 2 policy questions being considered today: should an additional dose of 2024-25 COVID-19 vaccine be recommended for adults greater than 65 years? And should additional doses of 24-25 COVID-19 vaccine be recommended for people ages 6 months who are moderately or severely immunocompromised? And so I'm going to go into some of the considerations that might be necessary to think this through. Next slide. So first, these recommendations would not be overly burdensome to implement. An additional dose recommendation would be the same formula of the 24-25 COVID-19 vaccine that's currently available. There is existing administration infrastructure and product can be used, and the recommendation could easily be integrated into existing systems or structures, clinical decision support and standing orders and things like that. There are some minor challenges that would remain. For example, there is obviously a need for additional education, and additional recommendations may also exacerbate existing vaccine fatigue. We do know that practices tend to maybe not carry the vaccine the whole year. So some practices that are having low demand for the vaccine may not reorder once they deplete their fall supply. So those are some considerations that are there, and we just need education, I think, to make sure that if this recommendation were there, that we still have providers carrying vaccine. Next slide. This is just a reminder of the differences between kind of should and may considerations. Some of the, differences when that is seen. So the proposed policy options frame both additional dose recommendations for older adults and immunocompromised as a should recommendation as opposed to a may recommendation. And overall, this would simplify and harmonize the schedule. You can see some of the considerations for should versus may here on the screen. Generally, a may recommendation is more difficult to implement with the converse of those should benefits that you're seeing over on the other side. Next slide. When we look at intervals for vaccination, some of the recommended interval for vaccination is consistent with language used for other vaccines, so that would be familiar to healthcare providers. And the recommended interval is consistent with other recommendations for additional doses for age 65. This standardization of the interval for both 65 plus and immunocompromised populations would simplify the schedule complexity. And then the minimal interval for vaccination, a minimal interval of 2 months, allows for flexibility of vaccine administration when accounting for individual risk and circumstances. Next slide. I did want to share some data about where we see people getting vaccinated. So this is place of vaccination for 24-25 COVID-19 vaccination. And you'll see This is for adults aged 18 years and older from the National Immunization Survey, and you'll see the vast majority of people so far this season have received a vaccination in the pharmacy or of adults at 81.9%. Next slide. And then if you look at those that are 65 and older, that number is very similar at 82.8%. Next slide. So just some additional considerations that because of the consideration that the majority are getting doses within a pharmacy setting. The May recommendation can be particularly challenging in a pharmacy setting, given that there can be some challenges with operationalizing with pharmacists and in a pharmacy because the May consideration says that it needs to be informed by clinical judgment of a healthcare provider and personal preferences and circumstances, and this is interpreted differently in different pharmacy settings. The challenges reported from pharmacy organizations or pharmacists include that not all pharmacists feel this clinical judgment is within their scope of practice. There is some discomfort with having, in some cases, discomfort having patient conversations to make a vaccination decision. Not all pharmacists have a clear understanding of what moderately or severely immunocompromising conditions are, and there are, in some cases, concerns with adequate reimbursement based on the recommendation. Sometimes it's the reimbursement happens, but sometimes when you have a May, it may take longer, and that can cause hesitancy in giving these additional doses. Next slide. And that's really kind of what I describe here. So, and what can happen is there can be reports of people being denied vaccination when there are changes in guidance, and you know, a lot of this is these are things that can be kind of solved by education, and so we do have at CDC a dedicated work stream on healthcare provider engagement that is helping with this education, the education and communications on recommendations and the importance of self-attestation. So if you do have, you know, a health condition to disclose, or not disclose, but that makes you eligible for that second dose is something that's really important, and then working with a wide array of partnerships. Next slide. There are some vaccine equity considerations. We know that social determinants of health drive differences in vaccine access, creating disparities in uptake. Some of the additional dose recommendations may further increase these disparities. Of note, related to whether someone is insured or not insured, we don't have the Bridge Access Program anymore, so there's less availability of COVID vaccine for uninsured adults. We have made some vaccine available through our state immunization programs so that there is some availability of COVID vaccine for uninsured adults, but not in the breadth that we had during the Bridge Access Program. Disability, there is an increased prevalence of disability with age, and that creates potential challenges getting to vaccination sites. And then there can be decreased access within certain settings with existing challenges such as long-term care. And so those are the vaccine equity considerations, and I think go to the next slide. That's the end of my presentation. Thanks.
Thank you so much, Dr. Peacock. We'd like to open for questions or comments from the voting members. All right, I believe Dr. Swami wanted to make a comment from American College of Obstetrics and Gynecology.
Yeah, thanks, Dr. Talbot. It's good to hear your voice. So I'm just going to read a statement representing the American College of OBGYN. First, we'd like to thank the leadership of ACIP and the ACIP working group for their collaboration on this topic and for inviting us to be able to share a position and expert opinions regarding COVID-19 vaccine. ACOG remains extremely supportive of the COVID-19 vaccine for pregnant individuals. Data shows that the vaccine is safe, efficacious, and decreases the risk of severe disease and hospitalization rates in infants when administered to pregnant individuals. Maternal COVID-19 vaccination can help reduce the risk of transmitting the virus to the newborn during pregnancy, delivery, and breastfeeding. Given this data and the decreasing immunization rates, as we've seen, particularly among pregnant individuals, we feel that this vaccine should be prioritized and recommended. Finally, we continue to encourage the consideration of the OBGYN voice and look forward to collaborating with CDC and other organizations to ensure optimal implementation of strategies to decrease the burden of COVID-19 disease in infants in particular. Thanks so much.
Thank you. Any other comments or questions? All right, why don't we move to COVID-19 epidemiology? Dr. Taylor.
Thank you, Dr. Talbot. Good afternoon, everybody. We could advance to the, thank you. My name is Chris Taylor, and I'm with the ResMed Hospitalization Surveillance Team at CDC. And I'll be presenting COVID-19 associated hospitalization data focusing on adults 65 years of age and older, as well as persons with immunocompromising conditions. Next slide, please. So COVIDNet is a population-based surveillance system that collects data from more than 300 acute care hospitals in 98 counties across 13 states. The COVIDNet catchment area includes about 10% of the U.S. population. I will note that the data presented today will be limited to hospitalizations identified in 90 counties across 12 states due to incomplete data. Hospitalizations reported to COVIDNet include all those where a positive SARS-CoV-2 test result was reported within 14 days prior or during hospitalization. Testing for SARS-CoV-2 is driven by clinical judgment and facility policies, and data on rates and basic demographic data are collected on all patients, while the clinical data presented are collected from an age and site stratified random sample. Next slide. I will start by focusing on hospitalizations among adults 65 years of age and older. Next slide. So adults ages 65 years and older comprise 2/3 of all COVID-19 associated hospitalizations among all adults ages 18 years of age and older. This figure shows the percent of COVID-19 associated hospitalizations by age group by week from March 2020 through August 2024. Over time, the proportion of hospitalizations has shifted to older adults and has generally stabilized over the past year. For the period of October 2023 through September 2024, highlighted by the red box, adults ages 65 years and older comprise 70% of all COVID hospitalizations captured in COVIDNet, with adults 75 years and older comprising half of all COVID-19 associated hospitalizations. Not pictured in this figure, but during this same period of October 23 through September 24, I'll note that children and adolescents 17 years of age and younger comprised 4% of all COVID-19 associated hospitalizations. Next slide, please. This figure shows the weekly rates of COVID-19 associated hospitalizations among all age groups from the beginning of the pandemic, from March 2020 through September 2024. Week after week, rates of COVID-19 associated hospitalizations are highest among adults ages 75 years and older, indicated by the solid orange line. Next slide. Among adults, rates of COVID-19 associated hospitalizations increase with age. This figure shows cumulative rates of hospitalization by adult age group from October 2023 through September 2024. At 1,410 hospitalizations per 100,000 population, the population-based rate of COVID-19 associated hospitalizations among adults 75 years and older show that for this period, 1.4 COVID hospitalizations occurred for every 100 U.S. persons aged 75 years and older. The table on the right indicates the rate ratios relative to the 75+ year age group. Rates among adults 75 years and older are 3 times as high than adults ages 65 to 74, nearly 9 times as high as adults ages 50 to 64, and 24 times as high as adults ages 18 to 49 years. Next slide. This figure also shows cumulative rates of COVID-19 associated hospitalizations, but over several surveillance seasons. For COVIDNet, the surveillance seasons extend from October through September of the following year. The 1920 season is limited to March through September of 2020. The most recent 23-24 season, with data from October 2023 through September 2024, is shown in orange. For each age group, rates of COVID-19 associated hospitalizations have decreased over time. Even with those observed decreases, note that the 23-24 cumulative rates for adults 75 years of age and older are higher than those seen for any other age group during any surveillance season since the start of COVIDNet hospitalization surveillance. Next slide. Most adults ages 65 years of age and older hospitalized with COVID-19 have underlying medical conditions. Among adults ages 65 years and older, 19% are residents of a long-term care facility, and 83% have 2 or more underlying medical conditions. Among adults ages 75 years and older, 24% are residents of a long-term care facility, and 86% have 2 or more underlying conditions. These data and the data presented on the next 2 slides for older adults present data limited to hospitalizations where COVID-19 is a likely primary reason for admission. Next slide, please. Adults ages 65 years and older remain at risk for severe outcomes during COVID-19 associated hospitalization. The median length of stay for adults hospitalized with COVID-19 is about 3 days. There are minor differences between adult age groups with respect to ICU admission, receipt of invasive mechanical ventilation, and in-hospital death. In-hospital death is more common among adults 50 years of age and older. In the bottom row of the table, the proportion of in-hospital deaths occurring among adults 50 to 64 years, 11.3%, is higher relative to adults 65 years and older at 7.7%. However, more hospitalizations occur among the 65-plus age group. As a result, as highlighted below the table, 80% of all adults hospitalized with COVID-19 who died in hospital were 65 years of age and older. I want to note that these are only in-hospital deaths. They do not include other COVID-19 related deaths that might occur after a patient is discharged to hospice or other deaths that may occur soon after hospital discharge that could be contributed to COVID-19 related illness. Data from earlier years of the COVID-19 pandemic suggest that deaths after discharge from COVID-19 associated hospitalization is common among older adults, with a significant portion occurring within 30 days of hospital discharge. Next slide, please. And fewer than half of adults ages 65 years and older hospitalized with COVID-19 received any COVID-19 vaccine since September of 2022. This final slide, focusing on older adults, shows the proportion of COVID-19 associated hospitalizations by vaccination status among adult age groups for October 2023 through May 2024. Among adults 65 years and older, highlighted in the box on the far right, 53% of adults hospitalized with COVID-19 received neither the 22-23 or 23-24 COVID-19 vaccine. Only 15% of adults ages 65 years and older hospitalized with COVID-19 received the recommended 23-24 COVID-19 vaccine prior to admission. Next slide. I'll now move on to describe COVID-19 hospitalizations among persons with immunocompromising conditions. Next slide. I'm not going to read everything on this slide, but these are the conditions that COVIDNet uses to define an immunocompromising condition. Note that some of these conditions are time-bound relative to admission for COVID-19 associated hospitalization. Immunosuppressive therapy is only considered if treatment was received within the 12 months before admission. Similarly, cancers are only considered if treatment or diagnosis has occurred in the 12 months prior to admission. And receipt of steroid therapy does not include inhaled or intranasal steroids or intramuscular or intra-articular steroid injections. Next slide, please. Between July 2023 and May 2024, about 1 in 6, or 15.6% of persons hospitalized with COVID-19 having an immunocompromising condition, as highlighted in the box on the far left. This is among persons of all ages hospitalized with COVID-19. The proportions vary by age group. 3% of children ages 4 years and younger have an immunocompromising condition, as shown in the center set of bars. Among adults, in the 3 columns on the right of the figure, the prevalence of immunocompromising condition ranges from 15 to 22% among adults hospitalized with COVID-19. Next slide. This figure shows the most common immunocompromising conditions among the 16% of persons of all ages with immunocompromised status hospitalized with COVID-19. Among persons of all ages, the most common immunocompromising conditions include immunosuppressive therapy, 46%, solid organ malignancy, 26%, receipt of steroid therapy, 26%, and metastatic cancer, 22%. These proportions do vary slightly when comparing adults to children and adolescents. Next slide, please. Few persons with an immunocompromising condition hospitalized with COVID-19 received any COVID-19 vaccine since September 2022. This figure shows COVID-19 vaccination status by immunocompromising condition, with immunocompromised persons shown using the orange bars. Among immunocompromised persons of all ages hospitalized with COVID-19 between October 2023 and May 2024, 67%, or 2/3, had not received any COVID-19 vaccine since September 1st, 2022. Only 14% of immunocompromised persons hospitalized with COVID-19 during this period received the recommended 23-24 COVID-19 vaccine dose prior to admission. The proportion of persons who received the recommended 23-24 vaccine did not vary by immunocompromising condition status. Next slide. Time since receipt of most recent COVID-19 vaccine varies little by immunocompromising condition status. This figure shows the time since most recent COVID-19 vaccination and is limited to persons hospitalized with COVID-19 who received either a 22-23 bivalent or a 23-24 formula COVID-19 vaccine since September 1st, 2022. Among those hospitalized with COVID during October 23 and May 24, more than half of all patients, regardless of immunocompromising condition, received COVID-19 vaccination more than 180 days or 6 months before positive SARS-CoV-2 test associated with hospital admission. Relative to patients with no immunocompromising conditions, slightly larger proportions of immunocompromised persons received COVID-19 vaccination between 31 and 120 days before admission. Please take note that the number of persons with an immunocompromising condition is relatively small, as presented in these data, and significant statistical differences should not be implied between immunocompromised status groups. Next slide, please. Risk for severe outcomes during COVID-19 associated hospitalization among children and adolescents varies little by immunocompromising condition status. This figure shows the percent of severe hospitalization outcomes and interventions among children hospitalized with COVID-19 by immunocompromising condition status. Among children with immunocompromising conditions, shown in red, 19% were admitted to the ICU, 6% received invasive mechanical ventilation, and fewer than 1% died in hospital. These proportions appear similar to those among children with no immunocompromising conditions. But as before, please take note the number of children and adolescents with an immunocompromising condition is relatively small, and significant statistical differences should not be implied between immunocompromised status groups. Next slide. In contrast with children and adolescents, the risk for severe outcome during COVID-19 associated hospitalization among adults does vary by immunocompromising condition status. This figure shows the percent of severe hospitalization outcomes and interventions among adults hospitalized with COVID-19 by immunocompromising condition status. Among adults with immunocompromising conditions, shown in orange, 27% were admitted to the ICU, 8% received invasive mechanical ventilation, and just under 15% died in hospital. These proportions are higher than those among adults with no immunocompromising conditions shown in blue for all 3 outcomes and interventions. And that is my last slide for these 2 groups. Thank you.
Thank you, Dr. Taylor. We're going to hold questions until Dr. Link Ellis's talk. We're going to hold all questions until the second talk.
All right, could I get the next slide, please? Today, I'll be presenting COVID vaccine effectiveness data to inform the current policy questions under consideration by ACIP. I'll start with an overview of what's known about VE in immunocompromised versus non-immunocompromised people, starting with original monovalent vaccines, then bivalent, and then 23-24 vaccines. Then I'll share data on VE in adults aged 65 years and up, again starting with original monovalent, then bivalent, then 23-24 vaccines. Next slide. Before we dive in, I wanted to summarize the key questions for COVID-19 VE. First, we know that time since dose impacts protection, but how much and over what time period is an open question with different answers by outcome, season, circulating variants, and other factors. Second, SARS-CoV-2 variants change over time, and we know that the variant vaccine match can impact effectiveness. Finally, we know that surges in disease, seroprevalence, and time since last SARS-CoV-2 infection impact measured VE. It can be difficult to disentangle time since dose, i.e. true waning, versus the impact of changes in variants versus time since prior infection. Next slide. As mentioned, patterns of prior infection can impact measured VE. This graph provides some context specifically for interpreting VE of 23-24 COVID-19 vaccines by showing the protection of persons with infection-induced immunity by age group during July through August 2023, that is just before the introduction of 23-24 vaccines. During this period, all adult age groups had high rates of infection-induced immunity, above 70% for all age groups and almost 90% for those aged 16 to 49 years. Infection can provide some protection from future infection, so VE findings, especially for the 23-24 vaccine, should be interpreted as the added benefit provided by COVID-19 vaccination in a population with a high prevalence of infection and vaccination-induced immunity. Next slide. Finally, before diving into the VE estimates, a note here on how we measure VE. Absolute vaccine effectiveness compares the frequency of health outcomes in vaccinated versus unvaccinated people. Absolute VE has most often been used to measure VE during the era of original monovalent and bivalent vaccines. During the bivalent era, however, we also measured relative VE, which compares the frequency of health outcomes in people who received one type of vaccine to people who received a different vaccine. For example, people who received a bivalent dose versus those who received only original monovalent vaccine. Generally, for 23-24 COVID-19 vaccines, we've combined absolute and relative VE and measured protection as the frequency and disease in those who received 23-24 vaccines to those who did not, regardless of past vaccination. In other words, the comparison group for 23-24 VE analyses includes people who were unvaccinated as well as those who received original monovalent and bivalent doses. Of note, this is similar to how influenza vaccine effectiveness is measured annually. Next slide. I'll start by presenting general methods for 3 different VE platforms included today. Next slide. The first VE study included today is the VISION Network, a multi-site network of electronic healthcare records at over 300 emergency department and urgent cares and over 200 hospitals. It uses a test-negative design and includes eligible adults with COVID-like illness and a NAT test result. Vaccination is documented by electronic healthcare records and state and city registries. Next slide. The second study included today is from the Ivy Network, a multi-site VE platform that uses a test-negative design with enrollment currently at 26 hospitals.
Participants were adults hospitalized with COVID-like illness. Cases have a SARS-CoV-2 positive NAT or antigen test, and controls had a NAT for SARS-CoV-2 and a negative influenza NAT. Vaccination history is ascertained through EMRs, state and local vaccine registries, and self-report, and specimens are collected for centralized testing and sequencing. Next slide. The third study today uses data from the Centers for Medicare and Medicaid Services. The Medicare studies use a retrospective cohort design based on Medicare fee-for-service beneficiaries aged 65 years and up. Events are identified from Medicare claims using ICD-10 and CPT codes, and VE is calculated as 1 minus the adjusted hazard ratio times 100%. Next slide. So now moving into results and data to inform the need for additional doses in persons with immunocompromise. Next slide. This slide shows VE of original monovalent vaccination in adults 50 and up from the Vision Network during December 2021 to March 2022, with immunocompromised estimates in purple and non-immunocompromised estimates in gray. 2-dose VE is shown here in the red box, and you can see that immunocompromised people have consistently lower vaccine effectiveness, though the waning pattern is much less clear than for non-immunocompromised. Next slide. And here we see an increase in VE after an additional dose, again with lower VE for immunocompromised people, but clearer waning patterns. Overall, VE of original mRNA doses versus unvaccinated persons during Delta and early Omicron was higher among non-immunocompromised adults compared with immunocompromised. An additional dose restored protection or increased protection in immunocompromised and non-immunocompromised persons, with some waning apparent. Next slide. Here we have data from the Ivy network showing original monovalent and bivalent versus unvaccinated VE by time since last dose. Estimates for those without immunocompromising conditions is on the top, and for those with immunocompromising conditions on the bottom. For this slide, note that the colors are a little bit different than the rest of the presentation. Here, orange is original monovalent, green is bivalent 7 to 89 days prior, and blue is bivalent 90 to 179 days prior. Next slide. First, note that recipients of the original monovalent vaccine, shown in orange, were more than 400 days out from their last dose in both the immunocompromised and non-immunocompromised groups, and VE had therefore waned quite a bit. Here we see that for both those with and without immunocompromising conditions, a bivalent vaccine restores protection that had waned. Next slide. And here, as with the Vision original monovalent data, we see somewhat different waning patterns between the two groups, with apparently less waning in those with immunocompromising conditions. Next slide. Continuing to move forward in time, this is Vision data showing VE of 2023 to 2024 COVID vaccines compared to no 23-24 COVID vaccine by time since dose. Immunocompromised are shown in purple and non-immunocompromised are shown in red. As with past formulations, we see generally lower VE during the 23-24 season for immunocompromised versus non-immunocompromised persons, though waning patterns for 23-24 doses are similar between the two groups. Next slide. So to wrap up, for immunocompromised people, COVID-19 vaccines provided protection for both persons with and without immunocompromised. COVID-19 VE patterns in immunocompromised populations were different season to season, with generally lower VE compared to non-immunocompromised, but with inconsistent waning patterns. During 23-24, VE against hospitalized COVID-19 in immunocompromised waned to null by about 4 to 6 months. The inconsistency in VE among immunocompromised persons is likely multifactorial, including heterogeneity among those classified as immunocompromised, variation in underlying immunity in response to prior infection, and differing health behaviors over time and by immunocompromised status. Next slide. So I'll now move into data on VE to inform the need for additional doses in adults aged 65 years and up. Next slide. This graph shows VE against hospitalization in the dotted lines and critical illness in the solid lines. VE of original monovalent doses is shown in gray, bivalent in blue, and 23-24 vaccines in red. You can see that for each vaccine formulation, VE for critical illness, generally defined as ICU admission or death, or mechanical ventilation or death, is higher than for VE for hospitalization. And although waning is apparent with the more recent formulations, VE remains higher for critical illness than for hospitalization, as can be seen by the solid lines remaining higher than the dotted lines. Next slide. This shows VE of 2 or 3 original monovalent doses and time since vaccination separated by Omicron sublineage period, BA.1 and BA.2 on the top, and BA.4 and BA.5 on the bottom. Although these data are for all immunocompetent adults aged 18 and up, they show a consistent pattern of waning of protection from the original 2 doses, followed by restoration of protection with a 3rd dose and subsequent waning of protection. This pattern is consistent across both sublineage periods. Next slide. These data from VISION show a similar pattern among those 65 and up specifically, and show the restoration of protection provided by 3 original monovalent doses, followed by waning, and then again restoration of protection provided by a 4th original monovalent dose. Next slide. Moving now into the bivalent period, here we have VE against severe in-hospital outcomes from the IV network, shown from least severe at the top to most severe at the bottom. Again, although these data are for all immunocompetent adults aged 18 and up, this is informative for the additional dose question, as we can see in the red box that VE against the most severe outcome, invasive mechanical ventilation or death, VE of the original monovalent vaccine waned less than for the less severe outcomes at the top. A bivalent dose in green provided additional protection and appeared more durable than for less severe outcomes. Next slide. Here we have Medicare data looking at VE of a bivalent dose versus the original monovalent dose against a critical outcome, COVID-19 related thromboembolic events. COVID-19 related thromboembolic events were defined as an ICD-10 or CPT code indicating ischemic stroke, venous thromboembolism, or myocardial infarction from 7 days before through 30 days after a medical claim indicating a COVID-19 diagnosis. Note that this is relative VE, so 54% protection in the 7 to 59 days after a bivalent dose is additional protection beyond that provided by original monovalent doses. Next slide. This slide shows VISION data looking at the additional benefit of 2 versus 1 bivalent dose against COVID-19 associated hospitalizations in adults 65 years and up. VE of an additional bivalent dose at least 4 months after the original bivalent dose appeared to provide some protection in addition to the first dose, with a point estimate of 20%, though the confidence interval was wide and crossed 0. Next slide. Now for the VISION 23-24 data. Here we have VE against COVID-19 associated emergency department or urgent care encounters among immunocompetent adults aged 18 and up on the top, and then split by age group, 18 to 64 in the middle and 65 plus on the bottom. On the left, you can see time since dose ranging from 7 to 59 days after receipt of a 23-24 dose to 180 to 299 days. Note that the referent group here is anyone who did not receive a 23-24 COVID-19 dose, including unvaccinated people and those who got an original monovalent or bivalent dose. So the VE estimates here represent additional protection beyond what people from the past have from past vaccination or infection. Here we see similar waning patterns to what we've seen in past years, with negligible additional protection after 6 months from the dose in both age groups. Next slide. This slide has the same setup, but now with hospitalization as the endpoint. Note that the confidence intervals for younger adults are wide, especially in the longer time since dose periods, due to lower vaccine uptake and lower baseline hospitalization rates in that group. For older adults, we see the same waning pattern as we did for emergency department and urgent care visits. Next slide. This slide shows the same VE at the top of, as at the top of the previous slide. That's VE against hospitalization for adults 18 and up, but the bottom is now VE against critical illness, defined as admission to the intensive care unit or death. Again, this is comparing to a combined group of unvaccinated people and those who received bivalent and/or original monovalent doses. So this is additional protection beyond that protection. Here we see that, as with previous seasons, VE for critical illness appears somewhat more durable compared to hospitalization. Next slide. And this slide shows data from the Medicare analysis on the top, VE against thromboembolic events and VE of 23-24 vaccines against death among beneficiaries with end-stage kidney disease, and data from Vision for ICU admission or death with slightly different cut points than the last slide on the bottom. Note that for thromboembolic events, median follow-up time was 74 days with a VE of 53%, and for death, median follow-up time was 104 days with a VE of 47%. And again, as with previous seasons, we see higher VE against the most critical outcomes and less waning than compared to earlier slides with less severe outcomes. Next slide. So first, to conclude, just a reminder that VE findings should be interpreted, especially for 23-24 vaccine, as the added benefit provided by COVID vaccination in a population with a very high prevalence of vaccine and infection-induced immunity at the start of the season. The 23-24 COVID-19 vaccines provided increased protection against COVID-19 associated emergency department and urgent care visits and hospitalizations compared to no 23-24 vaccine dose. However, this additional protection waned to zero against COVID-19 associated ED/UC visits and hospitalization by about 4 to 6 months after the last dose. Waning patterns for the 23-24 vaccines appeared similar to previous COVID-19 vaccine formulations, with the most durable protection against critical illness, which was measured in a number of studies in different ways. VE against critical illness remained above 40% at 5 months after vaccination among those 65+ years. As with previous COVID-19 vaccine formulations, effectiveness was similar across age groups. And finally, data from prior seasons show that an additional dose of the same formula appeared to provide additional protection beyond the original dose. Next slide. I'd like to just acknowledge the many investigators who contributed to these analyses, including Vision and IV investigators and partners at CMS and Acumen. Thank you.
Thank you, Dr. Link-Ellis. We're now open for questions for both Drs. Taylor and Link-Ellis. Dr. Chu.
So thank you for those very nice presentations. So it seems to me that one of the highest priority groups is individuals who are in long-term care facilities, and yet their vaccination rates remain quite low. And I'm wondering if there's messaging particularly targeted at providers who serve these populations to increase vaccine rates in these groups. And then my second question is whether or not you're able to measure the impact of the vaccines against long COVID, and whether or not that's a consideration for future analyses.
There has been a lot of work that's been done working with long-term care facilities and also with the organizations that support those with limited success. You know, some, I mean, so there has been education. We haven't had a lot of success in increasing the vaccine coverage in those areas.
And then for your second question about measuring vaccine effectiveness against post-COVID or long COVID, it's a particularly tricky area of research because the definition of long COVID can be so easily confused for so many other things. There are a number of studies that have attempted to look at it with varying definitions and generally find protection. How much that protection is how quickly it wanes has been really variable across studies. And generally, the CDC studies are not set up to look at that because you need a long period of follow-up time after an initial medical care encounter for COVID. And we know that long COVID often follows a COVID diagnosis that was not so severe in the acute phase. And so it's a really difficult endpoint to study. So it is an ongoing area of research, both by CDC and other groups.
Dr. Schechter?
Thank you, Rob Schechter. I was just struck by the COVIDnet data from Dr. Taylor about the 15% figure of adults 65 years and older who received the 23-24 COVID vaccine last year, and what that reflects about demand and access and whatever barriers we're facing in implementation. And related to the another high-risk group that was related in the earlier statement from the from I believe ACOG, that the separate COVIDnet study, which showed fewer than 5% of pregnant women whose infants went on to be hospitalized in that critical 0 to 6 month period, where hospitalization rates are as high as the 65 plus population. So no questions, just concerns around these missed opportunities to protect these high-risk populations. Thanks.
Thank you. Dr. Asturias?
Yeah, Edwin Asturias, and this question is for Dr. Taylor. If you go back to slide number 17, I would like to clarify your statement that there doesn't seem to be a difference in the rates of outcomes of children under 17 years of age immunocompromised versus not immunocompromised. At least I think our data from Colorado has shown that the rate of hospitalization in under 1 year of age is quite high and equivalent even to people above 60 years of age compared to in healthy children. So I'm wondering if that figure is mixing two different populations, the non-immunocompromised, in which may be, mainly infants under 1 year of age, versus the immunocompromised condition, which I suspect are a little bit older children.
Thank you. Yes, and you're correct that the rates for infants less than 6 months of age have been comparable to adults 65 to 74 years. So this slide here, the slide 17, where we show so we have here in orange those children and adolescents with the immunocompromising condition, and those without immunocompromising in orange, those without in blue. You're right. They might not. They might be two slightly different populations. And obviously, there's a lot of things, like, for example, with ICU admission, which you had mentioned, obviously the standards are different depending on the age of a child or an adolescent and other health statuses. And it's a lot of things that we don't directly take into account in an analysis like this. So there may be some differences between the populations. But I will point out here too, again, that because the sample size for the immunocompromised group shown in orange is small, we can't really say much about the differences looking here. And that's also why this is presented as a broader age group for children and adolescents less than 17 years of age, because we really wouldn't have any statistical power to go any smaller than that. Did that address your concerns?
Yeah, I think it does partially. I just want to reiterate that I think we haven't focused that much in that group of infants, and that is an important group that we are, in a way, not sort of tackling through vaccination in pregnancy, as well as other processes that we can sort of improve to sort of prevent the amount of illnesses that we're seeing there.
Thank you.
Ms. Moser?
Thank you.
First, I'd like to acknowledge the hundreds of people who submitted comments on the portal and thank them for taking their time to share their thoughts, because most of the comments were related to this. Sorry, should I start over or did you hear me? So first, I'd like to acknowledge the hundreds of people who submitted comments and thank them for taking time to share their thoughts, because so many people had commented on this particular part of the agenda today. The second is more of a thought. It's not so much a question, but I understand why in all of these studies we're trying to understand the vaccine efficacy and compare it to last year, whether somebody got last year's version of the vaccine or not. But I think it would be really helpful if we could figure out that control group, so to speak, the no recent vaccine group, because we're really putting a lot of different people in that category, because some people have never been vaccinated against COVID, and we're not taking into account at all recent disease. And so I understand we have a high population immunity, but the variants are changing. You talked about the complexity of trying to get at the importance of getting a new vaccine each year. And I think we're missing an opportunity when we don't try to understand, historically where people are at when, from the immunologic point of view. I think that would help people who in this population don't want to get any more COVID vaccines and they're trying to figure out what to do, as well as many of these people who are commenting who are scared because they're high risk, their family members aren't high risk and can't get additional doses. And so anything that we can do to help people better understand their protection level, I think is going to be important moving forward.
Thank you. Dr. Lear?
Thank you. 2 comments. Could we go to slide 6? This is the incidence rate of hospitalizations and they increasing with age. And it was stunning to me. When you look at 1,410 hospitalizations, you think that's a number. But when I did the conversion, that's 1 in 70 adults. And that is just stunning that many people over 75 are going to be admitted to the hospital with COVID. We don't have that with diabetics. We don't have that maybe with heart disease. But this is just a stunning number, which I think should be more promulgated. My other question is the recommendation for 6 months between the first dose and the second dose. And I'm torn by that. I'm gladdened by the fact that we have at least flexibility to go down to 2 months. But one of the things I ran into from colleagues and from my patients last summer was they wanted to get the vaccine in July or August because of a trip or a high exposure, but then could they get the next dose that was coming out in September, and when should they do it? And I usually just sort of arbitrarily said 4 months, but that's not quite meeting the 6-month standard. And I don't really have a question, but I sort of want to acknowledge that there's difficulty sometimes trying to figure out the right timing for that. So I don't really expect an answer, just a comment. Thank you.
Dr. Brewer?
So my question is for the last presenter. It might help the public watching this presentation to understand for slides 25 and 26, the final row for the age to 18 to 64-year-olds, how we should be interpreting those data points. So this would be slides 25 and 26.
I think he's asking about the vaccine effectiveness slides, so Deck 04.
That's right. So for 18 to 64-year-olds, and then the 2023 to 2024 COVID-19 dose, 180 to 299 days earlier, exactly. And there are lots of different ways people could be looking at this data point, and it'd be helpful to have some language to frame it for them.
Sorry, the audio in here is really bad, but I think you're asking for the interpretation of the 7 to 299 days earlier, and that is just an average of the breakdowns of the 4 categories below it. So if you see the 7 to 59, 60 to 119, 120 to 179, and then 180 to 299, that 7 to 299 row is just an average of those 4 rows where we've broke it out in more detail.
Yeah, yes. So I have a similar question. So in this same slide, if you do a Dr. Lair and do some math, it looks like somewhere around 20% of each category it may actually increase their risk of an ED or an urgent care, and I think the next slide was hospitalization. So, and the confidence intervals are pretty tight. So I do wonder how one interprets this particular slide. For example, if you took the seconds, 18 to 64, overall, looks like about 30% efficacy, but then you go down of that group, you have a negative 15%. So if I'm 18 to 64, what would I have to make a decision in there? You know, do I get it versus not based on this data? So I would be curious as to your interpretation of this, Dr. Link-Ellis.
Yeah, absolutely. So to be clear, there is no biological plausibility for vaccine increasing your risk of disease. So that is absolutely not what we think is happening in that longest time since vaccination. Vaccine effectiveness at its root is essentially measuring the risk of disease in a vaccinated population compared to an unvaccinated population. So what's happening in your unvaccinated or your less vaccinated population can have a big impact on what vaccine effectiveness is measured at. In this case, I think what's likely happening is that unvaccinated people are getting infected during that 6-month period when vaccinated people are protected by their vaccine. And so what that's essentially doing is raising the infection-induced immunity level in the unvaccinated population, which then gives us this sort of funny measurement of VE when the protection from the vaccine has waned such that vaccinated people are now susceptible to infection.
So I hear you. So there was the beginning discussion about absolute versus relative VE. So this one is reflecting relative, I imagine, is what you're saying.
This isn't relative VE exactly. It's a combination.
Right. So you actually presented three different scenarios. So this is what you're saying, the third scenario. All right. Thank you.
Very helpful, thank you.
Other questions or comments?
I don't know if you can see my hand.
Yes?
It's Josh Cushell. I don't know if you can see my hand. Sorry, I'm online. Can I speak?
Yes, please, Dr. Cushell.
Yeah, hi. So these have been wonderful presentations and very, very informative. But I have a comment and a request. As a clinician, I'm a fervent supporter of simple guidelines for vaccinations, and I think chronological age is a good one in that sense because it's clear in all of our patients and very simple. But as a geriatrician and gerontologist, I can tell you that chronological age is a very imperfect measure of vulnerability, and that's what everybody's getting at in these presentations. And this heterogeneity, the word heterogeneity came up a lot in terms of identifying different degrees of vulnerability. And there are many ways to measure it that we do clinically and in terms of research that are not possible for this kind of data. But I have one request for all of this surveillance and also vaccine effectiveness data. If it would be possible to present at least some of it stratified by sex or gender rather here, because men and women do not age the same way from an immune perspective. There are huge differences, and that in Figure 6, what Dr. Lohr talked about, that incredible vulnerability after 65 to being hospitalized after COVID. I think if you stratify by sex, I think you will see we will see some additional insights there, and I think that could help guide risk in the future.
Okay, one final comment, Dr. Brewer.
I guess my question is, and I really apologize for my voice here. I know it's hard to hear or make out what I'm saying. Do we have any estimate of how much of waning immunity is due to the artifact that you just described earlier? That is to say, the shifting of people in the control group into having been infected. Because we have this clear pattern of apparent waning immunity, but if we believe what we heard earlier, which is that a good portion of this implausible finding, biologically impossible, you said something to that effect, then it must also be that some amount of what we call waning immunity is not waning immunity at all. In other words, maybe the story is better than we think, and I'm just curious if we have any, like, even back of the envelope calculations about how much of what is apparently waning immunity is just due to natural infection in the control group.
So I think the phenomenon that I mentioned earlier, where the unvaccinated population is getting infected, which is resulting in lower than expected vaccine effectiveness, probably impacts VE more and more the further out you get from vaccination. And I think that we sort of cross a threshold around 4 to 6 months where we're starting to see this negative VE. We know that measured vaccine effectiveness can change quite a bit based on sort of the background rates of disease. And so, for example, we know that if there is a surge in disease the month before a new vaccine is introduced and the population has a very high rate of infection-induced immunity, we're going to measure lower VE. Exactly how much lower and how that impacts waning, I think, is very difficult to quantify precisely, because it's going to be different based on your outcome, based on your population, based on an individual's immune status. And in most of our VE studies, for example, we don't have serology on them, so we aren't measuring prior infection in an individual person. All we can do is look at it at the population level. So, you know, I think of these VE estimates in that sense as sort of a conservative estimate, that if we were able to stratify by like recent prior infection, we would probably see higher vaccine effectiveness. But because prior infection is so infrequently documented in medical records, that's not generally possible in these types of well-powered studies. You can do it in very small cohort studies, but then you lack the statistical power to stratify VE.
Just seems like something that would be useful to learn through modeling, but anyways, thank you. It was a very helpful answer.
So thank you very much for those questions and comments. I think we need to move on to Dr. Prosser's presentation of the economic analysis. Dr. Prosser?
Great, thank you. Good afternoon. I'm Lisa Prosser, and I'll be presenting the economic analysis. Next slide, please. I'd like to start by acknowledging all of the many collaborators who contributed to this analysis. Thank you. Next slide. We do not have any conflicts to report. Next slide. The original aims of this ongoing analysis, as presented in the September 2023 ACIP meeting, are listed in the first few bullets. Since that time, we have been continually updating the model as new data become available. In this phase of the analysis, we have made several updates to the model since we last presented in June of this year. This phase of the analysis focuses on the cost effectiveness of an additional mid-year dose. We have also updated the model to incorporate more recent data on the probability of hospitalization, current data on vaccine dose costs, and have adjusted all inputs to a 2024 costing year. In the next few slides, I'll review these updates in more detail. Other modeling assumptions remain the same as in the June 2024 presentation, and further details are included in the additional slides at the end of this deck. Next slide, please. This slide shows weekly rates of COVID-19 associated hospitalizations by season and how the rates have been declining year to year. In the June 2024 analysis, we used hospitalization rates from the 22-23 season shown in green. In this phase, we've updated the model to incorporate data from the 23-24 season shown in red. Next slide, please. This slide shows a comparison of the annualized probability of hospitalization with 23-24 on the left in gray and 22-23 on the right. Probabilities have dropped for all age groups, ranging from 14 to 33% lower than the previous year. Next slide. Updating the hospitalization rates will also impact the seasonality adjusted vaccine impact estimates, or SAVIs, included in the model. SAVIs combine monthly rates of vaccine effectiveness and hospitalization to reflect timing of vaccination, along with the seasonality of COVID-19 illness throughout the year. This slide shows updated SAVIs for both the one-dose strategy presented in June and the two-dose strategy new to this analysis. Next slide, please. Comparing seasonality adjusted vaccine impact across the two models yields lower estimates for both the one and two-dose strategies, ranging from 9 to 15% lower for the one-dose strategy and 2 to 6% lower for the two-dose strategy. Next slide, please. This slide shows vaccine dose costs reflecting observed market share for private sector and CDC negotiated prices. I'm looking at the far right column. The base case per dose costs are 1% higher for 5 to 11-year-olds, 10% higher for 12 to 17-year-olds, and 15% higher for adults 18 and older compared to last season's costs. Next slide. The two-dose strategy also includes updated assumptions for adverse events and cost of vaccination. These details are included in the additional slides. Next slide, please. In this phase, we have rerun all analyses listed on slides 11 and 12 using these updated model inputs. This presentation will focus on a subset of these analyses for the two-dose strategy. Other results are available in the additional slides. Next slide, please. We'll now turn to the results. Next slide. And next slide. This slide shows disaggregated results with each panel depicting a health outcome by type of event and by age. Results are presented for cohorts of 100 and 1,000. The total bar represents total events in the absence of vaccination. The gray part of the bars represents events averted with one dose. The striped top of the bar represents additional events averted with the mid-year dose. And the black portion of the bar at the bottom represents remaining events with vaccination. The top left panel shows total events, including symptomatic cases, long COVID, hospitalizations, and deaths. And it's easy to see that when looking at total cases across all outcomes, the total number of cases are similar across ages. But as we turn to higher severity outcomes in the other panels, the burden is higher in adults, especially adults 65 years and older. Bring your attention to the two panels at the bottom of the slide, ICU stays and deaths, and it's clear that the burden is highest in 65 and older. Next slide, please. This slide shows the same information from the previous slide in numeric form. The right-hand side of the table lists numbers of cases averted by vaccination and by type of outcome. Again, the burden of illness varies across groups, with higher burden and more higher severity cases averted for adult age groups. Next slide, please. This slide reports incremental cost-effectiveness ratios for each age group using a societal perspective for both the one-dose and two-dose strategies. For all age groups, vaccination requires an additional investment, as shown in the incremental cost column, and yields additional health benefits as measured in quality-adjusted life years. Next slide, please. This slide focuses in on the ICERs that were presented on the previous slide in the very far right column. Updating the model, important to note, there's some noise on the line. Thank you. important to note that on the far right hand side of the column, that updating the model, so the updates that we've made since June, yields higher ICERs across all age groups for the one-dose strategy, ranging from $59,000 per quality to $335,000 per quality, compared to $23,000 per quality to $212,000 per quality in the June analysis. For the two-dose strategy, again, new to this analysis, the ICERs range from $758,000 per quality down to $356,000 per quality for the 65 and older age group, with the highest ICERs in the 18 to 49 age group of $1.1 million per quality. Next, we'll turn to some sensitivity analyses. This slide shows one-way sensitivity analyses for the one-dose strategy for the 65 and older age group. The three most influential parameters are seasonality-adjusted vaccine impact, probability of hospitalization, and vaccine dose cost. Next slide, please. This slide shows one-way sensitivity analyses for the two-dose strategy, again for the same age group, 65 and older, with the same three parameters as most influential. We'll now turn to some additional sensitivity analyses that focus on these three parameters. Next slide, please. This slide presents the results of a one-way sensitivity analysis varying the probability of hospitalization to upper and lower bounds. Even using the upper bound of probability of hospitalization, ICERs for the three youngest age groups remain greater than $700,000 per quality.
Dr. Prosser.
$300,000 per quality for the
Dr.
50 to
Prosser.
64-year age group. Yes.
This is Gift Talbot. I just want to interrupt. Would you please clarify, when you say one dose, you mean one extra dose? And for two dose, you mean two extra?
No, I don't. So one dose is the one-dose strategy. So that is receiving a single dose.
Okay.
And the two dose is the additional dose strategy.
Thank you.
Thank you for that clarification. Any other clarifications? Great, thank you. And just a small comment there, the reason that we're representing the results from the one-dose strategy, which is what was recommended in June 2024, is because the ratios associated with that strategy has changed slightly based on the updates that we made to the model. So we wanted to present those both sets of results to the ACIP today.
Thank you.
Okay. Sure. So for the 65-year-old age group, the ICERs for the upper bounds fall to $99,000 per quality. Next slide, please. Varying the probability of hospitalization has a substantial impact on the ICERs. And in varying this parameter to beyond the range that was included in the previous slide, so the upper and lower bounds in our primary analysis, but so this is a scenario analysis going beyond those ranges, that if we expand that up to 2 to 4 times the base case, the ICERs are lower for all age groups, so it still remain higher than $350,000 per quality for the two-dose strategy for all age groups except for 65 and older. These higher rates correspond to conditions as listed in the footnote at the bottom of the slide, such as hypertension, diabetes, and chronic kidney disease. Next slide, please. And then just focusing on the bottom 2 rows of the table to highlight the results for the age group 65 and older. For this scenario analysis, the ICERs dropped to $180,000 per quality at 2 times the base case, down to $61,000 per quality adjusted life year for 4 times the base case, and proxying for a higher risk subgroup. Next slide, please. Similarly, ICERs are more favorable in a scenario analysis varying the probability of critical illness, again from 2 to 4 times the base case, with ICERs falling to $135,000 per quality for a 2-dose strategy in 65 and older. Next slide, please. Lower costs of vaccination are also associated with lower ICERs. Although even using all lower bounds for cost of vaccination, the ICERs remain above $250,000 per quality for an additional dose strategy, except for the age group 65 and older. Next slide, please. This slide focuses on varying vaccination costs for the 65 and older age group. So in the top table, varying all vaccination-related costs to lower bounds yields cost savings for a one-dose strategy and $70,000 per quality for a two-dose strategy. Next slide, please. Oh, sorry, back to the previous slide just for a moment. In the bottom table, varying the cost of the vaccine dose would move a one-dose strategy into the cost-saving range for a cost per dose of $50 or less, and the ICER for the additional dose strategy would fall below $180,000 per quality for a cost per dose lower than $60. Next slide, please. This slide shows how the ICERs vary for all age groups when varying the cost per dose from $20 to $140 per dose, with the one-dose strategy on the left-hand side and the additional dose strategy on the right-hand side. So you can see the ICERs are very sensitive to the cost of the vaccine dose. Next slide, please. The same set of limitations applies from previous phases of the modeling. Some notable areas with the least robust sets of data are for vaccine effectiveness, as well as the epidemiology and burden of long COVID, which we plan to update in future phases of the modeling. Next slide, please. In summary, for 2024-2025 COVID-19 vaccination, for the additional dose strategy economic analysis, the ICERs for age groups under 65 years were less favorable than for those 65 years and older across plausible parameter ranges. For those 65 years and older, ICERs are sensitive to seasonality-adjusted vaccine impact, probability of hospitalization, and cost of vaccination. And overall, ICERs are more favorable in scenarios with higher risks of hospitalization and lower costs of vaccination. And that concludes this presentation. I'd be happy to answer any questions. Thank you.
Thank you, Dr. Prosser. Are there any questions from the committee? Dr. Brewer? Oh. Okay, Dr. Shaw.
It's Al Shaw. Thank you very much, Dr. Prosser, for that. It's a great presentation. I just had a kind of a similar question to one I asked before, was whether your models accounted for the costs of potential post-infection care, so need for either transient or permanent residence in a skilled nursing facility, the costs of a family member who may need to leave work to care for an older adult. These are particularly relevant questions for the over 65 age group.
That's right. Thank you very much for those questions. So the costs associated with hospitalizations and complications for hospitalization are from market scan data, which include, I believe, episode costs, and will include some of those costs as they're paid for by the health plan. Although it's highly likely that there are some of those costs, if they're covered at the family level, that would not be incorporated in there. So I would say that this would include a conservative estimate of those costs. We have included costs of informal caregiver time, again, primarily for the time associated with hospitalization. We've included in the model an adjustment for requiring care for a period of time post-hospitalization, but again, a conservative approach to incorporating those informal caregiving time costs, but they are included in the model.
Okay, thanks.
Dr. Lair?
Thank you very much for your presentation. I just want to give a comment or a perspective as a small family practice buying my own vaccines. I do need to comment that the prices that I'm buying the COVID vaccines at the current time are about 30% less than what you've got listed in slide 9 for the private market. So kudos to the manufacturers for at least giving me a better price. I don't think I'm getting a better deal than the rest of the country, but I do think that's a significant difference in the calculations. Thank you.
It is. So that's a really important point. I'm glad you shared that. If I'd like to just show the slide. Let's see, that would be slide number 25. a really rough approximation, you would be looking at, roughly $100 per dose. We can also look at the next slide, which shows more detail on this. So for the additional dose strategy, those would be coming in, probably, if we looked at kind of the corresponding incremental cost effectiveness ratios, still remaining above $600,000 for age groups under 65 years of age, but perhaps getting closer to $200,000 per quality for 65 years and older. So thanks very much for that comment.
Dr. Schechter?
Hi, thank you. I think this will be directed again to Dr. Taylor, but it comes up with the economic analysis around hospitalization rates. And I just wanted to reflect on this last surge this last summer, which appeared to have, at least in California, higher hospitalization rates than the 2023 surge. And so I'm just wondering if that was also reflected in national hospitalization statistics, namely, was this most recent surge have higher hospitalization rates than the year before? And then maybe it'd be speculative about why that was the case, but just projecting forward and trying to understand the effect of hospitalization rates on these estimates.
Dr. Taylor, did you hear the question?
I did, thank you. I would say, so COVIDNet is comprised of multiple sites. And so each site was different. Some sites who had a mild winter had a larger summer surge, and sites that had very high rates in where we would typically see a winter peak in December and January saw a more moderate summer surge. And so we really did see some regional variability that across all sites sort of averaged out. I don't think what we saw this summer overall was generally different than what we had seen last summer, but that it did vary by site.
Thank you. Last question, Dr. Brewer.
Thank you. Noel Brewer. I have two questions. The first one is trying to tie the cost effectiveness analysis to equity. And I think you've done it in a creative way by, rather than pointing to different groups, you point to characteristics of the world they may experience, certain kinds of larger rates of disease and whatnot. But can you speak to that maybe more explicitly, like help us to understand how equity would show up in one or two of your slides of cost effectiveness?
Sure, thanks for that question. And it was interesting to see some additional models being presented in early analyses today that focus specifically on equity. So just to clearly state that there has been no formal incorporation of health equity considerations into the model that was presented here today. But as you've alluded to, Dr. Brewer, that if you look at the sensitivity analyses around any of the higher rates of hospitalization, critical illness, or death, that any of those, if there were a population or a subpopulation that had those higher rates, that certainly they would benefit more from vaccination. And so that could be a way to think about equity within this particular presentation.
And could we look at one specific slide, perhaps, that you think would help illustrate this? I'm sorry to put you on the spot, but it might help us to look at one.
Sure. So I think you could look at slide. Well, I think I would start with the one-way sensitivity analyses on slide 19. And just draw your attention to the parameters that are really driving the cost effectiveness of the model. And this, just to think about that from the converse perspective, that if there were kind of characteristics that were potentially associated with equity that were associated with these parameters that weren't driving the model, that again, that's not something that we would see vaccination addressing equity. But then if you move to the next slide, on slide 20, that here you can see the substantial impact on the probability of hospitalization for the incremental cost effectiveness ratios across all age groups. And particularly, for the one-dose strategy, which we're not looking at specifically here today, but there's certainly a lot of sensitivity, when looking at higher rates of hospitalization. So again, I think any subgroups, that are at higher risk for hospitalization or higher disease burden, would be potentially impacted here in a positive way from a health equity perspective. But I think, I do want to be clear that's not a particular goal of the current analysis, but certainly something that could be considered in future analyses.
Yeah, and I do appreciate that. You can build models. We've done it at UNC where you take these, you disaggregate the initial data. So, okay, let me go to my second question, which is brief. How does the model address the cost of time lost? So I go to get the vaccine on Friday. Saturday, I can't do any work at all, so I've lost a day of work, a day of childcare. And I'm just speaking of my last Saturday, for example. That's what happened as a result of the vaccine. Didn't put a grant in. I mean, there's stuff that I couldn't do, and yet I'm still committed to vaccination. Think it's great and all that. But how do we take that into account as we deal with the costs?
So so some of those costs, although of course not all of them, are incorporated into the model. We do include time costs for the vaccinee, both for initially for the time to receive vaccination, but also associated with any of the potential adverse events. So for systemic adverse events, as you just described, there would be the loss of 1 day of productive time that's incorporated into the model. If other adverse events were experienced, there would be a loss in productive time associated with those events in the model. And then similarly for COVID-19 illness, there's productivity loss associated with each of those events corresponding to with either the duration of illness or, for example, for hospitalizations, we include a multiplier, assuming that there will be some additional productivity loss for some period of time following the hospitalization after the hospitalization itself. So those are incorporated into the model. We have not included additional childcare costs. That certainly is something that could be included, but in this current phase of the model has not been incorporated.
Okay, at this point, I think we need to move on to the next presentation. Ms. Roper.
Thank you. Good afternoon. I'm Lauren Roper, and today I will be reviewing the Evidence to Recommendations framework on additional doses of 2024-2025 COVID-19 vaccine in older adults and people with moderate or severe immunocompromise. Next slide. These are the current ACIP recommendations and products which fall under these recommendations. At the June 27th ACIP meeting, ACIP voted to recommend 2024-2025 COVID-19 vaccines for everyone 6 months and older. On August 22nd, FDA approved and authorized 24-25 Pfizer-BioNTech and Moderna COVID-19 vaccines for people ages 6 months and older. On August 30th, 2024, FDA authorized 2024-2025 Novavax COVID-19 for people ages 12 and older. Next slide. Today, I will be presenting the Evidence to Recommendations framework on the following policy questions. In addition to previously recommended 24-25 vaccination, should a second dose of 2024-2025 COVID-19 vaccine be recommended for adults 65 years and older? Should a second dose of 2024-2025 COVID-19 vaccine be recommended for people ages 6 months and older who are moderately or severely immunocompromised? And should additional doses, so 3 or more, of 2024-2025 COVID-19 vaccine be recommended for people ages 6 months and older who are moderately or severely immunocompromised? The work group felt that this third policy question should be recommended under shared clinical decision-making. Throughout this presentation, in the interest of time, I may say immunocompromised, but when specifically referring to moderately or severely immunocompromised, but the full details will be spelled out in the slides. Next slide. This slide shows the timeline of additional COVID-19 vaccine dose recommendations in older adults. Most recently, ACIP recommended a second dose of the 23-24 COVID-19 vaccine in February for people ages 65 years and older. Next slide. These are the current recommendations in ages 5 years and older. So 1 dose of 24-25 COVID-19 vaccine. This dose is recommended at least 2 months after the last COVID-19 vaccine dose, and people who previously are unvaccinated for COVID-19 and are receiving Novavax should complete a 2-dose initial series. Next slide. It has been some time since additional doses of COVID-19 vaccine in people with immunocompromise has been discussed by the committee. An additional COVID-19 booster dose was recommended for persons with immunocompromise in fall of 2021, an optional second mRNA booster under shared clinical decision-making in spring of 2022, and the current recommendation has been in place since April of 2023. Next slide. Looking at the current recommendations in people with immunocompromise, a homologous initial vaccination series is recommended if previously unvaccinated or post-immunoablative therapy, and are recommended to receive at least 1 dose of 24-25 COVID-19 vaccine, may receive 1 additional dose of 24-25 COVID-19 vaccine, and may receive further additional doses informed by the clinical judgment of a healthcare provider and personal preference and circumstances. These additional doses should be administered at least 2 months after the last 24-25 COVID-19 vaccine dose. Next slide. So now that we reviewed the current recommendations, I wanted to briefly revisit the policy questions under consideration today and point out that this third policy question is meant to maintain the flexibility of the current recommendations. Next slide. Now we will review the public health problem domain. Next slide. We will begin by looking at the seasonality of SARS-CoV-2. This slide shows the weekly percent of tests positive from the National Respiratory and Enteric Virus Surveillance System, or NERVS, for SARS-CoV-2, influenza, and RSV in the United States since August of 2022. What we see is that influenza, depicted in blue, and RSV, depicted in green, have clearer increases in percent positivity during the typical respiratory virus months, with periods of low percent positivity. SARS-CoV-2, shown in black, however, continues to circulate year-round. Next slide. Since 2020, COVID-19 has consistently peaked in the winter and late summer. The summer peaks of July to September are in the gray boxes, and winter peaks of December to February are in light blue. Next slide. Adding in COVID-19 associated hospitalization rates from COVIDnet in orange, the pattern of peaks in winter and late summer is consistent. Next slide. The factors impacting COVID-19 periodicity are likely multifactorial, with host, environment, and behavioral factors all playing a role, with potential contributors including timing of vaccination, waning immunity, variant emergence and characteristics, temperature and relative humidity, as well as travel, school and daycare schedules, and holidays and large group gatherings. Next slide. Now we will review data specific to older adults. Next slide. Looking at some of the hospitalization data from COVIDnet, about 70% of COVID-19 associated hospitalizations in COVIDnet are in people ages 65 years and older, and about 50% of hospitalizations are in those 75 and older. Next slide. This is information from CDC's National Center for Health Statistics. The rates of COVID-19 associated deaths are highest in those 75 and older, with rates in adults 65 to 74 being the second highest. Next slide. Shown here are the weighted US SARS-CoV-2 seroprevalence by vaccine and infection history and age, based on blood donations from October 1st to December 31st of 2023. Across the 30 years and older age groups, seroprevalence is at 99% or greater. However, those 65 years and older have a higher proportion with vaccine-only seroprevalence at 24% compared to lower compared to younger age groups. Next slide. When thinking about this older adult population, we also need to consider immunosenescence. At birth, we have large thymuses, a large group of naive T cells that do not recognize specific pathogens, and no memory T cells that do recognize specific pathogens. Beginning in early childhood, continuing throughout our lives, our thymuses decrease in size and our pool of naive T cells decreases. At the same time, as we are exposed to pathogens, we develop memory T cells that can be maintained for a lifetime and are poised to respond quickly if we see that pathogen again. By the time we reach older adulthood, we have fewer naive T cells to respond to new pathogens, but a robust pool of memory T cells from nearly every pathogen we've encountered throughout our lives. This process is called immunosenescence. Next slide. While the process of immunosenescence I just described is related to T cells are central in helping other arms of the immune system. They are necessary to generate pathogen-specific cytotoxic T cells, which kill infected cells and help stimulate B cells to generate antibodies. Therefore, the paucity of naive T cells can affect the ability for a person to clear virus-infected cells and to generate good quality and high-titer antibodies against a new pathogen. If a person does not have sufficient pool of naive T cells, as is often seen with older adults, they may not generate robust, long-lasting neutralizing antibody responses or good memory cytotoxic T cells. Next slide. Now turning our attention to people with immunocompromise. Next slide. Again, reviewing some of the information presented by Dr. Taylor. Across all age groups, about 1 in 6 persons hospitalized with COVID-19 in COVIDNet surveillance system have an immunocompromising condition. Next slide. The 3 most common immunocompromising conditions among persons hospitalized with COVID-19 are immunosuppressive therapy, solid organ malignancy, and steroid therapy. Next slide. The risk for severe outcomes during COVID-19 associated hospitalization among adults varied by immunocompromising condition status, with a higher proportion being admitted to the ICU, receiving invasive mechanical ventilation, and in-hospital death. Next slide. Now we will move to the domain equity question. Does the problem impact all populations equally? Next slide. This slide shows the age-adjusted cumulative COVID-19 hospitalizations per 100,000 by race and ethnicity in the United States from October 23 to September of 2024. As you can see, there are still notable disparities in COVID-19 hospitalization rates, particularly for American Indian and Alaska Native non-Hispanic persons, shown on this slide in the blue triangles, and Black non-Hispanic persons, shown in the red squares. Next slide. The figure on this slide shows the percent of people with multiple chronic conditions by age and race ethnicity. As we can see, there are differences by race and ethnicity in the percent that have multiple comorbidities at younger ages. This may be contributing to some of the inequity we are seeing in the burden of COVID-19 by race and ethnicity. Therefore, it is important context to keep in mind as we consider age-based recommendations. Next slide. Starting at the 35 to 39 age group on this slide, the presence of multiple chronic conditions diverges between Black and white persons, and this difference continues to increase through age 60 to 64 before converging to a similar prevalence at ages 80 and older. This convergence at later ages is likely related to survival bias. As related to the policy, age-related recommendations can address some of the racial and ethnic disparities in risk factors for COVID-19 and lead to higher uptake in populations that need it most. This equity consideration was an important driver of the 50 years and older instead of 65 and older recommendation of the second original mRNA booster in the spring of 2022. Next slide. This slide shows data from the 2021 National Health Interview Survey. Overall, the prevalence of self-reported status of immunosuppression across U.S. adults was 7% and varied by race and ethnicity, with American Indian and Alaska Native persons having the highest rates. Next slide. Also from NHIS, prevalence of self-reported status of immunosuppression varied by sex, with females having the highest prevalence, and a higher proportion of people with self-reported immunosuppression were insured. Next slide. In summary of the public health problem in adults 65 and older, SARS-CoV-2 continues to circulate year-round with peaks occurring in the winter and late summer. Adults 65 and older have the highest rates of hospitalizations due to COVID-19 compared to other age groups, though hospitalizations have decreased over time. Adults 65 and older also have the highest rates of death due to COVID-19. Age-adjusted COVID-19 associated hospitalizations are highest in those American Indian and Alaska Native non-Hispanic persons, followed by Black non-Hispanic persons, and are lowest among Asian and Pacific Islander non-Hispanic persons. The number of chronic conditions goes up by age and are higher among Black non-Hispanic persons than other racial and ethnic groups. By age 50, approximately 25% of Black non-Hispanic persons have 2 or more chronic conditions, and by age 65, approximately 50% have 2 or more chronic conditions. Next slide. And shown here is a summary of public health problem in people with immunocompromise. About 1 in 6 people hospitalized with COVID-19 have an immunocompromising condition. Risk for severe outcomes during COVID-19 associated hospitalization among adults varies by immunocompromising status. Prevalence of self-reported immunosuppression differs by race and ethnicity, sex, and health insurance status. Next slide. After reviewing this domain, the work group felt that COVID-19 disease among adults 65 years and older and among persons with immunocompromise was of public health importance. Next slide. Now we will move to the benefits and harms domain. Next slide. Dr. Link-Yellis presented on vaccine effectiveness, so I'm not going to re-review all the data that was just presented, but will include some of the summary conclusions on the coming slides. On this slide, the data is from the Vision and IV networks showing vaccine effectiveness by vaccine formulation of most recent dose. VE against hospitalization wanes over time, but VE is more sustained against critical illness, though some waning is evident. Next slide. A microsimulation modeling study published in March of 2024 compared the frequency of COVID-19 vaccination by risk group. In this study, they assigned risk groups by age and immune status and simulated vaccine or hybrid protection. The model was calibrated to the epidemiology seen in September of 2022, and the simulation of different vaccine strategies was run over a 2-year time horizon. Next slide. The findings of this study showed that annual and semi-annual or every 6-month COVID-19 vaccine doses are likely to have the largest benefit in people ages 65 years and older and people who are immunocompromised. We do want to note that incidence of COVID-19 hospitalization is currently lower than when this model was calibrated, so measures of absolute risk are likely an overestimate, and number needed to treat are likely an underestimate based on current epidemiology. Looking at the bottom red box, we see that this model estimates that semi-annual dosing, or every 6 months, would result in an annual risk reduction of 142 COVID-19 hospitalizations per 100,000 in those 65 years to 74, and 368 COVID-19 hospitalizations per 100,000 in those 75 and older. This model also estimates that 6-month dosing would result in an annual risk reduction of 310 COVID-19 hospitalizations per 100,000 in those with immunocompromise. Next slide. Summarizing the benefits in adults 65 and older. 2022-2023 COVID-19 vaccination provided increased protection against COVID-19 associated emergency department and urgent care visits and hospitalizations compared to no 23-24 dose. Protection waned to 0 against COVID-19 associated emergency department and urgent care visits and hospitalization by about 4 to 6 months. Waning patterns of the 23-24 COVID-19 vaccines appeared similar to previous COVID-19 vaccine formulations, with most durable protection for critical illness. Vaccine effectiveness against critical illness remained about 40% at 5 months after vaccination. As with previous COVID-19 vaccine formulations, effectiveness was similar across age groups. Data from prior seasons shows that an additional dose appeared to provide some additional protection. Updated COVID-19 vaccine help provide protection against COVID-19 related thromboembolic events such as ischemic stroke, venous thromboembolism, and myocardial infarction in adults 65 and older. Based on modeling data, annual and semi-annual COVID-19 vaccine dosing is likely to have the largest benefit in people 65 and older and people who are moderately or severely immunocompromised. Next slide. Now summarizing the benefits in people with immunocompromise. COVID-19 vaccines have been shown to provide protection for both persons with and without immunocompromise. Patterns of COVID-19 VE and immunocompromise were different season to season, with generally lower VE compared to non-immunocompromised, but with inconsistent weighting patterns. During the 23-24 VE against hospitalization in people with immunocompromising conditions waned to 0 by about 4 to 6 months. This inconsistency in waning patterns is likely multifactorial, including heterogeneity among those classified as immunocompromised, variation in underlying immunity in response to prior infection, and differing health behaviors such as masking and social distancing over time and by immunocompromised status. Next slide. Moving to the harms, we will first look at data from VSafe. This data is from 2022 to 2023 VSafe reporting. Injection site reactions, systemic reactions, and health impacts of COVID-19 vaccine were reported less frequently in adults 65 and older compared to younger age groups. Next slide. Among persons aged 50 years and older, injection site and systemic reactions and health impacts were reported less frequently to VSafe in subsequent dosing following the initial vaccination series of 2 doses. This was true for both Pfizer-BioNTech, shown on the left, and Moderna, shown on the right. Next slide. This data is specific to those 12 years and older with presumed immunocompromised status. Local and systemic reactions and health impacts were generally less frequently reported to VSafe after dose 4 than after the 3-dose initial series currently recommended for people with immunocompromise. Next slide. The Vaccine Safety Data Link has signaled previously for ischemic stroke in 2022 and 2023 and has been presented to ACIP, but there has been no clear and consistent evidence of a safety problem. Next slide. VSD identified statistical signals for ischemic stroke following the 23-24 COVID-19 vaccination for Moderna in people ages 65 years and older, and Pfizer for people ages 50 to 64 years. This was presented to ACIP in June. CDC and FDA are continuing to evaluate this outcome. Next slide. VSD also signaled for GBS following the 23-24 Pfizer COVID-19 vaccine. The increased rate ratio observed may or may not represent a true risk. There were insufficient doses of Moderna or Novavax COVID-19 vaccines administered in the VSD to assess the rate of GBS with those vaccines. While GBS was seen after the Janssen COVID-19 vaccine, it has not been seen following mRNA vaccines prior to the 23-24 season. Next slide. FDA's 23-24 COVID-19 vaccine safety surveillance using commercial health plans and Medicare claims databases results are expected later this year, which will provide additional information about ischemic stroke, GBS, and other outcomes. The follow-up VSD study is in progress to further examine the risk of ischemic stroke after mRNA COVID-19 vaccines during 2022-2023 and 2023-2024. Next slide. Robust safety surveillance over 3 years of COVID-19 vaccine use demonstrated that serious adverse events have been rare. Anaphylactic reactions have rarely been reported following receipt of COVID-19 vaccines. A rare risk of myocarditis and pericarditis, however, this is prominently in adults, in males ages 12 to 39 years. There has been no increased risk observed in adults 65 years and older. Whether the risk might be different in immunocompromised people is unknown. COVID-19 vaccine doses continue to be reactogenic. The rate of local and systemic reactions reported to VSafe was lower with additional doses after the initial series. Most vaccine participants have mild reactions. However, during the 23-24, at least 10% of VSafe participants reported a health impact during the 7 days post-vaccination, such as being unable to complete daily activities. Overall, reactogenicity was less frequent and severe among older adults compared with adolescents and younger adults. Next slide. Moving to the domain equity question. Are the desirable and undesirable anticipated effects demonstrated across all populations equally? Next slide. There is no evidence to suggest that COVID-19 vaccine effectiveness varies substantially by race or ethnicity. Differences in vaccine hesitancy and uptake, crowding, access to care, and prior infection could impact vaccine effectiveness, and these factors may differ by race and ethnicity. There is no evidence to suggest that COVID-19 vaccine safety profiles vary by race ethnicity. However, risk has been shown to differ by age and sex, as the risk for myocarditis is highest in adolescent and young adult males. Benefits and harms for the U.S. population are best assessed when clinical trial and study populations are optimally representative of the U.S. population. Next slide. The work group felt that the desirable anticipated effects of a second dose of 24-25 COVID-19 vaccine in adults 65 years and older were moderate to large. Next slide. The work group majority felt that the undesirable anticipated effects of a second dose of 24-25 COVID-19 vaccine in adults 65 and older were small, with the majority choosing minimal. Next slide. And when asked, did the desirable effects of a second dose of 24-25 vaccine outweigh the undesirable effects in adults 65 and older, the work group felt that it favored the intervention. Next slide. The work group felt that the desirable anticipated effects of a second dose of 24-25 COVID-19 vaccine in people with immunocompromise were moderate. Next slide. The work group felt that the undesirable anticipated effects of a second dose of 24-25 COVID-19 vaccine in people with immunocompromise were small, with a minority polling minimal. Next slide. And when asked, do the desirable effects of a second dose of 24-25 vaccine outweigh the undesirable effects in adults with immunocompromise, in people with immunocompromise, the work group felt that it favored the intervention. Next slide. The work group felt that the desirable anticipated effects of 3 or more doses of 24-25 COVID-19 vaccine in people with immunocompromise were moderate. Next slide. The work group felt the undesirable anticipated effects of the 3 or more doses of 24-25 COVID-19 vaccine in people with immunocompromise were minimal to small. Next slide. And when asked, do the desirable effects of 3 or more doses of 2024-2025 vaccine outweigh the undesirable effects in people with immunocompromise, the work group was split between favored the intervention and unclear. Next slide. Now we will move to the values domain. Next slide. Dr. Peacock presented information that applies to the next few domains earlier in this session. Looking at data from the National Immunization Survey Adult COVID module, generally, adults 65 years and older were more concerned about COVID-19 disease than younger adults. They also had higher confidence in vaccine safety and vaccine importance. Next slide. Limited data exists on the concern about COVID-19, specifically in people with immunocompromise. Next slide. And this slide shows the intent to receive a 24-25 COVID-19 vaccination from omnibus surveys. Among all adults 18 and older, 24.7% said they definitely will get a first dose of 24-25 COVID-19 vaccination. Among adults 65 and older and 18 and older with health conditions, 32.6% indicated they definitely will get a second dose of COVID-19, and 25.9% definitely will get 3 or more doses. Next slide. Moving to the domain equity question. Is there important variability in how patients or populations value the outcome? Next slide. Looking at this NIS data again, but limited to those 65 years and older. Looking at the graph on the left, Black non-Hispanic adults 65 and older were more concerned about COVID-19 disease than people of other racial and ethnic groups. When we look at the groups of columns on the middle and the right, which represent COVID-19 vaccine confidence, we see there is variability by race and ethnicity. Next slide. When asked, do adults 65 and older feel that the desirable effects are large relative to the undesirable effects, the work group opinion was moderate. Next slide. And when asked, is there important uncertainty about or variability in how adults 65 and older value the main outcomes, the work group opinion was split between probably important uncertainty or variability and probably not important uncertainty or variability. Next slide. When asked, do people with immunocompromised feel the desirable effects are large relative to the undesirable effects, the work group opinion was moderate to large. Next slide. And when asked, is there important uncertainty about or variability in how the persons with immunocompromised value the main outcomes, the work group opinion was split between probably important uncertainty about or variability and probably not important uncertainty or variability. Next slide. Now moving to acceptability. Next slide. This figure shows the percent vaccinated with 23-24 COVID-19 vaccine based on the National Immunization Survey. We see that coverage for those 65 to 74 and 75 and older, which are represented by the brown and blue lines respectively that largely overlap, is about 40%, which is notably higher than for other age groups. Next slide. This figure shows the coverage data in adults 65 and older, but with the addition of those who had received at least a second dose of 23-24 vaccine. Through the end of June, 28.9% of adults 65 and older had received at least a second dose of 23-24 COVID-19 vaccine. Next slide. And this figure shows the coverage of at least 2 doses of 23-24 COVID-19 vaccine in adults 18 and older who are immunocompromised in relation to all adults 65 and older. 5.4% of adults who are immunocompromised received at least 2 doses of 23-24 COVID-19 vaccine. Next slide. We know that a healthcare provider recommendation is a key driver to vaccine uptake. When we look at provider recommendations by age, we see that reports of a healthcare provider recommendation for COVID-19 vaccine was highest among adults 65 years and older compared to younger age groups. Next slide. Furthermore, a healthcare provider recommendation was higher among adults 65 and older who had received at least 2 doses of 23-24 COVID-19 vaccine. Next slide. In a recent survey of physicians, advanced practice providers, pharmacists, and nurses who spent at least 50% of time providing outpatient care and have vaccines administered at the worksite, showed that 70% of respondents reported recommending a second COVID-19 vaccination to eligible patients ages 65 and older most of the time or always. These recommendation results were similar by provider type. Next slide. And in this same survey, 68% of respondents reported recommending a second COVID-19 vaccination to patients who are immunocompromised most of the time or always, and again, the recommendations were similar across provider type. Next slide. The work group obtained feedback from organizations that focus on older adults, people with immunocompromised, healthcare providers, and pharmacists. We received feedback that age-based recommendations or universal recommendations were preferred over risk-based or shared clinical decision-makings, as there are implementation challenges for both on top of an already complicated vaccine schedule, and that shared clinical decision-making recommendations can appear to have lower confidence and are difficult to communicate. Additionally, frequent changes in vaccine recommendations create confusion. Most preferred 1 to 2 total doses of COVID-19 vaccine per year, and to reiterate that self-attestation of being moderately or severely immunocompromised is permissible. Next slide. Moving to the domain equity question, is the intervention equally acceptable across all populations? Next slide. Among adults 65 years and older responding to the NIS through June of 2024, vaccination coverage differed by race and ethnicity. Coverage of at least 2 doses of 23-24 COVID-19 vaccine was statistically higher in Black non-Hispanic adults compared to white non-Hispanic adults, and vaccination coverage was higher in urban areas compared with rural areas. Next slide. Among adults with immunocompromising conditions responding to the National Immunization Survey, vaccination coverage differed by race and ethnicity. Coverage of at least 2 doses of 23-24 COVID-19 vaccine was statistically lower in Asian adults compared to white non-Hispanic adults. Vaccination coverage was higher in suburban areas compared to rural areas. Vaccination coverage was higher in those with health insurance compared to without. And vaccination coverage was higher among those with a healthcare provider recommendation. Next slide. When asked, would recommending a second dose of 2425 COVID-19 vaccine for adults 65 years and older be acceptable to key stakeholders, the work group opinion was probably yes or yes. Next slide. When asked, would recommending a second dose of 2425 vaccine for people ages 6 months and older with immunocompromise be acceptable to key stakeholders, the work group opinion was probably yes or yes. Next slide. And similarly, the work group felt that 3 or more doses of 2425 COVID-19 vaccine for people ages 6 months and older with immunocompromise would or probably would be acceptable to key stakeholders. Next slide. Next, we'll review the feasibility domain. Next slide. This slide comes from a survey of general internal medicine physicians regarding pneumococcal and HPV shared clinical decision-making. Most physicians strongly or somewhat strongly argued or agreed that shared clinical decision-making required more time than routine recommendations. Most respondents also thought that it creates confusion, and just over 40% either strongly or somewhat strongly agreed that shared clinical decision-making was hard to explain to patients and that they did not know how to implement this type of recommendation as ACIP intended. While these data are not COVID-19 vaccine specific, they can inform our understanding of acceptability of shared clinical decision-making for providers. Next slide. Again, with the domain equity question, is the intervention equally feasible to implement across all populations? Next slide. Social determinants of health drive differences in vaccine access, creating disparities in uptake. Additional dose recommendations may further increase these disparities. For example, decreased access with the end of the Bridge Access Program, increased disability prevalence with age, creating potential challenges getting to vaccination sites, and decreased access in settings already having challenges such as long-term care. And in the absence of an ACIP recommendation, decreased access if required to pay out of pocket. Next slide. When asked, is a second dose of 2425 COVID-19 vaccine feasible to implement among adults 65 and older, the work group majority opinion was yes, with a minority opinion of probably yes. Next slide. When asked, is a second dose of 2425 vaccine feasible to implement among persons with immunocompromise, the work group opinion was split between yes and probably yes. Next slide. And when asked, are 3 or more doses of 2425 COVID-19 vaccine feasible to implement among persons with immunocompromise, the work group opinion was split between yes and probably yes. Next slide. Moving to the resource use domain. Next slide. This slide was shown as part of Dr. Prosser's presentation. We wanted to highlight the base case ICER of 356,534 per quality adjusted life year for a second dose of 2425 vaccine in adults 65 and older. Next slide. And on this slide, we see that when we vary the probability of hospitalization and increase it, the ICERs were more favorable across all age groups. Next slide. And moving to the domain equity question, is the intervention a reasonable and efficient allocation of resources across all populations? Next slide. A second dose of COVID-19 vaccine is most cost-effective in older adults in whom burden is the highest. A second dose of COVID-19 vaccine is likely cost-effective in populations with higher prevalence of risk factors such as underlying conditions, which increase their probability of hospitalization due to COVID-19. We do not have information specific to cost effectiveness of additional doses in people with moderate or severe immunocompromise. Next slide. In summarizing the resource use domain, the base case ICER of a second dose of 2425 COVID-19 vaccine in adults 65 and older was $356,534 per quality adjusted life year. For all COVID-19 vaccines, if list prices were reduced, vaccination would be more cost effective. Next slide. When asked, is a second dose of 2425 COVID-19 vaccine in adults 65 and older a reasonable and efficient allocation of resources, the work group response was split between yes and probably yes. Next slide. When asked, is a second dose of 2425 vaccine in people 6 months and older with immunocompromise, the work group response was split between yes and probably yes. Next slide. And when asked, are 3 or more additional doses of 24-25 COVID-19 vaccine in people 6 months and older with immunocompromise, the work group responses varied between probably no, probably yes, varies, and don't know. Next slide. And we will finish with work group interpretations. Next slide. A harmonized recommendation for older adults and immunocompromised persons would ease implementation and help simplify an already complicated immunization schedule. Some work group members, however, were not in favor of a harmonized recommendation and having differing recommendations in the 2 populations under consideration. The relative absence of data makes selecting the correct number of recommended doses challenging for immunocompromised persons, especially given the heterogeneity in this population. Allowing for flexibility in additional doses may allow these patients to time vaccination around travel, life events, chemotherapy, etc. Next slide. There was low uptake of more than 1 dose of 23-24 vaccines. Complexity of existing schedule has led to reduced adherence by clinicians. Provider recommendations directly impact uptake, and provider education and making sure providers are on board is critical to ensuring adherence. While simpler vaccination recommendations aren't perfect, they may benefit in increasing vaccine uptake and enhancing protection at the population level. Focusing on the number of doses of 24-25 rather than additional doses and recommendations could help reduce complexity and improve uptake. Next slide. Shown here are the summary work group judgments for a second dose of 24-25 COVID-19 vaccines in adults 65 and older. Next slide. For the overall balance of consequences, the work group was split majority opinion of the desirable consequences clearly outweigh undesirable consequences in most settings, with the majority of the work group feeling the desirable consequences probably outweigh undesirable consequences in most settings. Next slide. The work group felt there was sufficient information to move forward with a recommendation. Next slide. And for the type of recommendation, the majority polled to recommend the intervention of a second dose of 24-25 COVID-19 vaccine in adults 65 and older. Next slide. Again, this slide shows the work group judgments of a second dose of 24-25 COVID-19 vaccines in people ages 6 months and older with moderate or severe immunocompromise. Next slide. For the overall balance of consequences, the work group majority opinion was that the desirable consequences probably outweigh undesirable consequences in most settings, with a minority of the work group feeling that the desirable consequences clearly outweigh undesirable consequences in most settings. Next slide. The work group again felt that there was sufficient information to move forward with a recommendation. Next slide. For the type of recommendation, the majority polled to recommend the intervention of a second dose of 24-25 COVID-19 vaccine in people ages 6 months and older with moderate or severe immunocompromise. Next slide. And finally, shown on this slide are the work group judgments of 3 or more doses of 24-25 COVID-19 vaccines in people ages 6 months and older with moderate or severe immunocompromise. Next slide. Overall, the balance of consequences, the work group felt that the desirable consequences probably outweigh undesirable consequences in most settings. Next slide. Again, the work group felt there was sufficient information to move forward with a recommendation. Next slide. For the type of recommendation, the majority polled to recommend the intervention of 3 or more doses of 24-25 COVID-19 vaccine in people ages 6 months and older with moderate or severe immunocompromise based on shared clinical decision-making. Next slide. And wrapping up, although the work group considered the first 2 policy questions separately, they ended up polling for a similar recommendation of second dose in both adults 65 and older and people 6 months and older with moderate or severe immunocompromise. This is why the vote language for the second question differs slightly from the policy question to specify ages 6 months to 64 years. Next slide. And I just want to acknowledge the incredible group of people that contributed to this presentation. Next slide. And now I'll hand it off to Lakshmi to present clinical considerations. Thank you.
Hello, my name is Dr. Lakshmi Panayottakopoulos, and I'll be presenting clinical considerations for the use of 2024-2025 COVID-19 vaccines in the United States. Next slide. On June 27, 2024, ACIP recommended 2024-25 COVID-19 vaccination for everyone ages 6 months and older. On August 22nd, FDA approved and authorized the Moderna and Pfizer-BioNTech mRNA 2024-25 COVID-19 vaccines, and on August 30th, FDA authorized the Novavax 2024-25 COVID-19 vaccine. The interim clinical considerations for use of COVID-19 vaccines website was rapidly updated with detailed recommendations for use after both of these FDA actions. And on September 10th, an MMWR policy note was published outlining the recommendations. Next slide. So during today's talk, I will review the use of 2024-25 COVID-19 vaccines, starting with the routine schedule and the proposed recommendations for a second dose in adults ages 65 years and older. I will then discuss the use of 2024-25 COVID-19 vaccine for people with moderate or severe immunocompromise and the proposed recommendations for use of additional doses. And finally, I will highlight some updates to the clinical considerations. Next slide. Now I will discuss the routine schedule, which is the schedule for people without moderate or severe immunocompromise. Next slide. So children ages 6 months to 4 years old are recommended to receive an initial series of either 2 doses of Moderna vaccine or 3 doses of Pfizer-BioNTech vaccine. They need at least 1 dose of the 2024-25 COVID-19 vaccine, either as part of or in addition to their initial series. And for this age group, all doses should be homologous, that is, from the same manufacturer. Next slide. Everyone ages 5 years and older needs 1 dose of 2024-25 COVID-19 vaccine. This 24-25 COVID-19 vaccine dose is recommended at least 2 months after the receipt of the last or prior formulation COVID-19 vaccine dose. As a reminder, mRNA COVID-19 vaccines are authorized or approved for ages 6 months and older, and Novavax COVID-19 vaccine is authorized for ages 12 years and older. People who are previously unvaccinated for COVID-19 and are receiving Novavax should complete a 2-dose initial series. Next slide. The proposed recommendations for people ages 5 to 64 years will remain the same. Next slide. The proposed recommendations for adults ages 65 years and older are for 2 doses of the 2024-25 COVID-19 vaccine at a recommended interval of 6 months and a minimum interval of 2 months. Having a recommended and minimum interval is standard for all vaccines and additionally allows for some flexibility in timing of doses. For those adults 65 and older who have never received a COVID-19 vaccine and are receiving their first dose of Novavax vaccine, 2 doses are recommended as their initial vaccination series, followed by a 3rd dose of any age-appropriate COVID-19 vaccine 6 months after their 2nd dose with the same 2-month minimum interval. Next slide. Now I will go through the recommendations for people with moderate or severe immunocompromise. Next slide. People ages 6 months and older who are moderately or severely immunocompromised are recommended to get an initial COVID-19 vaccine series. This consists of 3 homologous mRNA COVID-19 vaccine doses or 2 Novavax COVID-19 vaccine doses. Of note, previously vaccinated people who subsequently undergo hematopoietic cell transplant and CAR T-cell therapy or B-cell depleting therapy are recommended to undergo revaccination and receive the initial vaccination series. As in the routine schedule, everyone needs at least 1 2024-25 COVID-19 vaccine dose. Currently, people who are immunocompromised may receive one additional 2024-25 COVID-19 vaccine dose and have the option to receive further additional doses informed by healthcare provider judgment and personal preference at least 2 months after their last dose. This is another way of saying that additional doses are currently a shared clinical decision-making recommendation for people who are immunocompromised. Next slide. The proposed recommendations for people who are immunocompromised are as follows. The initial COVID-19 vaccine series would remain the same. The proposed recommendation for 2024-25 COVID-19 vaccine doses is for at least 2 doses with a recommended interval of 6 months and a minimum interval of 2 months. One of these 2 doses may be a part of the initial vaccination series, and at least one of the 2 doses should be received 6 months after completion of the initial series. Beyond that, the additional doses for 2024-25 COVID-19 vaccine would remain under shared clinical decision-making. Next slide. Now to review some updates to the clinical considerations. Next slide. Specifically, I will review updates to language around age transitions, interchangeability of COVID-19 vaccines, and remind the committee on guidance for COVID-19 vaccination following SARS-CoV-2 infection. Next slide. So for for age transition, CDC recommends that people receive the age-appropriate vaccine product and dosage based on their age on the day of vaccination. If a person moves to an older age group between vaccine doses, they should receive the vaccine product and dosage for the older age group. For children who transition from age 4 to age 5 years, and children who are moderately or severely immunocompromised and transition from age 11 to age 12 years, the option to administer a lower dosage is no longer authorized. Next slide. The main interchangeability language remains the same, in which COVID-19 vaccine doses from the same manufacturer should be administered whenever recommended. However, there are circumstances in which vaccines from different manufacturers may be administered, including the same vaccine not available at the time of the clinic visit, previous dose unknown, person would not otherwise receive a vaccine dose, and contraindication to a previously received COVID-19 vaccine. Of note, a VAERS report is not indicated in these circumstances, meaning they are not considered errors. Next slide. And now I will discuss additional guidance on interchangeability for Novavax vaccine. People ages 12 years and older who are initiating vaccination with Novavax and receive the first dose of Novavax should complete a 2-dose initial series with Novavax vaccine. However, if more than 8 weeks have elapsed since the receipt of the first dose, any 2024-25 COVID-19 vaccine may be administered. Next slide. And since this question comes up frequently, I wanted to remind everyone of COVID-19 vaccination guidance following SARS-CoV-2 infection. COVID-19 vaccine is recommended for everyone ages 6 months and older, regardless of prior symptomatic or asymptomatic SARS-CoV-2 infection, including people with long COVID. People who recently had SARS-CoV-2 infection may consider delaying a COVID-19 vaccine dose by 3 months from symptom onset, or positive test if the infection was asymptomatic. Individual factors such as risk of severe COVID-19 and current indicators of community transmission should be taken into account when determining whether to delay getting a COVID-19 vaccination after infection. Next slide. Now for a summary. Next slide. I'd like to emphasize that the COVID-19 vaccine schedule is straightforward for the majority of the population. Children ages 6 months to 4 years who are unvaccinated should receive a multi-dose initial series with a 2024-25 COVID-19 mRNA vaccine. Those who have previously completed an initial series should receive 1 dose of a 2024-25 mRNA vaccine from the same manufacturer as the initial series. People ages 5 to 64 years should receive 1 age-appropriate dose of the 2024-25 COVID-19 vaccine. And the proposed recommendation for people ages 65 years and older is that they receive 2 doses of any 2024-25 COVID-19 vaccine spaced 6 months apart. Next slide. People who are moderately or severely immunocompromised and unvaccinated should receive a multi-dose vaccination series with an age-appropriate 2024-25 vaccine and receive 1 2024-25 vaccine dose 6 months after completing the initial series. Those who have previously completed an initial series should receive 2 doses of an age-appropriate 2024-25 COVID-19 vaccine spaced 6 months apart, and they may receive additional age-appropriate doses under shared clinical decision-making. Next slide. To summarize, the interim clinical considerations for use of COVID-19 vaccines in the United States webpage continues to be rapidly updated to reflect the most recent COVID-19 vaccine guidance. The COVID-19 vaccine recommendations have moved towards simplicity and the standard language used for the ACIP routine immunization schedules and general best practices. And recommendations for the use of additional doses in older adults and people with moderate and severe immunocompromise will be updated following the October ACIP meeting votes. Next slide. I would like to acknowledge everyone on this slide, especially our interim clinical consideration writers, Mary Chamberlain and Susan Goldstein, who work day and night to ensure this document stays relevant and accurate. We are happy to take any questions on the evidence to recommendations framework and clinical considerations. Thank you.
So thank you very much. That was an amazing couple of presentations. We will need motions following these presentations, but let's take questions and any discussion first. Dr. Lear.
So thank you for the presentations. And I'd like to say thank you to the public who've been sending in many emails and public comments about this topic. There's been a strong push to offer the vaccine to anyone who wants it, not just over 65 and not just immunocompromised. They feel that if they have a particular indication, such as an ill family member, and they want to protect themselves, they're asking for the ability to get the additional vaccines. I am not comfortable with that personally. My particular question is, if someone who doesn't have one of these indications wants to get the vaccine and pay for it out of their own pocket, I don't see a particular reason that we're saying they cannot do that. It's like a medication, you can do it off-label from a doctor's office. Am I mistaken in that, or is there something in here that says that they actually cannot do that? Thank you.
Thank you for that question. That is something that came up during workgroup discussions. And I guess the 2 things that were part of those discussions was, 1, that's not something that we do for other vaccines that aren't recommended typically. And the other one would just be the cost, and just looking at the economic analysis presentation and just looking at it from a societal perspective as opposed to the individual perspective that you mentioned. So I think it would be unusual to have that for COVID-19 vaccine when that's not a standard practice for other vaccinations.
But just to clarify, I think Dr. Lear's question was about people paying out of pocket for off-label use of a vaccine, which is something that is generally allowed and that's considered part of medical practice, I think. So there's a number of other questions. Dr. Asturias?
Yes, thank you, Edwin Asturias, and a tour de force indeed of extremely well put together data and also a very important topic. I do have a question for your clinical recommendations for slides 19 and 20, and that has to do, is the impact of the two-dose recommendation vaccines based on the biannual seasonal effect, or the timing would not impact the desirable effect? In other words, when we are saying you can get two doses spaced 6 months apart, does it matter if I get it just before, where we are seeing just the pattern of the season? Is that ideal or preferable, rather than, getting the vaccine whenever I want and then, not sort of tackling that effect of the biphasic sort of pattern?
There were a lot of things that went into kind of that 6-month recommendation, including the waning of vaccine effectiveness, cost effectiveness, feasibility, values, attitudes. There's a lot of things, even when surveying the practitioners who take care of immunocompromised patients. Many of them felt that, once a year vaccination was sufficient, just because it's hard to get patients back in and get them vaccinated. So there were a lot of things that were taken into account in addition to seasonality. I think with the seasonality, we've seen surges in the summer, mostly in July and August, and then also in the winter, December, January. However, some of that has not entirely settled yet and is still unpredictable. So the 6-month interval is the recommendation, but the 2-month minimum interval is what gives the flexibility to time that additional dose around some of the other factors, some of the local surges and the preference and major events or travel, et cetera, if that makes sense.
Yeah, I appreciate the clarification, but I guess what I'm trying to say is, should the language include anything about ideally timing it to sort of before these surges that we are sort of starting to see, or we should leave it at the discretion of everyone?
I mean, I think that that's something that we can turn to the committee and get some additional feedback on, now that you've seen a lot of the data that went into the current wording. So not sure if anyone has any thoughts about that.
Well, I'm not sure that seasonality has settled into a predictable enough pattern that we can quite do that, although obviously it's what we would like to be able to do. Dr. Sneas?
Hi, thank you so much for that presentation. As someone, practicing physician who sees both adults and kids and vaccinates adults and kids, there's a lot of information to take in. I have this is more of a clarification for slide 15 on the interim clinical considerations for interchangeability of COVID-19 vaccines. This slide refers to patients ages 6 months to 4 years. Is that correct? And I'm just wondering about whether that should be clarified where it says whenever recommended, because the recommendation is to use a homologous dose, except, I guess, in these circumstances listed.
So in addition to 6 months and 4 years, it would also apply to people who are immunocompromised who are recommended to get a homologous series, and also people receiving Novavax who are previously unvaccinated.
Okay. Thank you.
Ms. Moser?
Thank you. Just in addition to what Jamie said, and Melinda, to your response, some of the people who commented in the online forum said that even when they were willing to pay out of pocket, they weren't able to get the vaccine. So, and these were caregivers of high-risk people. So if that is something that's allowed, then probably we need to do something to make sure that providers and pharmacists know that they can do that. And then the second question is related to, one other point about that was that there were also educators and parents of young children concerned that the child would get the families will get the vaccine in the fall, and then they have to wait the whole year to be able to get the vaccine again, and it's after school starts, and so the kids are coming home with the virus. So there are a couple of timing issues related to that. And then just my final question is that when people are infected, I was trying to find it in the slides and I didn't, but my recollection was that they can defer for 3 months is what we're telling them. But now we're saying, you know, they can get vaccinated every 6 months. And so I'm just wondering what the basis for that discrepancy is.
So this is Dr. Fleming-Dutra, and I did want to clarify a few comments about the off-label issue. While that is allowed under the practice of medicine, there are some complexities that make that a little bit more difficult, and we'll hear some more about that in a later session. But there are some, I think, in certain jurisdictions, certain vaccinators are not able to give vaccine that are not ACIP recommended. So although a physician may be able to prescribe it off-label, you know, a patient may have difficulty accessing said vaccine if it's not under an ACIP recommendation, so that is something to consider. And then specific to COVID-19 vaccines, which are covered under the Countermeasure Injury Compensation Program, they do have to be used in alignment with HHS guidance, so FDA and CDC, and so if they are used outside of that guidance, there are some complexities about whether the vaccinator and the will be covered under the Countermeasure Injury Compensation Program should there be a claim to that program, or HRSA colleagues might be able to add more to that. But I just wanted to clarify that there's a few complexities here.
Thank you.
Dr. Shaw and then Dr. Talbot.
Thanks. So, yeah, Ms. Roper and Dr. Panagiotakopoulos, there were two incredible presentations. I had a question on the clinical consideration slide deck for slide 17. So with regard to the third point about considering the risk of severe COVID-19 and current indicators of community transmission when determining whether to delay getting a vaccination after infection, I was trying to figure out who that applied to because I thought part of the point of delay was the possibility that pre-existing antibodies could bind to the spike protein generated by the vaccine, mRNA or Novavax, and inhibit the immune response. So is this point particularly relevant for substantially immune-compromised individuals when we don't expect any vaccine response? So for older individuals, I mean, they would probably have pre-existing antibodies, though diminished. It is quite complicated, but I was trying to figure out what the intent was for that particular point.
So that statement is not meant for any specific population, and a lot of this data comes from low rates of reinfection in the first 3 months following your infection. And so some people might consider delaying the vaccine if they have a low risk of getting reinfected, but you could also move that up and get it sooner than 3 months if, for example, you're about to travel or you're about to be in a higher risk situation.
Okay, I mean, I think, right, if you do it too soon, then I think the possibility is that the vaccine will not be effective, I think, because of pre-existing antibodies from the prior infection. Is that it?
Quick point, this would be a great challenge for some of our scientific colleagues. If we could have a COVID vaccine that would create antibodies to last a year, that would alleviate some of these issues. So it's on my wish list.
Can we get the slide with the policy proposal up? Oh. Sorry,
So
Dr. Chu.
Sorry, I just have a minor point, which was to concur with Dr. Shaw that I think the the 2 months in one slide and 3 months in another is a little bit confusing recommendation-wise. I think there's pretty good data to show that you have persistent immunity from an infection for 3 to 4 months that prevents you from getting another infection in that protected time period due to high titers of antibody. So I'm wondering if rather than changing the 3-month recommendation for everybody else, that you could potentially say that should receive 2 doses of the age-appropriate vaccine, spaced 6 months apart, as close as 3 months after the last one, just to align the language.
So just to clarify, Dr. Hsu, you were specifying to change the minimum interval language. I don't know if our FDA colleagues want to comment at all. There also are minimum intervals noted in the EUA as well as the package inserts that.
Dr. Lehr.
So since I'm on a roll today, I'd like to make a motion in favor of the ACIP voting language as presented on this slide. I won't read it out for everyone. Thank you.
We have a motion. Is there a second? Dr. Jameson? So we have a motion and a second. I am told that we need 3 separate votes. So, Dr. Lehr, would you like to make?
I'll keep on going and make a motion for the second bullet point. And Dr. Jameson?
Well, just a minute. For clarity, let's start with the first bullet point for 65 and older.
I'd like to make a motion for the first bullet point. The ACIP recommends a second dose of 2024-2025 COVID-19 vaccine for adults ages 65 years and older.
Second.
Okay, we have a motion and a second for the first recommendation on the slide. Are there any additional questions or comments related to this motion? Okay, moving on to the second.
For the second bullet point, I make a motion that the ACIP recommends a second dose of 2024-2025 COVID-19 vaccine for people ages 6 months through 64 years who are moderately or severely immunocompromised.
Thank you. We have a motion. Do we have a second?
Second.
We have a second from Dr. Jameson. Are there any additional comments or questions related to the second motion? Okay, I don't see any. Regarding the third policy proposal, is there a motion?
I would like to make a motion. This is Dr. Lehr. ACIP recommends additional doses, i.e. 3 or more doses, of 2024-2025 COVID-19 vaccine for people ages 6 months and older who are moderately or severely immunocompromised under shared clinical decision-making.
Dr. Lehr has made a motion for the third recommendation on the slide. Is there a second?
This is Denise Jameson. I second.
And Dr. Jameson has seconded the motion. So that was quick. Good work, all. Are there any questions or comments specific to the third motion? Okay, we do have a couple of liaison members who would like to speak, so I will call on them. I ask them to please be brief in their comments. Ms. Hayes?
Yes, Carol Hayes with the American College of Nurse Midwives. I had heard that the current vaccine is not necessarily 100% aligned with the circulating strains of the virus, and I was wondering if anybody had any data on that.
Is Dr. Thornburg on the line by chance? And if you could pull up the backup slide. Hang on just a second, I'm sorry. Backup slide 121.
Were we asking for Dr. Thornburg? Dr. Thornburg, are you on?
Or Dr. Silk, are you on? And could you answer that question?
Yeah, and I'm here, thanks. I don't think Dr. Thornburg is on the line, but I'll give it a go. And from my understanding is that, as you're seeing here, these are sublineages of JN1. And so I don't have specific data from our lab or otherwise, but what I'm told is that they are expected to provide good protection, given that they're all subsets or sublineages of the strains that are in the vaccine. I hope that helps a little.
It does actually, because I've heard a lot of hesitancy about getting it because people are saying, oh, well, I've heard it doesn't match this year. So thank you very much. I will confidently recommend.
Thank you. Dr. Schmader.
Yes, thanks. First, AGS wants to go on record supporting the recommendation for an additional dose of COVID vaccine in people 65 and older. AGS also notes that an important population is likely to benefit from an additional dose does not fit the policy language for 65 plus and immunocompromised. Our nursing home residents who are younger than 65 years old, and we take care of a lot of those individuals. And all people residing in nursing homes, including those less than 65, are high risk for severe COVID, high transmission areas, staff have low vaccination rates, as you know, and they could benefit from an additional dose. So I don't know where to include that, maybe in the clinical guidance, but it's something to consider. Thank you.
Thank you. Dr. Hopkins.
Thank you very much for the opportunity to comment from NFID. Vaccines are clearly our best defense to help protect against these respiratory diseases, yet our vaccination rates remain well below our goals. In fact, a recent NFID survey shows that less than 1 in 5 U.S. adults are concerned about flu, COVID-19, RSV, or pneumococcal disease, and only 38% say they'll definitely get a flu vaccine, and only 26% will definitely get an updated COVID-19 vaccine this season. Top reasons cited for not getting vaccinated include concerns about side effects and distrust of vaccines in general. To address this problem, we require a multifaceted strategy. As healthcare professionals, we need to address concerns about side effects and safety head-on with clear and transparent communication. As ACIP reviews the data on vaccine effectiveness, we need to remind the public that even when vaccines don't prevent disease entirely, vaccination can help prevent against severe complications, including hospitalization and death. As a society, we must also address issues and other barriers, beginning with establishing the Vaccines for Adults program. The NFID Call to Action report on strategies to improve adult immunization in the U.S., developed with more than 25 partner organizations, includes recommended strategies at the healthcare system, provider, patient, and legislative policy levels. Now's the time to begin developing and implementing these strategies to improve public health. And we at NFID remain committed to working with CDC and our partners to reduce the overall burden of vaccine-preventable diseases across the U.S. Thank you.
Thank you. Are there any additional questions or comments from the committee? Seeing none. We need to do public comment at 3:45, correct? So I think we can take a break until 3:45. Please be back for public comment. Thank you.
Hola, se sigue traduciendo.
25 minutes? 25 minutes, okay. Okay. So, okay, just, I guess, they'll let us, we're gonna go on a break and then we gotta switch over. Okay. All right.
Okay, good afternoon. Can I ask everyone to please take their seats? It's now 3:45, and we'll reconvene the meeting to begin oral public comment. I'd like to welcome and thank our public comment speakers for addressing the committee today. All of the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and in order to make it through all of the listed speakers, it's extremely important that each speaker limits his or her remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. Our committee appreciates diverse viewpoints that are respectful in nature and focused on the issues being discussed at our two-day meeting. Thank you again to our speakers, and we look forward to your comments. Mr. Louis Ferdinand, are you on?
I am, yeah.
Okay, you can start.
Great, yeah, hi. I'm Noah Louis Ferdinand. I'm the communications coordinator at Voices for Vaccines. I wanted to comment on a few of the things being discussed today. The first of which is the addition of the high-dose flu vaccine to the VFC program for those who have had transplants. I think that's great because I think we, as a country, really don't do a whole lot to protect those who are vulnerable through flu vaccination, right? Uptake rates for those who are young and healthy are often quite low. Anecdotally, as someone in their 20s, and a lot of my friends are super enthusiastic about getting their flu vaccines. So I think just having that option for those who might need more protection is a generally good thing. As for pneumococcal vaccination, expanding that recommendation, one thing I'd be curious to see when considering making decisions like this is some data on how likely people are to take up vaccines when they're recommended to get multiple in a year or a season, adults that is. So, you know, maybe an adult who's 50, they're supposed to get a COVID vaccine, a flu shot, you know, potentially a pneumococcal vaccine, and I think the shingles one right around then too. You know, and you think about, okay, what's likely to influence whether they take that up, right? Do they understand the importance of all those vaccines? Is there a perceived need? You know, you have to take time off if it's multiple appointments. It's not the most fun thing in the world to get a shot, right? Maybe feel a little unwell afterwards for a bit. I'm guessing these things probably factor into people's decisions, again, when recommended multiple vaccines. And so I would just want to know if that affects uptake in some way or another. It might, I don't know, but just curious to see that. Whether that's the case, because I feel like that's an important public health, you know, implementation question. You know, are the people who are getting the flu shot the ones who are also getting the COVID vaccine or pneumococcal vaccine or whatever? So I'd just be curious. You know, I think public health professionals, you know, this is just another thing on the schedule, and certainly, you know, if it's voted on, the evidence and the, you know, the efficacy and the safety are there, but people are rarely so clinical when making these decisions. So I would just wonder if the uptake varies based on how many vaccines are recommended in a season. That'd be great. Thank you.
Thank you for your comment. Our next speaker is Mr. Wang. Mr. Wang, are you on?
Hi, thank you so much for having me. Honorable Chair Dr. Talbot, Executive Secretary, and members of the CDC, ACIP, and the public, thank you for this opportunity to speak with you today. My name is Andrew Wang. My remarks today have been submitted formally as public comments to the Federal Register. I have no financial conflicts of interest and have zero financial investments in any company that produce or manufacture COVID vaccines. As a public health professional and health services researcher, I hold a doctorate in public health and master of public health with a specific focus on health disparities, working to achieve health equity in vulnerable and under-resourced populations at a federally qualified health center in Chicago. My remarks today do not represent my employer or any other affiliate institutions, but I do represent the voice of many in the public who continue to have serious concerns of the ongoing COVID pandemic. My comments today are to those attending this meeting and the medical community who have adopted living with COVID. This infectious disease that continues to affect hundreds of millions of Americans every year and requires your ongoing attention to protect the public's health and well-being. This requires at least minimally twice a year or at least every 6 months access to COVID vaccines for people of all ages, regardless of health status, and I urge you to consider revising your policy question to match this. By continuing a restrictive approach to access, this ultimately creates confusion and undue barriers for vulnerable people and discourages high-risk people from getting needed vaccine boosters. People of all ages, including those who are under the age of 65 years of age, should have the choice and option to receive another COVID vaccine, and more specifically for the upcoming 2025 calendar year during the spring of 2025 and the fall of 2025. The public will continue to be vaccine hesitant if the ACIP committee introduces ongoing unnecessary and burdensome and complex criteria. An economic analysis, unfortunately, is flawed when the populations on all categories do not obtain the co-vaccine. The co-vaccine schedule must address waning efficacy in the months following vaccination, as well as emergence of any new strains by recommending updated vaccines for all ages, at least every 6 months. This aligns well with the approach by the FDA, which has taken a more active approach to align the vaccination variant with the most dominating and circulating variant. Ensuring access at least twice a year result in the most effective protection against death, hospitalization, infection, and potentially long COVID. The CDC's clear and unequivocal recommendation on co-vaccine at least twice a year for all ages will influence recommendations for all healthcare providers coverage by health insurance. Moreover, it will improve public awareness in people of all ages about the importance of having a recent vaccination within the last 6 months to provide the best protection as part of a multi-layer approach to preventing illness. The CDC must ensure equitable and affordable access as well to these updated co-vaccines and prevent limited access because of financial constraints or demographics. The CDC's Bridge Vaccine Access Program ended in August of 2024, leaving many people who are uninsured or underinsured with limited access to co-vaccines. I ask you, with your role, to support no-cost access to co-vaccines to prevent and reduce this barrier. Thank you so much for having me today, and I appreciate your sincere consideration.
Thank you, Mr. Wang. Our next speaker is Mr. Hennessy.
Can you hear me?
Yes, we can. Please proceed.
The CDC must allow for anyone to get a second COVID shot 2 months after the first, not just immunocompromised. Please alter the voting language of the upcoming vote for keeping the same immunocompromised access to removing the immunocompromised language and expanding it to all groups equally. Limiting access only causes to the immunocompromised causes unnecessary barriers to access while also limiting the best possible protection. Allowing anyone to get a new primary series will benefit all of us, but also people in your lives too. Additional shots have proven to be safe and effective, and a new primary series of Novavax, for instance, even primes the immune system better than just one. So CDC must allow access for everyone to get a second shot 2 months later, and then a third 6 months after that for a new primary series. And also make sure insurance covers this and restore the Bridge Access Program. COVID has caused immune system damage to our entire population, and we need additional vaccine doses for everyone. CDC has confirmed that COVID spikes in both summer and winter, and even low periods of transmission aren't that low anymore. We need to adopt a more frequent vaccine strategy with updated COVID vaccines every 6 months instead of just in the fall. mRNA must update their vaccine every 6 months, while Novavax should be studied to see if it still mounts an immune response to the latest variant or needs to be updated. Vaccines wane between 4 to 6 months, and needless summer surges are a result of CDC's failed attempt to treat COVID like the flu and put vaccination schedule on an arbitrary timeline. You mentioned it's not standard practice to allow off-label use, but COVID has changed normality for us and we must recalibrate. Mandy Coven claimed yesterday that the best way to prevent long COVID is to get vaccinated, but because of the current restrictions in vaccine dosing and the waning effects of vaccines after a few months, Americans literally cannot get the best possible protection she was advertising most of the year. Multiple Novavax shots also offer additional immune protection and Matrix M benefits. Allowing broader access will help redefine what fully vaccinated means and keep us all healthier. One of you even said we need a COVID vaccine that can create antibodies to last a year, and this is how we can achieve it. Looking forward, ACIP must conduct more expedited funding and research into intranasal COVID vaccines that are non-annotated, such as Castlevac's and Novavax. We need these in addition to intramuscular vaccines. Finally, ACIP must push to make non-annotated H5N1 vaccines available to everyone, especially farmers, but also pressure manufacturers to make vaccines that actually stop transmission. We cannot settle with low-efficacy H5N1 vaccines once a year like we have with COVID and the flu. Settling for good enough and putting H5N1 vaccines on the same schedule as fall flu shots would result in needless death. It is the CDC's job to actually prevent disease, not just manage them. Don't make the same mistake you did with COVID. We need preventative vaccines. Thank you.
Thank you. Mr. Nierenberg?
Hi, can everyone hear me?
Yes, we can. Please proceed.
Okay, thank you. I wish to thank the ACIP for the opportunity to address committee members and the public, and I wish to thank presenters for such comprehensive, lucid presentations. I will do my best and obviously fail to be brief. The relative stagnation of vaccine innovation with influenza in the clinic, despite extensive breakthroughs at the bench, is unsettling. Clinically available options have scarcely changed since the era of Salk and Francis, in spite of an extraordinary profusion of discovery. In particular, today, we've seen disappointing effectiveness against H3N2 viruses, which in part is likely attributable to the emergence of egg adaptation during vaccine production, and yet most of our influenza vaccines continue to be made in eggs. We urgently need stronger support at the clinical trial, regulatory, and manufacturing level to modernize approaches to dealing with influenza. The burden of injections required each season is growing to be wearisome for much of the public. A combination vaccine would be very helpful in reducing that. Still, non-trivial open questions persist, such as whether or not to separate sites of vaccination for influenza and COVID-19 vaccines, or whether there may be an advantage to using the same arm for vaccination each season. Naturally, how one gets vaccinated is less important than the fact of getting vaccinated, but these represent potentially low-hanging fruit that in aggregate may have meaningful public health benefit. The public may also be more accepting of mucosally administered vaccines, and FDA's decision to allow caregiver and self-administration of flu mist to me appears to be the right one. With regard to COVID-19, I feel compelled to note that the durability of antibodies elicited by current vaccines, including mRNA vaccines, is within the bounds of what is reasonable for any vaccination with stereotyped biphasic antibody titer kinetics. Long-lived plasma cells, however those be defined on flow cytometry, are valuable insofar as their antibody remains protective. The pace of antigenic drift by SARS-CoV-2 and conversion evolution of neutralizing epitopes towards evasion limits the utility of these antibodies and would necessitate boosting independent of antibody durability if the goal is substantial infection suppression. Improved localization of functional antibodies to the upper respiratory tract could also help. As it pertains to additional doses of COVID-19 vaccine, I am broadly supportive that the option be available. However, we have significant data gaps as it pertains to the appropriate interval for boosting with an additional dose of vaccine. In immunocompetent individuals, a lack of boost response when doses administered at fewer than 3 months from an infection, and RCT data from Covail showed 2-dose boosters 2 months apart also failed to boost antibody responses. Data generalizability to more vulnerable cohorts that such a policy principally target is unclear. Under a framework of shared decision-making, reasonable hypotheses can be made regarding how to optimize protection for individuals from COVID-19, given these current data gaps, but this does not justify the persistence of those gaps. They must be filled. I urge that language be present communicating knowns and unknowns for those seeking to take advantage of an additional COVID-19 vaccine. Lastly, I would like to express that immunocompromised individuals who have reached out to me have indicated that they would be generally supportive of an additional dose, but struggle to find vaccination circumstances that consider their vulnerabilities. Many are not comfortable getting vaccinated in a poorly ventilated pharmacy at peak business hours. Thank you so much.
Thank you, Mr. Sestaro. Thank you, Mr. Nierenberg. Our next speaker is Mr. Sestaro. Are you on?
Yes, can you hear me?
Yes, thank you. Go ahead.
Thank you for the opportunity. My name is Tim Sestaro. I'm the father of 4 boys. My first 3 kids were vaccinated with no issues. My last son was severely injured by the failure of his pediatricians to adhere to the CDC's safety regulations, protocols that you have in place, and guidance. So my point of talking today is to get to the bottom of why the ACIP is failing to get the necessary word down to pediatricians. My son was presenting with severe allergic reactions, and he was severely sick while vaccinated. I was deployed for this country while my wife took my son to get help for what he was suffering, and he had open wound allergic reactions all over his body. And for some reason, pediatricians think they can vaccinate over moderately ill and severely ill circumstances. That is a failure, and you are the overall responsible group for this. So why are pediatricians vaccinating moderately to severely ill kids? Fix that. 2, the CDC has listed on their website signs and symptoms of a primary immune deficiency. What are those signs and symptoms? The first ones that you have listed: frequent or repeated infections, ear infections, skin infections. My son had 6 skin infections, awful allergic reaction, immune system-driven skin infections that his pediatricians coined up to eczema. And that's fine, because when I questioned the pediatrician, she said, eczema is an allergic reaction, and we're vaccinating over eczema. Well, here the CDC is stating signs and symptoms of a primary immune deficiency. My son had 4 recurrent ear infections in a 6-month span leading up to the live rotavirus vaccine and the live MMRV. How are infants that are immune deficient, that's what my son was presenting with, that's what you are saying he was, and he is being given the live rotavirus vaccine and MMRV at the earliest possible time frame. I'm a police officer in New York. If I was given incentives to arrest people and give tickets, do you think I would give them instead of offering fair and impartial justice to those people? Yes. Finally, whoever created this right here should be fired. The working group that created this, the MMRV and the MMR, for the first dose, the CDC recommends the MMR and varicella vaccines be given separately in children 12 through 47 months old, unless the parent or caregiver expresses a preference for MMRV vaccine. Whoever created that should be fired. My son had the febrile seizures 7 to 10 days afterwards that are more likely to be given when given the MMRV instead of the MMR. So why is that left up to parents is a disgrace. The FDA should be put on notice. Why are they clearing 2 vaccines that both offer the same immunity, but one is more dangerous? The trials have already shown that one is more likely to cause febrile seizures, and my doctors did not care for my infant's health. They gave him the MMRV. They bypassed every safety recommendation and protocol and guidance you have in place, so you need to fix that.
Thank you for your comment.
That's from you guys.
Thank you for your comment. Your time is done. We appreciate your comment.
Thank you so much. I'm passionate about this because my son has brain damage now, and it could have been prevented. 100% preventable if you guys are doing your job.
I'm so sorry for what happened to your son.
Thank you. I know we can work to fix this.
Our next speaker is Mr. Besanov. Are you on, please?
Yes, I'm on. Can you hear me?
Yes, we can. You may make your comment.
My name is Daniel Basanov, and I am a member of the public. Thank you for this opportunity to comment. I strongly urge the CDC to recommend COVID-19 vaccines for people of all ages and health issues at least twice a year, including full access to spring vaccine for everyone. This is crucial as we continue to live with COVID, a virus that persists year-round and frequently surges during both summer and winter. Vaccination schedules must reflect this reality, and everyone should have access to updated vaccines that are adjusted for the latest variants. We need at least 2 vaccines per year for all, not just the most vulnerable. Vaccine immunity wanes significantly within 4 to 6 months, leaving people at risk of infection and complications. Restricting vaccine access based on age or health status leaves large populations of the population unprotected, which in turn increases the chances of transmission and reinforces infection for everyone. The emergence of new variants also means that regular updates to the vaccines are necessary to maintain efficacy and help prevent severe illness. Because I'm not classified as high risk, I have experienced barriers in getting vaccinated, where vaccine providers questioned my eligibility, causing me to miss the opportunity to receive the additional protection. This confusion, paired with restricted access, puts people like me and many others at higher risk, particularly as COVID continues to spread. The current low vaccination rates are alarming. As of October 2024, only 1 in 9 adults and 1 in 4 of those 65 and older have received the updated 2024-2025 COVID vaccine. Compare this to influenza vaccination rates, which are almost double that. COVID isn't a seasonal illness like the flu. It's with us year-round. This underscores the need for continuous, widespread vaccination efforts. Moreover, relying on infection-induced immunity is a dangerous strategy. Multiple infections increase the risk of long COVID, which affects millions and can lead to severe long-term health issues. Vaccination reduces the risk of long COVID and other complications. Therefore, frequent vaccinations with updated vaccines is essential to protecting public health. A restrictive vaccine eligibility approach also creates confusion and discourages people from getting needed boosters. The CDC must take clear, unequivocal recommendations for all ages to receive vaccines every 6 months. This will not only influence healthcare providers and insurance coverage, but also improve public understanding of the importance of staying up to date on COVID vaccination. Thank you.
Thank you for your comment. Our final public comment speaker is Mr. Greenblatt.
Hello, everyone. Can you hear me?
Yes, we can. Please proceed.
Hello, committee members. Thank you for allowing me to speak today. The Global Healthy Living Foundation supports widespread access and widespread vaccine access and public trust in their safety and effectiveness. However, we have concerns about certain RSV and PCV vaccine guidelines proposed by the committee and hope to see revisions before finalization. GHLF is a 501c3 patient group advocating for those with chronic disease, especially the most vulnerable who are least able to advocate for themselves. Vaccine access is crucial for their daily lives. The clinical risk criteria for RSV vaccines put forward by ACIP in patients aged 60 to 74 pose significant challenges for implementation, particularly in community settings. Conditions like end-stage renal disease, severe obesity, neurologic and neuromuscular conditions, and other immunocompromised groups require thorough evaluation, but necessary medical records may not be readily accessible in community settings, which can cause life-altering delays to care. ACIP's current guidance suggests that patient attestation is sufficient evidence enough for a risk factor, but this places healthcare professionals in a difficult position. Pharmacists and non-primary care providers should not be required to disregard their clinical judgment based on available evidence. ACIP should acknowledge that healthcare providers may face limitations and ensure that they can make informed decisions without compromising patient safety. Furthermore, community pharmacies are one of the most easily accessible healthcare points in the U.S., especially for seniors in low-income areas where ethnic and racial minorities are overrepresented. Pharmacists should be empowered to make sound clinical decisions, and ACIP should reassess the risk criteria to ensure pharmacists can apply them accurately and confidently. One solution is for ACIP to align its recommendations with FDA-labeled indications. Healthcare professionals are accustomed to adhering to FDA-approved guidelines, which offer clear, actionable guidance. By aligning criteria with FDA guidelines, ACIP can more effectively assist healthcare professionals in effectively and safely delivering vaccines. Regarding the PCV vaccine, pneumococcal vaccination rates in the U.S. are alarmingly low. We urge ACIP to make routine recommendations for the pneumococcal vaccine for all adults aged 50 and older, aligning with FDA indicated labels. To further improve immunization rates, ACIP should include all FDA-approved pneumococcal vaccines as part of their routine guidance. Thank you for the opportunity to comment on these regulatory changes. We ask that you also read our full submitted comment letter, which expands on many of the points made today. We hope ACIP will implement the recommended changes to safeguard patient access. Thank you very much.
Thank you very much for your comment. That concludes the public comment session. Thank you to all of our public comment speakers, and I also want to thank those who took the time to submit written public comments via the CDC docket as well. With that, can we get the vote language up? And now I will turn things over to Dr. Talbot.
What do you mean I go the first one? Tell them to go the first one. Oh, can you go to the first one? Oh, yes, so sorry. If all the voting members would make sure that their computers are muted and turn on their camera so that...
No, we're not having people who use their camera.
Oh, we not.
Just the people on Zoom.
Just the two on Zoom. Sorry, y'all.
But we will...
Perfect. ACIP recommends a pneumococcal conjugate vaccine for
I'm sorry,
all...
I'm unable to turn on my camera. It's George Michel here.
That's fine, but thank you for letting us know.
Okay, okay.
ACIP recommends a pneumococcal conjugate vaccine for all PCV-naive adults aged greater than equal to 50 years. And we'll start off with Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Dr. Brewer, yeah.
Noel Brewer, no conflicts, yes.
Dr. Maldonado.
Bonnie Maldonado, no conflicts, yes.
Minnie Gamboge, no conflicts, yes.
Sybil Sinaez, no conflicts, yes.
Edwin Asturias, no conflicts, yes.
Rob Schechter, no conflicts, yes.
Denise Jameson, no conflicts, yes.
Helen Chu, no conflicts, yes.
Jamie Lair, no conflicts, no.
Charlotte Moser, no conflicts, yes.
Albert Shaw, no conflicts, yes.
And then for our online members, Dr. Chen.
Lin Chen, no conflicts, yes.
And then Dr. Kushal.
Dr. Kushal, no conflicts, yes.
All right. And then this is Kip. Yes, I gotta. I'm Kip Talbot, and I have no conflicts, and I vote yes. So I have 14 yeses and 1 no. And the motion passes.
So the motion passes.
Okay, thank you. Can we have the second slide? Oh, no, the second pneumococcal slide.
That's it.
Was that it? We didn't have to vote 3 different times?
No, that was COVID.
Oh, so sorry. No, I thought it was pneumococcal. Anyway, let's go to flu. It was COVID. All right. I was so excited about the pneumococcus, I couldn't help myself. Okay. I've been waiting for it to go down to 50 for a long time. All right, this is the influenza vote. Approve the vaccines for children's resolution for vaccines to prevent influenza. This time I'm actually going to go in alphabetical order. Dr. Asturias.
Edwin Asturias, no conflicts, yes.
Dr. Brewer.
Noel Brewer, no conflicts, yes.
Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Dr. Chen.
Lin Chen, no conflicts, yes.
Dr. Chu.
Helen Chu, no conflicts, yes.
Dr. Sinaez.
Dr. Sybil Sinaez, no conflicts, yes.
Dr. Jameson.
Denise Jameson, no conflicts, yes.
Dr. Kaposh.
Minnie Gamboge, no conflicts, yes.
Dr. Kushal.
George Kushal, no conflicts, yes.
Dr. Lair.
Jamie Lair, no conflicts, yes.
Dr. Maldonado.
Bonnie Maldonado, no conflicts, yes.
Dr. Moser, Miss Moser.
Charlotte Moser, no conflicts, yes.
Dr. Schechter.
Rob Schechter, no conflicts, yes.
Dr. Shaw.
Al Shaw, no conflicts, yes.
And I'm Kip Talbot, no conflicts, yes. 15-0. Motion passes. All right, now we can move to COVID and its many votes. Okay, where's COVID? Next slide. In addition to previously recommended 2024 to 2025 vaccination, ACIP recommends a second dose of the 2024-2025 COVID-19 vaccine for adults ages 65 years and older. Dr. Asturias.
Edwin Asturias, no conflicts, yes.
Dr. Brewer.
Noel Brewer, no conflicts, yes.
Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Dr. Chen.
Lin Chen, no conflicts, yes.
Dr. Chu.
Helen Chu, no conflicts, yes.
Dr. Sinaez.
Sybil Sinaez, no conflicts, yes.
Dr. Jameson.
Denise Jameson, no conflicts, yes.
Dr. Kaposh.
Minnie Gamboge, no conflicts, yes.
Dr. Kushal.
George Kushal, no conflicts, yes.
Dr. Lair.
Jamie Lair, no conflicts, yes.
Dr. Maldonado.
Bonnie Maldonado, no conflicts, yes.
Ms. Moser.
Charlotte Moser, no conflicts, yes.
Dr. Schechter.
Rob Schechter, no conflicts, yes.
Dr. Shaw.
Al Shaw, no conflicts, yes.
And then I'm Kip Talbot, and I have no conflicts, yes. It's 15 yeses and 0 no's, so the motion passes. Can you put up the next slide, please? Thank you. All right, COVID-19 vote 2. In addition to previously recommended 2024-2025 vaccination, ACIP recommends a second dose of the 2024-2025 COVID-19 vaccine for people ages 6 months to 64 years of age who are moderately or severely immunocompromised. And just to confuse everyone, I'm going to go backwards. Dr. Shaw?
Al Shaw, no conflicts, yes.
Dr. Schechter?
Rob Schechter, no conflicts, yes.
Ms. Moser?
Charlotte Moser, no conflicts, no, yes, sorry.
It's okay. Dr. Maldonado?
Bonnie Maldonado, no conflicts, yes.
Dr. Lair?
Jamie Lair, no conflicts, yes.
Dr. Kushel?
George Kushel, no conflicts, yes.
Dr. Kamboj?
Minnie Cambodge, no conflicts, yes.
Dr. Jameson?
Denise Jameson, no conflicts, yes.
Dr. Sineas?
Sybil Sineas, no conflicts, yes.
Dr. Chu?
Helen Chu, no conflicts, yes.
Dr. Chen?
Lin Chan, no conflicts, yes.
Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Dr. Brewer?
Noel Brewer, no conflicts, yes.
Dr. Asturias?
Edwin Asturias, no conflicts, yes.
And then I am Kip Talbot, and I have no conflicts, and I vote yes. Once again, that's 15 yeses and 0 noes, so the motion passes. Okay. Vote 3, if you could put that up, please. All righty. Dr. Asturias, oh, sorry, I got to read it. In addition to previously recommended 2024-2025 vaccination, ACIP recommends additional doses, that is 3 or more doses of 2024-2025 COVID-19 vaccine for people ages 6 months and older who are moderately or severely immunocompromised under shared clinical decision-making. Dr. Asturias.
Edwin Asturias, no conflicts, yes.
Dr. Brewer.
Noel Brewer, no conflicts, yes.
Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Dr. Chen.
Lin Chan, no conflicts, yes.
Dr. Chu.
Helen Chu, no conflicts, yes.
Dr. Sineas.
Sybil Sineas, no conflicts, yes.
Dr. Jameson.
Denise Jameson, no conflicts, yes.
Dr. Kamboj.
Minnie Cambodge, no conflicts, yes.
Dr. Kushel.
George Kushel, no conflicts, yes.
Dr. Lair.
Jamie Lair, no conflicts, yes.
Dr. Maldonado.
Bonnie Maldonado, no conflicts, yes.
Ms. Moser.
Charlotte Moser, no conflicts, yes.
Dr. Schechter.
Rob Schechter, no conflicts, yes.
Dr. Shaw.
Al Shaw, no conflicts, yes.
And I'm Dr. Talbot, no conflicts, yes. That's 15 yeses and 0 noes, and the motion passes. Okay, you're on, because I'm done.
Okay, Dr. Talbot has asked me to resume. So that concludes the votes. Thank you all very much. And we can now proceed with our final session of the day for a report from the maternal pediatrics, or from the RSV maternal pediatrics work group. Can we get those slides up, please? And I will turn, and I'll ask Dr. Chu to open up the session. Thank you.
Thank you, Dr. Wharton. So my name is Helen Chu. I'm the new chair of the Maternal Pediatric RSV Work Group. And I would first like to acknowledge the service of Dr. Sarah Long, who was prior chair. So as of last year, we now have 2 products to prevent severe RSV in children. For infants, there is now a maternal vaccine, Pfizer, as well as nirsevimab, which is a monoclonal antibody that is administered at birth. The maternal vaccine is administered to pregnant persons between 32 to 36 weeks gestation to protect the infant through transplacental antibody transfer. And nirsevimab is administered at birth to all infants under 8 months of age. as well as a second season dose for children 8 to 19 months who are at increased risk of severe RSV disease. So either the maternal RSV vaccine or nirsevimab is given to protect infants against severe RSV disease, and only one is needed in most instances. Next slide. So nirsevimab and maternal vaccine have different administration windows to time with the RSV season in order to provide optimal protection to the infant. Maternal RSV vaccine is given between the months of September and January in most of the continental United States, whereas infant RSV immunization with nirsevimab is administered October through March, ideally during the birth hospitalization. Next slide. So today we will cover the safety and efficacy of clesrovimab with a presentation from our colleague Dr. Sinha, Merck, maternal RSV vaccine safety from Dr. De Silva at Health Partners Institute, and then finally work group considerations from Ms. Danielle Mulia at CDC. So I would like to acknowledge the ACIP members, including Dr. Brooks and Dr. Jameson, as well as the liaisons and the ex officio members and consultants, and the grade ETR consultants who have worked on these recommendations, as well as the many work group members at CDC, including Dr. Jefferson Jones, and our new co-lead, Ms. Danielle Mulia. Thank you.
So our next presentation is on clesrovimab. Dr. Sinha, are you on? We're early. I know. Shows up here. Is the Merck speaker on, please?
Try again, I'm sure. Can you hear me?
Yes, but there's an echo.
My apologies. Give us one moment while we fix our audio issue here.
Okay, well, it sounds better now. I think you may have it.
How are we going to hear that? How about now? Do you still hear the echo?
No, that's better. You can proceed.
I need to redial into the room. It's not. I don't know why they didn't hear us. Can you go to? Can you pull up the?
Dr. Chu, thank you for your patience while we sort this issue out. What do I mean?
Pull up the meeting info again. I'm going to dial back into the room.
So are you going to, is the speaker planning on screen sharing?
Six, 2, 8, 7, 6, 6. No.
Welcome to Zoom for Government. Enter your meeting ID followed by pound.
Hello, can you hear me?
We can hear you. Your slides.
Enter your participant ID followed by pound. Otherwise, just.
We can. Thank you. Okay, now the slides are displaying correctly. Go ahead.
Welcome to Zoom for Government. enter your participant ID, please enter the meeting passcode, followed by pound.
Speaker needs mode.
You are in the meeting now. There are more than 70 participants in the meeting.
Dr. Chu, it's Anna
You have been
Sinha.
added. You are muted. You can mute or unmute.
Can the speaker go ahead with the presentation, please?
Dr. Chu, can you hear me? It's Anna Sinha.
Dr. Sinha, we can hear you. Can you hear us?
Great. Yes, my apologies for that difficulty. I'll go ahead and get started.
Great. Thank you so much.
Yep. Good afternoon. I'm Anna Sinha, the lead clinical director and product development team lead for clesrovimab. And after that technical snafu, it's my pleasure to present our clinical development program to you today. I'm joined by a few colleagues who can help us with questions after the presentation. So to begin, this slide highlights a few of clesrovimab's important characteristics. The figure to the left shows the crystal structure of RSV F protein, with clesrovimab bound to 2 of its 3 sites on the trimeric F protein. Clesrovimab binds with high affinity to F protein site 4. Its binding epitope is highly conserved, which is to say it has a very low rate of mutations detected within its binding site sequences. Next, clesrovimab has high potency in vitro against a range of RSV clinical isolates and is equipotent against RSV A and B. Third, it has 3 engineered substitutions termed YTE that result in an extended half-life. And finally, clesrovimab has a high nasal PK with a high proportion of serum to nasal tissue partitioning. This leads us to clesrovimab's proposed initial indication, dosing, and administration, as you see summarized. Its proposed indication is for the prevention of RSV lower respiratory tract disease in neonatal infants who are born during or entering their first RSV season, with a dose of 105 milligrams administered as a single IM injection with the same dose for all infants regardless of weight. In a snapshot here, we see the clinical development program supporting clesrovimab. Note the high-level objective for each phase of development below the timeline. And on the right of the slide, in green above the timeline, are the 2 pivotal late-phase studies supporting clesrovimab, and they'll be the focus of the rest of this presentation. We'll start with Protocol 4, clesrovimab's phase 2b/3 study in healthy infants, and you can see its full title here. Beginning with the study's design. Protocol 4 is clesrovimab's phase 2b/3 double-blinded, randomized, placebo-controlled study in healthy preterm and full-term infants. Infants entering their first RSV season were randomized 2-to-1 to receive either clesrovimab 105 milligrams IM or placebo, and all were followed for at least 365 days. The first 300 enrolled comprised the phase 2b cohort, followed by an interim analysis for safety, and then the continuous, seamless enrollment of the study's phase 3 cohort. Of note, the first 1,650 enrolled were planned for follow-up through day 515, that is to say, through a second RSV season. The primary endpoints for this study were safety and tolerability of clesrovimab compared to placebo, as well as the efficacy of clesrovimab against RSV-associated medically attended lower respiratory infection, I'm going to call that MALRI, requiring at least 1 indicator of LRI or severity through 5 months. And this was hypothesis tested. Its secondary endpoints were efficacy against RSV-associated hospitalization through 5 months, also hypothesis tested, and efficacy against RSV-associated MALRI, requiring at least 1 indicator of LRI or severity through 6 months. These efficacy endpoints were complemented by a comprehensive set of additional endpoints, and I'll review those in a moment. This study is now complete. So turning from design to results, you'll note that the baseline characteristics were similar in both clesrovimab and placebo groups. A total of 3,614 healthy infants were randomized and dosed, of whom 2,411 received clesrovimab, with the balance receiving placebo. The study had sites in 22 countries across 5 continents, and thus enrolled a diverse population. 631 were in the early and moderate preterm group, with the remainder of the characteristics as you see summarized on the slides table. Moving to efficacy results, we see that a single dose of clesrovimab protects healthy preterm and full-term infants against mild, moderate, and severe RSV disease through 5 months. We studied a range of endpoints in order to capture the full efficacy profile and saw that efficacy increases as severity of endpoint increases, ranging from 52% against acute respiratory infection, that's comprised of both upper and lower respiratory infection, up to 91.7% against severe MALRI. Note that the statistical criteria for success were met for both of the hypotheses tested, for the primary efficacy endpoint of RSV-associated MALRI requiring at least one indicator of LRIs or severity, and for the secondary endpoint of RSV-associated hospitalization. So let's turn next to the results when we consider efficacy through 6 months. And you see those results summarized here. We see that efficacy was durable across all endpoints through 6 months, with very similar efficacy results to the set of results just reviewed. Moving from the RSV-associated efficacy endpoints to the all-cause endpoints, we see in this table that the point estimates for efficacy against all-cause MALRI requiring at least one indicator of LRI or severity and all-cause LRI hospitalization were 13.1% and 49% respectively, with the confidence intervals you see on the table. Next, turning to safety. Those results are summarized in the table to the left of the slide. And what you'll note is that the safety profile of clesrovimab is generally comparable to that of placebo. The proportion of participants with adverse events, including all adverse events, drug-related adverse events, any SAEs, drug-related SAEs, were generally comparable between intervention groups, and the majority were grade 1 or 2 in terms of toxicity grading. Solicited adverse events, both injection site and systemic, were collected days 1 to 5. They're summarized in the middle rows of the table and were comparable between clesrovimab and placebo groups. With regards to adverse events of special interest, or AESI, the proportion of participants with hypersensitivity anaphylaxis or rash AESI were low in either intervention group. Specifically for anaphylaxis hypersensitivity AESIs, there was one non-serious grade 2 event of bronchospasm that occurred in the clesrovimab group on day 3 post-dose and was not considered related to study intervention. No deaths were considered related to study intervention and no patterns identified in terms of cause of death or timing. This brings us to the conclusions for Protocol 4. With regards to efficacy, clesrovimab, administered as a single dose for infants of all weights, provided robust protection against mild, moderate, and severe RSV disease for healthy infants, including term and preterm. The clinical data demonstrated over 90% efficacy in preventing RSV LRI hospitalizations through 6 months. Clesrovimab efficacy was durable across all efficacy endpoints through 6 months. And I didn't have the opportunity to show you this data, but there was no shifting of RSV disease burden seen in the second RSV season. Turning to safety, clesrovimab is well tolerated in healthy preterm and full-term infants with safety profile that is generally comparable to that of placebo. That brings us to Protocol 7. Protocol 7 is clesrovimab's phase 3 study in infants who are at increased risk for severe RSV disease and are palivizumab eligible. You see the full title on the slide. Starting with study design. This is a phase 3, partially blinded, randomized palivizumab controlled study in infants at increased risk for severe RSV disease, including those with chronic lung disease of prematurity, premature gestational age less than or equal to 35 weeks, and/or congenital heart disease. In season 1, infants were enrolled to receive either clesrovimab, 105 milligrams IM, or palivizumab. Palivizumab eligibility was determined by local and national guidelines for palivizumab use. Those infants enrolled into the clesrovimab group received a placebo injection at day 28, while those infants enrolled into the palivizumab group received a total of 3 to 5 monthly palivizumab doses as determined by local RSV seasonality and guidelines for use. All infants were unblinded at day 60. At the time of enrollment, those infants who had qualified for a second season of RSV prophylaxis were identified, with all infants planned to receive clesrovimab 210 milligrams open label in that second season, regardless of which group they were enrolled in the first season. Focusing on season 1, the primary endpoints were the safety and tolerability of clesrovimab. Its secondary endpoints in season 1 were efficacy of clesrovimab against RSV-associated MALRI and RSV-associated hospitalization, both through 5 months, and a description of PK. An interim analysis from this study is supporting regulatory filings, and this study is ongoing. Turning from design to results, a total of 896 infants were dosed at the time of interim analysis, of whom 446 received clesrovimab. The study had sites in 27 countries across 6 continents and enrolled a diverse population. Summarized at the top of the table, you can see the underlying condition by group. And in total, 401, or 44.8%, met the AAP palivizumab eligibility criteria. So, keeping in mind that the primary endpoints for this study were safety and tolerability, let's start there. With regards to safety results for Protocol 7, you see those summarized in the table to the left. And what we note is that the safety profile for clesrovimab is generally comparable to that of palivizumab. The proportion of participants with AEs, including any AEs, drug-related AEs, any SAEs, and drug-related SAEs, were generally comparable between intervention groups, and the majority grade 1 or 2 in terms of toxicity grading. Solicited AEs, both injection site and systemic, were collected days 1 to 5 after each dose. The cumulative results are summarized in the middle rows of the table and were comparable between clesrovimab and palivizumab groups. No anaphylaxis hypersensitivity AESI were reported, and the proportion of participants with rash AESI were low in either intervention group. All were non-serious and grade 1. In the study, 8 SAEs resulting in deaths were observed in the clesrovimab group and 4 in the palivizumab group. No deaths were considered related to study intervention by investigator, no pattern identified with respect to cause of death or timing, and they were largely attributable to the underlying comorbidities that made the infant eligible for enrollment in Protocol 7. Turning to the secondary endpoints of RSV-associated MALRI and RSV-associated hospitalization through 5 months in season 1, you see those results summarized here in the table's incidence rates, and they demonstrate general comparability in the clesrovimab group compared to the palivizumab group. Let's turn next to the secondary endpoints concerning PK. As you can see from the box and whiskers plot to the left, summarizing the estimated areas under the curve from days 0 to 150 in season 1, PK exposures in infants with increased risk for severe RSV disease are similar to those found in healthy infants, and this supports the extrapolation of efficacy to the infant population with preterm birth, chronic lung disease, or CHD enrolled in Protocol 7 without requiring dose adjustment. That brings us to the conclusions for Protocol 7. First, with regards to safety. The safety profile of clesrovimab in infants at increased risk for severe RSV disease is generally comparable to that of palivizumab and consistent with the safety profile observed in healthy infants. Next, with regards to efficacy in Protocol 7's population was inferred by the efficacy established from Protocol 4 based on the comparable clesrovimab PK data. In infants at increased risk for severe RSV disease, a single dose of clesrovimab protects against RSV disease, including RSV hospitalization, through 6 months. And that brings me to the summary for my presentation. With regards to the studies we've reviewed and clesrovimab's clinical development program, in terms of efficacy, clesrovimab administered as a single dose for infants of any weight provides robust protection against mild, moderate, and severe RSV disease for infants, including those who are term, preterm, and with risk factors. In healthy infants, clesrovimab is highly efficacious against a broad spectrum of RSV disease endpoints, with no shifting of disease burden into the second RSV season. There's over 90% efficacy observed in preventing RSV LOI hospitalization through 6 months. Clesrovimab also protects infants at increased risk for severe RSV disease comparable to palivizumab. The dose is the same for infants of all weights. Efficacy is sustained through 6 months, providing durable efficacy for an entire typical RSV season. Next, with regards to safety, clesrovimab is well tolerated in infants with a safety profile generally comparable to that of controlled and consistent across infant populations. Clesrovimab is well tolerated in healthy preterm and full-term infants who are enduring or entering their first RSV season with a safety profile that is generally comparable to that of placebo. And the safety profile of clesrovimab in infants at increased risk for severe RSV disease is generally comparable to palivizumab and consistent with that in healthy infants. With that, thank you for the opportunity to present today and your patience with our AV difficulties at the start of the presentation.
Thank you very much. We've got a few minutes for questions from the committee. Dr. Jamieson.
So since you summarized that this was robust protection at any weight and the dose is the same for infants at all weights, would you be able to stratify efficacy by infant weight?
Yeah, thanks for the question. So we've conducted subgroup analyses, including a subgroup analysis stratified by weight. And what we observed there is that the stratified efficacy results are generally comparable and consistent with the overall efficacy results. And we're happy to share that with the work group.
It would be great to be able to see that data, those data.
Right. So we're happy to bring that to ACIP as a whole. And we have that data available. Yeah, and I believe it's been provided to the work group. Yeah. Dr. Jamieson, is that helpful?
Yeah, thanks. It would be nice for us to be able to see those data.
I don't think I have it in my slide deck for this meeting. So please let me make sure that it's in the materials provided to the work group and bring it back to ACIP. Thank you.
Thank you. Appreciate it.
Thank you. Dr. Brooks.
Yes, the same for race and ethnicity. Exactly what I was going to ask.
Dr. Brooks, could you say that again? I missed your audio.
Oh, yeah, sorry. The same for race and ethnicity, stratification of VE.
Correct. So we have stratified analyses by race, ethnicity, weight, preterm, full term, and a number of other subgroup analyses, and we're very happy to share that with both the work group and ACIP as a whole. Thank you, Dr. Brooks. We'll be sure to get that.
Thank you. Dr. Brewer?
I just want to make sure I understand the data here. So on slide, you have efficacy data on slides 8 and 9. And on slide 8, your primary outcome is Mallory, requiring one or more indicator of LRI severity. But on the next slide, that's labeled a secondary outcome. I appreciate it's a different time point. I just want to make sure I'm understanding this.
That's right. You summarized it absolutely correctly. Our primary efficacy endpoint was RSV MALRI, requiring at least one indicator of LRI severity, days 0 to 150 after dosing. That is to say, through 5 months. And that's what you see on this slide here. One of our secondary endpoints, next slide please, was the same efficacy endpoint, but now days 0 to 180 post-dose. That is to say, through 6 months. That is one of our two secondary endpoints. Does that provide the clarification needed?
Yeah, good. Now, so I'm following now. Thank you so much. And there's another thing that also changes labels. So I was just trying to understand. Okay, that's helpful. But my next question is, can you help me understand why like the LRI hospitalization data look pretty similar and look pretty good, but there's a big drop off when when moving to the all-cause data on slide 10. So there's a big fall off for your primary outcome for all cause, but for hospitalization there's not. Do you have any sense of why that might be?
So here, you're right. LRI hospitalization due to any cause is 49%, right? And that reflects the severity of that endpoint. And it reflects the fact that we're encompassing not just RSV that was determined by our pre-specified RSV LRI endpoint, but LRI hospitalization due to any cause. Similarly, when we look at the first row of this table, MALRI due to any cause, that is a very broad endpoint encompassing a lot of disease that's seen both in clinics as well as the hospital. I think what we're seeing in the efficacy estimate for that endpoint is really the broadness of how that endpoint is defined. It encompasses a lot of disease seen both in the clinic and the hospital, and I think that's reflected in that 13.1% efficacy. That's how I interpret that data.
That makes sense. Thank you.
Dr. Brooks, did you have another question? No. Dr. Chu.
Thank you for that nice presentation. I just had a question as a follow-up to Dr. Jameson's. I think I would like to see the efficacy stratified by gestational age as well as by weight, but I was also hoping to see the PK data, especially out to 6 months, and whether or not you see faster or slower fall off with differential gestational age or birth weight. Thank you.
Yeah, Dr. Chu, I want to make sure I understand your request clearly. So in addition to the stratified efficacy that we've provided to the work group, you'd also like to receive stratified PK data. Did I get that right?
That's correct. Thank you.
Okay. And I'm turning to my colleagues at the table. We can provide that.
And there was no covariate on.
We can provide that data, correct? Yes, we'll get that to the work group. Thank you.
Dr. Schechter.
Hi, Rob Schechter. I had some related questions about durability of protection. I'm wondering if you have any indication related to the PK data or other data about expected durability of protection after the 5-month first season. And I guess I see that the primary and secondary event counts were small, but I'm wondering if they tended to occur later after infusion or shorter after infusion, or if it was pretty random. Maybe if there's the power to look at that, the duration of protection compared to timing of the injection.
Yeah. So here are a couple of points. One is I wanted to clarify that all of our efficacy endpoints were collected through 180 days, through 6 months. So we have that clinical efficacy data in hand. I also want to make another point with regards to our clinical efficacy data, and that's sort of the flip side of what I just said. Our clinical efficacy data goes through 180 days, and that's when our active surveillance period ended. So that is the duration for which we have efficacy data. That's an answer to your first point. With regards to our second point, here I think it would be very helpful to provide the case counts by time, the incidence curves, often termed Kaplan-Meier curves, to the work group, because the nature of that will allow you to see that our efficacy is durable through the entire 180 days for which we conducted active surveillance. Moreover, the distribution of those case counts over time enables you to appreciate that there was transmission going on for that entire 180-day period. Did I answer all of the points in your question?
I think so. I think a Kaplan-Meier curve or similar presentation would be helpful. And I'm wondering within this, and how it looked within the 6 months that during the active surveillance. I guess a related question would be if you have a correlate of protection from the antibody level at this point, or that would be, it's too soon to determine that in terms of monitoring titers over time.
Yeah. So for clesrovimab, there is no formal correlate of protection. Instead, we really need to rely on our clinical efficacy. And because we have that clinical efficacy out to 6 months, which is to say 180 days, again, I think that gives us a lot of clinical data and reassurance with regards to our duration of protection. But with regards to the specific question, which was with regards to a correlate of protection, there is no such formal correlate.
We do need to move on in a moment, but we've got two more questions. Dr. Chu? Okay. Dr. Brewer? Do you have another question?
Okay, very quickly, is this an exhaustive, I guess I'm surprised by the outcomes. Are there other outcomes we should know about that are not reported here? Are there any additional secondary outcomes not yet reported for the 5 or 6 month time period?
Do you mean in terms of efficacy estimates?
Thank you, yes.
Yeah, so the secondary endpoints are exactly as I've described. In terms of additional tertiary endpoints, I think we've been exhaustive in terms of our presentation.
So you reported all secondary and tertiary for these 2 time points?
Correct.
All right, thank you. And my second thing is actually something for the committee. We've asked for a lot of secondary, pardon, go ahead. For our committee here at ACIP, we've asked for a lot of secondary analyses, post hoc analyses, and I have a concern about the stability of the data across this kind of intensive probing. I think it's helpful to sharpen our intuitions, but one thing that is sometimes done is to focus on primary and second, maybe a primary outcome only, or perhaps primary and secondary. I'm a little concerned about the intensiveness of inspecting the data across this many outcomes, and I was wondering if we would consider softening our request somewhat to focus, for example, on primary and secondary outcomes.
Doc, was that a question to me?
No, it's actually a question to my colleagues here on ACIP.
I think it was a comment to the committee. No, yeah. Okay, so thank you very much for that presentation and that good discussion. And we'll now move on to the presentation from Dr. De Silva. Dr. De Silva, we can see your slides. Go ahead.
Can you hear me?
Yes, we can.
Wonderful. Good afternoon. Today I will be presenting preliminary data about the RSV pre-F vaccine and the outcomes of preterm birth and small for gestational age at birth from the Vaccine Safety Data Link. Next slide. Established in 1990, the Vaccine Safety Data Link, or VSD, is a collaborative project between CDC's Immunization Safety Office and 13 integrated healthcare organizations in the United States. The VSD monitors the safety of vaccines used in the United States primarily through observational, multi-site studies of rare and serious events following vaccination. The project includes data on approximately 15.5 million individuals across all sites annually, which represents approximately 3 to 4% of the US population. The VSD has an annual birth cohort of approximately 115,000 live births. Data is organized using a common data model with standardized coding systems. The map on the right shows currently participating VSD healthcare organizations. There are 13 VSD sites that provide clinical, methodological, and data expertise. 11 of the 13 sites provide data for the project. Sites that do not provide data are denoted with an asterisk. Next slide. The prenatal RSV vaccine was recommended for use by ACIP on September 22, 2023, for use between 32 through 36 weeks gestation, with seasonal administration from September through January. Most VSD sites did not start vaccinating until late October or November 2023. One VSD site did not administer the vaccine in their health system. 2 sites continued administrations through the end of February 2024. Next slide. We performed a matched analysis comparing pregnant persons exposed to RSV vaccine with pregnant persons unexposed at the same gestational week to evaluate preterm birth and small for gestational age, or SGA, at birth. Next slide. Preterm birth is defined as a live birth occurring prior to 37 weeks gestation. The RSV pre-F clinical trial identified an imbalance in preterm births in the vaccinated group compared to the placebo group. Most preterm births in the clinical trial were late preterm, occurring between 34 through less than 37 weeks gestation. Most occurred more than 30 days after vaccination, and the imbalance was most prominent in a single country. Of note, the GSK RSV prenatal vaccine clinical trial was halted due to an imbalance in preterm birth in the vaccinated group. Next slide. Small for gestational birth is defined as birth weight below the 10th percentile for gestational age and sex. SGA can be caused by the infant being constitutionally small, which is often related to parental genetics, or they can be small for gestational age due to intrauterine growth restriction, also called IUGR, which is a pathological process caused by placentation issues, resulting in the decreased placental blood flow, maternal conditions, or genetic or structural abnormalities. Early onset IUGR, which occurs prior to 32 weeks gestation, is usually more severe than late onset IUGR, with higher associated morbidity and mortality. While SGA was not evaluated in the clinical trial, there was an imbalance in low birth weight, defined as birth weight less than 2,500 grams, among the RSV pre-F vaccinated group compared with the placebo group. Next slide. For the matched analysis, we included pregnant persons 16 through 49 years of age with gestational age 30 through less than 37 weeks during September 22nd, 2023, and the end of the recommended time period for vaccination, which was either January 31st, 2024 for most sites, or for 2 sites, February 29th, 2024. We used a target trial emulation design to compare vaccinated and unvaccinated persons at each gestational week. Pregnant persons exposed to RSV pre-F vaccine were matched 1-to-1 on VSD site and propensity to be vaccinated to unvaccinated pregnant persons during the same gestational week. Unvaccinated matches were assigned an index date equal to the gestational day of vaccine for their vaccinated match. The matched pair was censored if the unvaccinated person was later vaccinated. Propensity to be vaccinated was calculated for the 2 sites individually and for all other sites combined. Variables included in the propensity to be vaccinated calculations were maternal age at pregnancy start, calendar week at pregnancy start, number of weeks with prenatal care encounters, race, ethnicity, comorbidities, including hypertension, diabetes, gestational hypertension, gestational diabetes, obesity, and substance use, history of preterm labor, poor fetal growth, supervision of high-risk pregnancy, enrollment, and VSD site. Next slide. For SGA, match sets were excluded if the infant weight was not available for either infant in the matched pair. A log binomial model with robust variance was used to estimate risk ratios with 95% confidence intervals. We provide the risk ratios overall for vaccines administered between 30 to less than 37 weeks, as well as restricted to vaccines administered during 32 through less than 37 weeks gestational age, which is the ACIP recommended age for vaccination. Next slide. This table shows age group and race and ethnicity characteristics of the matched cohort. There are 14,099 matched pairs included in the analysis. Of note, the matched cohort is not unique individuals, as some initially unvaccinated persons were ultimately vaccinated and were subsequently rematched as vaccinated. While the characteristics are similar between the two groups, RSV vaccinated persons tended to be older than their unvaccinated matches. The vaccinated group had a higher percentage of Asian patients and lower percentage of Black and Hispanic patients compared to their unvaccinated matches. Next slide. This slide shows preterm birth risk among RSV vaccinated pregnant persons or their unvaccinated matches, with vaccinations occurring between 30 through 36 weeks gestational age. The table shows the number of matched pairs, the number of events in the RSV vaccinated and unvaccinated, and the risk ratios. The rows include the overall number of matched pairs and the number of matched pairs limited to persons who received the vaccine between 32 through 36 weeks gestational age. The risk ratio for preterm birth comparing vaccinated to unvaccinated matches is 0.90, with a non-significant confidence interval. When restricting vaccines to 30 through 32 weeks gestation, the risk ratio is unchanged. Next slide. This figure is a smooth curve showing the average preterm birth risk by gestational age at vaccination or index date, represented by a solid line, with the 95% confidence band represented by the shaded area for both the RSV vaccinated group, which is shown in red, and the unvaccinated matched group, shown in blue. The x-axis shows the week of vaccination or index date for unvaccinated matches, and the y-axis shows the smooth preterm birth risk. The figure suggests that the risk of preterm birth is similar by gestational age for both vaccinated and unvaccinated groups. Next slide. This slide shows small for gestational age at birth risk among infants born to RSV vaccinated pregnant persons or their unvaccinated matches, with vaccinations occurring between 30 through 36 weeks gestational age. As a reminder, for this outcome, matched sets were excluded if the infant weight was not available for either infant in the matched pair. Because of this, the total number of matched pairs is smaller than what was included in the preterm birth analysis. The table shows the number of matched pairs, the number of events in the RSV vaccinated and unvaccinated groups, and the risk ratios. The rows include the overall number of matched pairs and the number of matched pairs limited to persons who received the vaccine between 32 through 36 weeks gestational age. The risk ratio for SGA at birth comparing vaccinated to unvaccinated matches is 1.02 with a non-significant confidence interval. When restricting vaccination to 32 through 36 weeks gestation, the risk ratio is 1.03, again with a non-significant confidence interval. Next slide. In conclusion, RSV vaccine is not associated with increased risk for preterm birth or SGA at birth. We are currently working on the analysis for acute safety outcomes, stillbirth, and the combined outcome of preeclampsia, eclampsia, and HELP. We need to complete chart reviews for stillbirth and some acute safety outcomes. For the combined outcome of preeclampsia, eclampsia, and HELP, there was an association with hypertensive disorders of pregnancies identified in a recent study as well as during the clinical trial. The onset of this outcome likely starts prior to 32 weeks and is only subsequently that it reaches the level of clinical detection with documentation of a diagnosis code in the medical record. Because of this, we have been discussing the best analysis plan to evaluate this outcome. Next slide. I would like to thank everyone who contributed to this project, and I'm happy to answer any questions you may have.
Thank you. We've got a few minutes for questions, if the committee has any for the speaker. Dr. Schechter.
Thank you for the presentation. Is the study limited to the single season, or are there plans for continued surveillance?
Well, we plan to continue the surveillance during this season as well, potentially going further than that, but this was just for the first season that I have shown the data.
Any other questions? Dr. Brewer.
Could you speak again to the slide on slide 11, where there appears to be a spread at 36 weeks? And how should we think about that? I didn't quite get the interpretation. I apologize.
So our interpretation is that it does depend on the time of vaccination when the max pairs were vaccinated, and that we do think there could be some residual confounding. We don't interpret this as a safety signal suggesting that vaccination at 36 weeks confers a lower risk. We just say that it's similar in both the vaccinated and unvaccinated groups. So we're thinking of it as showing a similar trend in both of the groups, and for the most part, that's a very similar preterm birth risk.
Dr. Joseph?
Hi, can you hear me?
Yes, we can. Thank you.
Thank you. My name is Naima Joseph. I'm a maternal fetal medicine specialist and a liaison with the American College of Obstetricians and Gynecologists. So thank you so much for presenting this data. And while it continues to reassure us that maternal immunization is a safe strategy for conferring infant protection against RSV, I think it does raise 2 points in that, as mentioned earlier, that overall maternal immunization was low, and that the data for licensure included patients who were included in the trial prior to 32 weeks, which is different from the trial dosing window. And so really can't address the immortal time bias, and so may underestimate or overestimate the risk associated with vaccines at lower gestational age. And so I was wondering if there was any thought of the work group looking at data from other surveillance systems, for example, United Kingdom, that might help inform the risk for preterm birth, given, as you've noted, implementation challenges, and as we see in your presentation, continued disparities in access that might be mitigated with reviewing the licensure approval window. Thank you.
I can comment on that. I don't believe that the UK has started maternal vaccination yet. Is that correct?
I believe the UK started in September, so there wouldn't yet be data on preterm birth, but we would be happy to look at those data at the time that they're available.
Dr. Asturias?
Yeah, thank you for that presentation. I didn't see in your slides, but can you clarify between the match sort of groups, the RSV versus not vaccinated, were there any exclusions or any conditions sort of similar between the groups or not?
Can you show slide 16, please? So this slide shows the standardized mean differences for variables that are included in the propensity score. We didn't include all of the variables in a table, but you can see that in the figure, the x-axis shows the standardized mean difference and the y-axis shows the covariates that are included. The blue circles are the standardized mean differences for the entire population before matching, and the red circles show the standardized mean differences after matching. This includes only the matched pairs. The unmatched pairs are excluded. So you can see there is very similar characteristics between the two groups, although there are still some imbalances in race and ethnicity, age. Some imbalances exist. For some of the comorbid conditions, such as hypertension, diabetes, obesity, those are very close to zero, so very well matched. And these are only the characteristics included in our propensity score matching. So if there were specific characteristics you were interested in or underlying comorbidities, then depending on, we might have some of that data.
Any additional questions? Okay, so the last talk in the session is from Ms. Mulia on work group considerations.
Thank you. Today I will be reviewing the maternal and pediatric RSV workgroup interpretations of the data presented today and next steps. Next slide. I will begin by reviewing workgroup interpretations on the safety and efficacy of clesrovimab. Next slide. The policy question being considered by the workgroup at this time is, should clesrovimab be recommended for all infants less than 8 months of age entering their first RSV season or born during the RSV season? If recommended, the policy for clesrovimab would be the same as the policy for nirsevimab for infants less than 8 months entering or born during their first RSV season. Next slide. The workgroup reviewed data on the safety and efficacy of clesrovimab from the manufacturer's phase 2b/3 placebo-controlled study in healthy preterm infants born at 29 to 35 weeks gestation and full-term infants born at 35 weeks gestation and later. The workgroup also reviewed a phase 3 palivizumab-controlled study in infants at increased risk for severe RSV disease. Next slide. The workgroup noted that the phase 2b/3 trial demonstrated high efficacy for prevention of severe RSV disease through 150 days post-dose. The efficacy against hospitalization for prevention of RSV-associated lower respiratory tract infection was 91% with a 95% confidence interval from 76% to 97%, and the efficacy against medically attended RSV-associated lower respiratory tract infection, which was the primary trial outcome, was 60% with a 95% confidence interval from 44% to 72%. Next slide. The workgroup noted that serious adverse events appeared balanced between the clesrovimab and placebo arms. However, rare adverse events are unlikely to be detected in a trial this small. Next slide. The workgroup felt the safety and efficacy data looked promising. However, they have requested additional pharmacokinetic, immunogenicity, efficacy, and safety data from the manufacturer. The workgroup also noted in their discussion that clesrovimab has a demonstrated shorter half-life than nirsevimab, 42 versus 70 days. However, the clinical efficacy against severe RSV appeared sustained at 150 and 180 days. Trial enrollment began in 2021, a period when typical RSV seasonality had been disrupted by the COVID-19 pandemic. And finally, the clesrovimab and nirsevimab trial outcomes had different definitions, and therefore comparing the results from the trials should be done with caution. Next slide. In future workgroup meetings, we plan to review additional data on the phase 2b/3 and phase 3 studies that have been requested by the workgroup. We will review the grade assessment of the evidence for this policy, cost-effectiveness analyses, and the evidence to recommendation framework, which include the domains of public health problem, benefits and harms, values, acceptability, feasibility, resource use, and equity. Next slide. During the February 2025 ACIP meeting, we plan on presenting a summary of grade, cost-effectiveness analyses, and the evidence to recommendation framework in preparation for a potential vote by ACIP, the timing of which depends on FDA licensure. Next slide. I will end by reviewing the workgroup interpretation of the first season data on maternal RSV vaccine safety. Next slide. As a reminder, in clinical trials, the Pfizer maternal RSV vaccine, Abrysvo, was administered at 24 through 36 weeks gestation, and more preterm births and hypertensive disorders of pregnancy were observed among pregnant people who received maternal vaccine compared to the placebo. However, differences were not statistically significant, and data were insufficient to establish or exclude a causal relationship. The FDA approved maternal RSV vaccine for use in pregnant persons at 32 through 36 weeks gestation to avoid the potential risk for preterm birth at less than 32 weeks gestation, which is associated with increased morbidity and mortality. ACIP judged the benefits of maternal vaccine administered at 32 through 36 weeks gestation to outweigh the potential risk for preterm birth and hypertensive disorders of pregnancy. Next slide. Preliminary findings from the first season of maternal RSV vaccine safety in a vaccine safety data link study found that maternal RSV vaccine administered during 32 through 36 weeks gestation was not associated with an increased risk of preterm birth or small for gestational age at birth. The risk ratio of preterm birth among persons who received maternal vaccine compared to those who did not was 0.9, with a 95% confidence interval from 0.8 to 1. And the risk ratio for small for gestational age at birth among persons who received a maternal vaccine compared to those who did not was 1.03, with a 95% confidence interval from 0.95 to 1.14. Both had tight confidence intervals that included 1, and the work group felt that these data were very reassuring. Next slide. The work group felt that at this point, messaging about potential risks for hypertensive disorders of pregnancy should be separated from preterm birth. There's little post-licensure data available regarding the risk of hypertensive disorders of pregnancy. One study has conducted a secondary analysis of roughly 3,000 pregnant individuals, 1,000 vaccinated and 2,000 unvaccinated, and found an association of maternal RSV vaccine and hypertensive disorders of pregnancy. Some work group members felt that when counseling pregnant people on maternal RSV vaccination at 32 through 36 weeks, messaging on potential risks of preterm birth could be softened, or counseling no longer needed to include discussion regarding a potential risk of preterm birth. CDC and FDA will continue to monitor safety for maternal vaccine, including conducting further VSDL analyses for hypertensive disorders of pregnancy. Next slide. Thank you, and I will now take any questions.
Are there questions for Ms. Mulia or the work group? Dr. Shah?
Yeah, thanks very much. I'm just kind of for my information, I'm just wondering if the rates of preterm birth or low for birth weight are, in this study, are kind of in a range that are expected from other studies?
Is Dr. De Silva still on the line? We can defer to VSD on that one.
Yes, I still am. Can you repeat the question, please?
I was wondering if the rates reported in the study of preterm birth that are low for gestational age are in the range that have been otherwise reported to be relatively expected statistically?
So many of the published reports and statistics for preterm birth include individuals throughout their pregnancies from 22 through the end of gestation or the end of pregnancy. We did do some previous work. Is it possible to pull up my slide 15? The VSD, because of this, we specifically wanted to look at the historical incidence of preterm birth among singleton pregnancies within the VSD. So we did look at the historical incidence, and the average preterm birth incidence from 32 through 36 weeks was 4.4%, with a range between 6.1% at 32 weeks to 3.1% preterm birth risk at 36 weeks. So the identified preterm birth rates in our population was expected, and I do think that SGA at birth is also within expected.
Thanks. If I recall, that signal from the trial was, is there any more information on the basis of it? My understanding was it would primarily occurred in the Southern Hemisphere and low and middle income countries, and it was just very mysterious at the time. Is there any more data at this point, about what happened?
I mean, there continues to be no clear reason for it. I mean, again, it wasn't statistically significant. Both GSK's published on their data. They couldn't find any clear kind of biologic reason. It was also during certain months of the year. And so both Pfizer and GSK's data kind of continues to be a bit of a mystery as far as for the signal, there doesn't seem to be a clear kind of biologic or other signal that they can determine.
Okay, thanks.
Dr. Schechter?
Yeah, I apologize. It's late in the day, but I wanted to just make a comment related to the work group, but unrelated to the presentations about nirsevimab implementation this season. So we go into RSV. I wanted to commend CDC for, in the clinical considerations and other documents, adding, I'm not going to get the language exactly right, but a preference for delivery of nirsevimab to newborns at the birth hospital setting. And I'm not sure how broadly that's been received or broadcast, and would encourage not only that broadcast, but other ways in which to encourage, as we're still hearing from a lot of birth hospitals who are reluctant to start implementing nirsevimab, one reason being the cost for their private pay patients of purchase in a birth hospital bundle that's not been adjusted for the cost of the product. So any means, including the possibility of committee recommendations around that language as well, to encourage speedy implementation of these valuable intervention. Thanks.
Thank you for that comment. So as you noted, our guidance is that for infants born shortly before or during the RSV season, they should be immunized within 1 week of birth, ideally during the birth hospitalization. We also know, and I'll defer to my colleagues in ISD in a moment, that in collaboration with AIM, the Association for Immunization Managers, CDC is holding a series of learning collaboratives on nirsevimab. The first call is on Friday, and the objective of the learning collaboratives is to provide birthing hospitals with an opportunity to learn promising practices from each other, get information from CDC, provide feedback on what is and isn't working well, and inform CDC on resources that they need to be successful, and we'll take the information learned during those back to the work group. So, and then I wanted to see if anybody from ISD is on and would like to comment.
Hi, this is Kevin Chatham-Stevens from ISD. Yeah, just to follow up on your comments, definitely agree with those. Just some additional information. I think, CDC has been working closely with the immunization programs to further enroll additional birthing hospitals into VFC, offering specialized technical assistance to these awardees. There have been site visits to some of the jurisdictions, as well as some focus group with some of the immunization programs and key informant interviews, really trying to drill down into some of the key issues and potential solutions to enroll additional birthing hospitals. I'll also note that in early August, CDC held a perinatal and maternal immunization reverse site visit, in which many of the immunization program managers from across the country came to CDC, and there was specific discussion regarding this issues as well. And there's also going to be a QI, quality improvement program in birthing hospitals as well. And so I think we're definitely trying to track this and do everything we can along with our jurisdictional partners to have as many birthing hospitals enrolled in VFC as possible. Thank you.
Ms. Hayes, do you have a comment?
Yes, I just wanted to say thank you. It's just, I love seeing data on vaccinating pregnant women that says it's safe. Thank you.
Thank you. So, Dr. Talbot, I believe the committee has completed its business for today. Shall we see if there's any objections to recess till tomorrow?
Be a good idea.
Okay. Do any committee members have any objections to recessing today's meeting?
Move to recess.
So we will recess, and the committee will reconvene tomorrow morning at 8 a.m. So thank you all very much.
Thank you.